We have amongst us a surgeon par excellence and a passionate academician, Professor Dr. Satish Jain, ENT, head and neck cancer and skull-base surgeon, Jain ENT Hospital, Jaipur, an eminent scholar with an illustrious career spanning over 2 decades. Dr. Satish has done pioneering work in the development of endoscopic and microscopic skull-base surgery, initiated cochlear implant program in Rajasthan, and has several other merits to his credit. Parading the achievements of this renowned academician is, of course, a biographer's delight. With all cordiality and respect, we welcome Dr. Satish Jain for his session on live surgery, basics to advanced. With that, I request you to give your undivided attention to Dr. Satish Jain. We welcome you, sir. The first surgery will be chaired by Dr. Sajid, AOI State Secretary and Senior ENT Surgeon Manjeri, and Dr. Saduddin Ahmed, Head of the Department, Kottayam Medical College. Thank you.
Hello. Hello.
Yes, sir.
Hello.
Yes, sir. We can hear you, sir.
Hello. Am I audible?
We can see you, sir. We can hear you.
Thank you. Good
Yes, sir,
morning,
thank
all. And first of all, I extend my thanks and gratitude to the organizing team for giving me this opportunity once again to share my thoughts and, learn more from this very high-end conference from the Kerala state. And as we all know, we know this dictum, well begun is half done. And that is what we see this morning with a fantastic, informative lecture from, video lecture from our friend, dear friend Manoj. It was really mind-blowing to see the fine details, fine crux of cochlear implant surgery, who himself is a master in this field. And we learned a lot from that. Thank you so much, Manoj. And once
Good morning, Satish ji. I am Shahid and Dr. Sadruddin is chairing the session.
Hi, boss.
Both.
Thank you, Dr. Sajid.
Thank you. We welcome you to this KENTCON. We love to be here in physical presentation, but I know that you have to travel to Hyderabad and also it is very difficult to arrange all this here. But you have got a fantastic setup. We know there. We can telecast anywhere from there. Thank you for inviting our, coming to KENTCON. Thank you very much.
Over to you, sir.
Thank you. Thank you, Dr. Sajid, once again for giving me this opportunity. And I welcome here Dr. Sharif, who is from Kerala State, to be here in our theater today with us as a member of Kerala State ENT Association. Really nice to see him here in the theater. So as I said, well begun is half done, and thanks to Manoj for this mind-blowing lecture. Today's session, we have, cases lined up as the organizing team, spoke to me. And I am indeed, so glad to meet those people wanting to deliver maximum possible to the delegates. So they discussed a couple of times to bring out variety of cases to incite more and more discussion. So we are beginning our day with the basics, with the case of nasal polyposis, and plan is a full house sinus surgery. So I'll take you first to the CT scan, which I call as a Google map for the, paranasal sinus anatomy. And that will definitely help us to, carry out the sinus surgery with utmost safety and preventing complications. After that, we'll have otology case, like we have a small acoustic neuroma. I didn't keep the large one. We had 3 cases of acoustic today. So the small one I've kept for demonstration. Then we'll have some other cases like inverted papilloma, especially frontal sinus inverted papilloma involving the orbit, some tympanoplasty, revision rhinosporosis, and some more revision FAS and other cases. So let's see how much we can go till 4 o'clock. So to begin with, are you getting any imaging picture?
Yeah, we can.
So this is the basic, CT scan of the patient. One thing I always mention, and I will reiterate again here, to order a CT scan in a digital format. Order a CT scan, some millimetric sections. A paranasal sinus CT scan we all require is a non-enhancing CT scan, because we are looking for the getting this for the inflammatory disease of the paranasal sinuses, where we don't need a contrast enhancement. So what we need to order is a fine some millimetric section like this. You can see in the corner here, it is 0.6 mm sections in axial plane. It is always shot in axial planes. And then you can reformat, reconstruct in your own software. This is DICOM, you can download from Google, and you get three-dimensional imaging, that too dynamic, to get maximum details of this paranasal sinus, labyrinth, you can say. This area is very, very important. Let me show you why this is important, why we are so concerned about. See, paranasal sinuses are all around surrounded by orbit and skull base. All the way, orbit and skull base are in close proximity. The threshold of safety for this surgery is very low if you are not oriented all the time. There are so many structures running in close proximity to the limits of the paranasal sinuses, like carotid artery, optic nerve, cavernous sinus, lot many cranial nerves, and so many things. You have to be ultra oriented to prevent complications. And the only thing which helps you is a three-dimensional CT scan. Unfortunately, many a time patients come to us with a printout of a scan. That to a coronal scan only, majority of the times. And why it happens? The reason is very simple. It all depends upon the surgeon how you order the CT scan. You write a CT scan PNS, that's it. What will radiologist do? Radiologist will do 5 mm section in less than 10 seconds with 10 or 20 slices in a printout to give you that this is your CT PNS. Now, how much informative it is, you know very well. So what kind of CT scan should be? See, this is 0.6 mm section. Every time I move with 0.6 mm. If I reconstruct to a coronal one, see this. This is 0.4 mm in reconstruction now. Now, every time I move with 0.4 mm. See this, every time 0.4 mm. So I don't miss any submillimetric anatomy. That is the basic reason. Now imagine, in the area of the paranasal sinuses, in one section, like in this, you have seen 116 slices. 116 axial, coronal, sagittal around 350 or something. Then in a bone window and soft tissue window differently will be double. And it is so impossible for a patient to carry on printouts, and equally impossible for the surgeon to look at all those slices. And that too, is not up to the mark. So what kind of CT scan we need is a dynamic one. Dynamic one you can run, and you can see each and every anatomy, so dynamic. Like, for example, let me show you why it is important. See, I am coming from anterior to posterior coronal section. What I see here is the frontal sinus. Then two cavities, looks like intersinus septum deviated to one side. Some opacity here. Now, as we go behind, we see another intersinus septal. Now, see, if you get in this printout, this is intersinus septal cell. We don't know which sinus this is opening into. We need to know, so that we can widen to see the intersinus cell, or we can communicate in surgical session. See this. This intersinus septal cell is communicating to the right sinus. See how easy it is for the dynamic CT to understand and give information to you. So number one is dynamic CT. Number two is three-dimensional. Three-dimensional dynamic CT is the only reason we go for CT scan like this. For example, see this. Any structure in coronal plane we know, we easily understand in coronal plane, because in the same plane we operate as well. So it is easier to relate the anatomy in coronal plane. Now, there are certain anatomy which is best, depicted, or more details are given in the axial plane. Some anatomy, the best details are depicted in, sagittal plane, like frontal sinus. Frontal sinus is best seen in sagittal plane. Now, see, this is intersinus septal cell. How it is related to the frontal sinus? How it is look like on the axial sagittal section? See this. This is your intersinus septal cell on coronal. Take your cursor there and see where is the intersinal septal cell and how it can interfere with the drainage pathway of the frontal sinus. So all you can see when you relate three-dimensionally. The point is, why I'm trying to say is, this should something we can make a habit or a practice to order a CT scan in digital format and then see dynamically so that you don't miss any single fine submillimetric anatomy, which is important to prevent complication, important to carry out a complete surgical procedure. Otherwise, not knowing this fact is always makes you in trouble, or makes you in doubt whether you are close to some critical structure or not, or either you're likely to do an incomplete job or you'll end up with some complications. So we have to be very to stay very close to the perfection. We need to have a complete information of CT scan in the dynamic format. Do you agree with me?
Yes, sir. Yes, sir.
So, like coronal section, I'm not going in details of the CT scan right now as the case is ready. But yes, I'll touch upon some important issues which we need to see on CT scan and some positive findings in this particular patient. Coming from the most anterior to the posterior. See, the first thing, the bony septum, the higher bony septum is little deviate to the left side. And you'll see in the rest of the, the right nasal cavity is more roomy as compared to the left, and this high deviation is something need to be corrected. Why I am showing on CT scan this high deviation? Because this is the time that you can have this thing in your mind and you can counsel your patient that will require an additional septoplasty as well. What happens sometimes intraoperatively, you decongest the node and you feel like there is hardly any room, hardly any problem in carrying out the sinus surgery, even on this left side after decongestion, and you can go ahead. Now passing your instrument through the narrow passage can actually cause trauma on both sides and can lead to synechia later on, which is something counterproductive for the sinus surgery, as entire sinus surgery success depends upon the ability to introduce post-operatively the topical irrigations. So in this, from the first picture, you can make up your mind and tell your patient then, advance that you'll need a septoplasty as well. And I can show you if you want how a limited septoplasty can, open up the space on the left side. So this is first thing, you need to see the nasal septum. Then coming from anterior to posterior, the first thing what you come across is the stigmatization in the frontal bone. There are two spaces with an unequal, size of the frontal sinuses. This is intersinus septum, which is rarely in the midline. And these are frontal sinuses. Why I'm saying frontal sinuses? This is two anterior anatomy. Two anterior are frontal sinuses. And why? Because there is floor intact and this floor is formed by beak. Let me take you what I'm saying to the three-dimensional. See this, where I am. This is frontal sinus and this floor is formed by beak. Can you see this?
Yes, sir. Yes, sir.
Hello?
Yes, sir. Yes, sir.
So beak is why I'm emphasizing on it. This beak is going to be our single most landmark to find the frontal sinus, to enter into the frontal sinus in the safest way. That is what I will corroborate intraoperatively as well. See, when you come with your endoscope from here, with a 70 degree suppose, the first thing you come across is the beak. And as you go behind the beak, see, as the beak ends, as you go behind the beak, what is this? The frontal drainage pathway. Can you see?
Yes, sir. Yes, sir.
The frontal outflow, the single most important anatomy you can, consider in your practice as the most reliable landmark is the beak. That is what I'm going to show you. In any of the most difficult frontal sinus situation, the beak is almost always there. In any number of revision surgeries done, beak is hardly disturbed. So it is always there as a landmark. And this is a God's given landmark which is never going to change. You follow the beak, follow the beak, follow the beak. Where the beak ends has to be the frontal drainage pathway, nothing else. So this is what I'm going to corroborate. Now see in the coronal section what I was seeing. As long as the beak is there, see this, as long as the beak is there, the above pneumatization is the frontal sinus. See the beak is still intact. That is intersinus septal cell. Beak is still intact. Now the beak is gone. And see what is this? This is frontal drainage pathway. Can you see very clear?
Yes, sir.
Now the frontal is gone. See this, until now it was frontal sinus. See now it is until this was frontal sinus. Now the floor has gone, the beak has gone. Until now you don't see the maxillary sinuses in view. So simple. And now as you go behind, as the frontal recess appears, the frontal drainage pathway appears, see the cribriform plate coming into picture. That is the ethmoidal roof. That is called anterior ethmoidal roof. The anterior part of the ethmoidal roof immediately behind the frontal sinus. And see at this level, the maxillary sinus starts appearing. So now we have gone posterior to the frontal sinus to the level that we should be able to see the maxillary sinus as well. Sometimes at this point, you see a lot of pneumatization going above the orbit behind the frontal sinus when the maxillary sinus in view, and that kind of pneumatization going above the orbit is a supraorbital cell, not the frontal sinus proper, as you see the cribriform plate in view. That is most important. Let me bring the coronal section again. See this. That was the frontal sinus. As the frontal gone, now the cribriform appearing. See the cribriform plate? Very
Yes, sir.
clear?
Yes, yes, sir. Very clear.
Very clear. See the cribriform plate forming the anterior part of the ethmoidal roof. It has two lamella, the horizontal and lateral, and see the entire anterior ethmoidal cavities completely opacified bilaterally. With no distinction of cells and landmarks, it is completely opacified bilaterally. And the structure, the most important structure which I am trying to show here is the middle turbinate on either side, which is attached to the junction of lateral and medial lamella of the cribriform plate. Very clearly. Can you see this?
Yes, sir.
Or
Yes.
do I show in other view? See now much better. See, the another beauty of this dynamicity is you can change the window setting to see the bony and soft tissue things prominent differently. Now see, this is the bone, that is the cribriform plate, that is the middle turbinate, which is attached on either side at the level of horizontal and lateral lamella. This is how. So that is anterior ethmoidal roof. Now again, I am going back to the frontal. This frontal ended. I am going behind. The anterior ethmoidal roof appeared. I am going behind in the anterior ethmoid now. Far behind in the anterior ethmoid now. And at this point, can you see some beaking of the orbit?
Yes, sir. Yes.
On either side, this is the medial rector, this is superior oblique, and the confluence of these muscles, you see this beaking of the orbit, and that is where the anterior ethmoidal artery leaves the orbit to enter this lateral lamella, which is considered to be the thinnest part of the skull base. So what I'm trying to say, I'm going back again to show you so that you don't, frighten yourself all the time with the anterior ethmoidal artery. See, I'm going back to where the level of the ethmoidal artery, where the anterior ethmoidal roof is ending now to become the posterior ethmoidal roof. Now I'm coming back. See this frontal sinus? Now going behind, the frontal sinus ended, anterior ethmoidal roof started. See the cribriform? Behind. So far, no anterior ethmoidal artery. So try to understand the anterior ethmoidal artery. See, coming behind. See where the anterior ethmoidal artery comes, where the anterior ethmoidal roof ends. Do you notice this thing? And now, as you cross the level of the artery, the flat posterior ethmoidal roof starts. Can you see?
Yes, sir. Yes.
So let me take this to the 3-dimensional and show you how far behind this anterior ethmoidal artery enters into the skull base from the frontal sinus relationship. So that when you do the frontal sinus work, you are not always, terrified with the anterior ethmoidal artery. See, let me pick up the anterior ethmoidal artery on this coronal view here. See, that's the level of the anterior ethmoidal artery. Can you see? And
Yes,
now
sir.
see this level in the sagittal. See, if I draw a line here, this is the anterior border of the frontal sinus here. See this? Can you see?
Yes, sir. Yes, sir. Yes.
This is the frontal beak. See the level of the frontal beak. Can you see here?
Yes, sir.
And see how much behind the anterethmoidal arteries. When you are working with a 70-degree from here along the beak towards the frontal sinus, then you work along the ethmoidal roof there and see the arteries far behind this red line. See, so once you are working in this trajectory towards the frontal sinus, basically your artery is miles away behind in a different trajectory. I hope you got my point, what I'm trying to say.
Yes,
So
sir.
when you're working for the frontal sinus with a 70-degree, your artery is far behind. It is from here, yeah, I can say from here it is almost, see, more than 1.5 centimeter behind from the beak. Can you see this?
Yes, sir. Yes.
So don't get terrified all the time while you're walking along the beak for the frontal sinus that your anterethmoidal artery going to be anywhere close. This is far away, miles away, I can say, in my terms, away and in a different direction running along the skull bed. That is something you can extrapolate from your, CT imaging very clearly. Is that clear?
Yes, sir. Yes.
Now, importantly, before we go fast, this is, this was the anterethmoidal artery roof. As we go behind, immediately the postethmoidal roof starts. So the anterethmoidal artery runs in the posterior most part of the anterethmoidal roof where the postethmoidal roof starts. Then the postethmoid is it's like a box bounded above by the skull base, medially by the superior turbinate here, laterally by the medial wall of the orbit, lamina papyracea, and then you go behind. See, these are larger cells. You can see the cell walls, but all white out. Larger cell, as you go behind, larger cell. Now see, the roof is formed by the frontal bone. Entire ethmoidal roof is formed by the frontal bone. Keep an eye on the frontal bone from terial to terial on this frontal bone. As you go behind, now the frontal bone is leaving. And this lesser wing of the sphenoid has come. And when lesser wing comes, it is the sphenoid sinus behind. So this transition from the postethmoid to sphenoid is very important to know during surgery as well. As in the posterior lateral wall of the sphenoid, we have tigers running the optic nerve carotid artery, and we should know where exactly the sphenoid had started so as to orient ourselves not to damage this structure blindly. So during surgery at this point, I will show you when the transition from posterior to sphenoid starts. See this rostrum, and here comes the opening of the sphenoid sinus. So the moment the sphenoid sinus comes, that is your limit, that the sphenoid sinus is coming into the picture behind, and then staying anterior to the sphenoid sinus, you can complete your postethmoidal work without any, being terrified with the carotid artery or optic nerve behind, because all those structures are going to be always behind the level of the natural ostium of the sphenoid. In any given abnormal anatomy, the optic and carotid artery cannot come anterior to the sphenoid ostium. It has never been reported so far, and it cannot come. Simple. So the sphenoid sinuses, the multiple septation, incomplete septation. This is the real septation. That is incomplete septation. See the multiple as you go behind, incomplete, like frontal sinus, scallopings. And then these are the pterygoid process. So, and the plates. So in this, what CT scan, what we have found, what we need to notice is some important relationship with the skull base, the kind of cribriform plate, the kind of skull base, the kind of orbit, any dehiscence, anterethmoidal artery, all these things to be kept in mind to prevent complications. So this was a quick review of the CT scan, and the case is ready. In a couple of minutes, we are starting. Before is the time for any questions or any suggestions.
Yes, sir.
Hello?
It's a lucid presentation of yes, sir. It is a lucid presentation of the radiology of the nose and paranasal sinus. and the importance of getting a digital images, especially 0.6 mm cut with reconstructed images.
See, the beauty of digital cuts is you can share with your friends. You can tag on any particular anatomy and share them. You can, on your team viewer, run together from a distant site. Like my friend is in Singapore and he's in theater, he can share his CT scan lively. I can see on my computer his CT scan through TeamViewer and so many things. So this is something, and this is a something data which you can store for future, for your presentation, for future reference or future follow-up or so many things, because printouts is something nowhere, a substitute to this digital format.
Delegates, if
Any questions?
if
We have
there are
a
any
couple of
questions,
minutes
you can,
before I wash up.
yeah, you can scrub and start the surgery, I believe.
Okay.
We are eagerly waiting for your master. Sharif, are you there?
Any questions by the delegates?
Yes, you want to?
There are
Yes,
mics
Dr.
left
Sharif
from
is
the
here. You can
auditorium. You all
speak to
can
him.
approach the mic and
Yeah.
Yes, sir. I'm here.
Sharif, case is induced and
Yeah,
draped,
the case
right?
This sir is about to wash up for the case.
Okay.
Okay, sir. Thank you.
any doubts regarding any queries to Dr. Satish Jain, please come up. There are mics put up in the stage.
Audio visual people, you can shift to theater, I believe.
मेरे को दे नहीं उससे वो था ना you can come, you can. You're part of the team today.
Dr. Sharif? Sharif?
Hello.
Yeah.
Can you give
We are getting CT image right now.
can you give the details of the patient?
What do you want?
Details of the patient, the symptoms and
Yeah, the patient had
case history. Yeah.
yes. Patient had history of nasal obstruction, recurrent discharge, and stuffiness in the nose. Had been treated several times at several places with antibiotic steroids. And on examination, was a cavity full of polyps. Then we counseled him for surgery. His, before surgery, he was given a course of steroids for almost 12 days from now. Can you
Yes, we are getting that image.
endoscopic picture?
Endoscopic picture, yes.
So for the Kerala people, Dr. Sharif is a part of our team today
Yeah.
with us in the theater. Dr. Sharif, once
Yes.
again, you're welcome.
It's an honor, sir, to be with you in the theater.
So I hope the picture is good.
Very good.
So this is the picture after preparation for almost 12 days,
Okay,
Now,
steroid and
why and
antibiotic.
what kind of preparation is required? See, what I kept before the surgery was the marrow cell pieces soaked in saline and adrenaline. See this?
Yeah.
Two, two, two marrow cells cut in almost 8 to 10 pieces of different sizes. Soaked in this was 1:2 combination in this patient. It depends upon the patient's, age and, physical status. We choose this concentration. In elderly patient, we dilute more to prevent any further cardiovascular, sensitivity. But this topical is pretty safe overall. We have
Sir, what
never injected
proportion-
for so many years now.
Sir, what proportion is saline and adrenaline? They're not
This-
using
this-
4% silocaine.
Pardon?
What proportion of saline and adrenaline and sir not using 4% lignocaine?
Not 4% because the patient is being operated under general anesthesia.
Yes.
No 4%. It's pure saline and adrenaline. In this particular patient, we have used 1:2 combination. Younger patient, you can use even a pure 1:1000. Elderly, 1:4 or whatever, but never inject. The reason being, this is a benign disease. In elderly patient, particularly cardiovascular labile patient, we can't afford this adrenaline when we inject to go in the disseminate in the systemic circulation and give cardiac complications. Those have been happened and reported in the literature, and we can't afford to take such a chance in this era now. So better use the topical, give at least 10 to 15 minutes for the topicals to apply, and this is to apply. See what I'm doing. I'm not pressing anywhere. We have to apply this adrenaline on the mucosal surface, and the first application itself decongests the mucosa. The first application itself decongests to prevent further absorption of adrenaline through the mucosa. So it makes it pretty very, very safe,
Sir, if you do in local anesthesia, we will use it this 4% because we used to do cases under local anesthesia also.
Yeah, local anesthesia, there are so many issues. Number one, the patient comfort, because many a times this surgery we use most of the time microdebrider, your powered instrument. Then sometimes you may need a drill, sometimes cobblator. And see, your airway safety is always a concern. The patient, is always frightened. And then there are so many issues. So it is better now to operate under general anesthesia. Nowadays, general anesthesia is becoming more and more safe. So we always operate all nasal cases under general anesthesia for the safety reasons, safety concerns. Number one. So in preparation, the pre-operative, why this preparation is required? To make your surgical field better. Why? Because this is inflammatory disease, and the resultant inflammation in the nose and paranasal sinus mucosa, resulting in vasodilatation, resulting in more bleeding, more oozing, and making the identification of the landmark difficult. What we discussed at the outset, this is the surgery which has low safety threshold. Identification of the landmarks is so crucial to progress during surgery and to prevent complication. If you keep operating in a bloody field, identification of the landmarks making more and more difficult, and you can ultimately land up in complications. So the most important thing in preventing complication is the surgical field. And see what I'm doing? The same marrow cell pieces, soak in saline adrenaline, apply everywhere, remove, rinse in saline, and use in the dip in same solution and reuse during the entire surgery. And at the end of the surgery, we'll pack the cavity, the ethmoidal cavity with the same pieces soaked in, the steroid. So this is how we carry out. And see, this is the most important intraoperative preparation from surgeon side. This topical application, never ever press anywhere. See, if you press anywhere, it is going to be counterproductive in terms of giving venous congestion. So prevent, such practices of pressing hard to open up the space to get more better field. This is never something going to happen. So use a gentle application onto the surface of this adrenaline to decongest more and more. Number one. The second part of the preparation, we are all dependent on our anesthesiologist, and tell you, see, let me tell you the parameters. See this? Can you see the pulse rate 54?
Yes, sir. Yes.
BP is more than, it is measuring, it's normotensive and now 100, 120, whatever. So the pulse rate is the most important criteria, for the surgical field. Why I'm saying so? Because this surgery, what we face bleeding is the capillary bleeding. It is not arterial bleeding. It is not arterial bleeding. And in order to reduce the capillary oozing, the best parameter to keep under control is the cardiac output. And in order to reduce the cardiac output, the best parameter is to reduce the heart rate, to reduce the overall cardiac output. And I'm so indebted to our anesthesia team and our chief anesthesiologist, Dr. Anupam, who has been with me for more than 15 years from now, together. And I consider him something, a master in this field for this particular anesthesia. See the field now?
Yes, sir.
How's the picture?
Yes, it's very good. Picture is clear.
So
Sir, is
now
any drug given for this to reduce the heart rate by like metoprolol by the anesthetist?
They use a lot of pre-operative and intraoperative preparation. So I never fall into that is their, something prerogative. And since we are working as a team, so he's taking care of this part of the, work. So now what I'm doing, see this? I'm just removing the polyps, the luminal polyps. See this?
Yes, sir. Yes.
These are polyps in the lumen to make the anatomy more understandable and prominent. Can you see this?
Yes, sir. Yes. Very clear.
Because multiple polyps, because this is what picture you are seeing is after preparation for so many days, And I can see certain landmarks in picture now. Let me show you. Give me. After every step, make it a habit to apply the same Merocel. See this?
Yes, sir. Yes.
Soak in saline adrenaline, apply for few seconds. Another important thing is don't keep it pressed for long. See, don't forget our goal is topical application. Whatever it applies in 5-10 seconds is going to apply the same thing in 1 minute, 5 minutes, whatever time you keep in nose. So there is no point in keeping it for long. There's few seconds and the job is done. Wash. Wash. See this? Chota. So what the structures, can you see something structure coming in your picture? There are, see our area of interest is the lateral nasal wall. And what we see here, the prominence and depressions in the lateral nasal wall from beginning, this is inferior turbinate. See this first prominence there. Can you see this?
Yes, sir. Yes.
This belongs to the nasolacrimal system.
Yes. Maxillary line.
The second prominence, can you see this? The
Uncinate.
only mobile structure in the lateral nasal wall. This is uncinate process. This uncinate is very often distorted when you find a lot of, massive polyposis. So the best way to identify is relating from the nasolacrimal duct because it remains unchanged. Behind that, it should be the uncinate, and that too confirmed by being a mobile structure. See this?
Yes, sir. Yes, sir.
So that's the uncinate process. The third thing behind that, let me remove. The third structure behind that, what you see, where the polyps are attached. So this is bulla ethmodalis. Can you see this?
Yes, sir. Yes.
That is the cell of the bulla. And in between them is the hiatus seminaris superior inferioris. And if I go in the depth of the hiatus, it opens laterally into a 3-dimensional space. Can you see this 3-dimensional space?
Yes, sir.
This
Yes.
is infundibulum, and in the infundibulum laterally, what opens is the natural os of the maxillary sinus. So that is what the anatomy in the middle meatus at this point of time after removal of these polyps. I hope it is very clear to everybody.
Yes, sir. Yes.
In this sinus surgery, this particular patient, our goal is multi-pronged. Multi-pronged means it is not the surgery which is going to surgery only which is going to cure the patient. It will facilitate the cure or the further treatment, because this is, we all know, nowadays proven to be an inflammatory disease, and steroid is the only thing which works at the entire inflammatory cascade. So now this surgery will be having multi-pronged aims. Number one, to reduce this inflammation, these polyps, whatever eosinophilic inflammation, to reduce this inflammatory load which has not been taken so far by the medical management. The core of the medical management is the topical steroids, which couldn't tackle this and the disease persisted. You can't give oral steroid for long. You give oral steroid, patient improves, you withdraw it, again the symptoms reappear. So the inflammatory load is too much to be tackled by the topical steroid. That's why the surgery has a role. And the goal of the surgery is to reduce the inflammatory load, number one. Number two, to open up the sinuses to establish their ventilation and drainage for their health, which the surgery will, do. And the third thing surgery will do, the most important nowadays, will give avenue for the topical steroids to penetrate deep into the sinuses. Now see, my first step of the surgery is infundibulotomy. See my
Yes, sir. Yes.
reverse biting going into the infundibulum. Turn it
Yes.
little down. See, this is a very important step. If I turn it little down, it goes away from the nasolacrimal system. This nasolacrimal system is coming anteriorly like here. So if you turn it down, it automatically keeps you more and more away and bite through it. See this?
Yes, sir.
Enlarge, advance it. Advance it until you come across the hard bone. When you come across the hard bone, that is the bone referred to as a nasolacrimal duct. Now see, at this point, what we have opened is infundibulum. Can you see?
Yes, sir. Yes.
This uncinate has two parts. See now the natural ostium. Natural ostium here. This uncinate has the upper part. I will show you where it goes. And this lower part horizontally going to a variable distance line. So what I'm now doing is, see this? This is the lower part of the uncinate. You can remove it by means of a, through biting, you can remove it by means of a micro divider, you can remove by a scissors, whatever. So here, I'm completing my middle meatal enterostomy. See this?
Yes, sir. Yes.
And we have seen on CT scan, there is hardly any, extensive disease in the maxillary sinus. This mucosal, edema is simply because of the blockage of the sinuses due to polyps being in the middle meatus.
Sir, for uncinectomy, do you routinely use this ostrum backbiting forceps or either instruments like sickle knife or other blunting
Yes.
instruments?
Yes. So, you know what happens? When initially this surgery was started with a Stamberger method cleaner, they would use the sickle knife. We can use the sickle knife, but you have to be extra careful. Let me tell you why. There's a valid point you have raised here. Now see, this is the widening of the middle meatus. See, I don't see any extensive disease in the middle, in the maxillary sinus, so I'm not widening it to anymore. Yes, otherwise you can widen it. If I widen it till the posterior wall, it will be grade 2, kind of a middle meatal enterostomy, or I can widen it any further to the floor, grade 3 or 4, a sort of medial maxillectomy, depending upon the requirement of suction. So you're coming to your question regarding the use of sickle knife. See, this is uncinate. You can use your sickle knife right to the attachment of the uncinate and take it in toto. See this?
Yes, sir. Yes.
The concern number one is this. I will show that now. Why we have stopped that? The concern, my biggest concern is this upper part of the uncinate is in close proximity to the orbital wall, that is lamina peparissia. The closest structure out of all lateral wall structure to the lamina peparissia is what? This uncinate process. And this will use as a landmark. We'll take the advantage of it using as a landmark when you remove the upper part. I will show you that why this upper part of the uncinate is so important. वो लगा, regular. ये नहीं. Section. Wash. Hello.
Yes, sir.
So this is middle meatal enterostomy.
Yes.
I hope it is very clear.
Yes, sir. Yes.
And what I'm trying to say, this upper part of the uncinate, we will use it as one of the major landmarks to identify immediately the lateral wall of the entire sinonasal corridor, that is lamina peparissia. The moment I remove the upper part of the uncinate, you will be right on the lateral limit of your entire sinonasal corridor, that is lamina peparissia. Let me show you. Let me show it very clear, and that can be used as one of the best landmarks. In the beginning, you get something as a landmark to show your limits. The moment you follow that, you will never give an orbital complication, as simple as that. See this lateral upper part of the uncinate. Now, there are many ways to remove this upper part of the uncinate. I can go behind with my, see this?
Yes, sir.
With my curate and fracture it gently. See this? Or I can take away with my shaver. See this? Because it has a thin bony plate, nothing else. See this?
Yes, sir. Yes.
What I'm looking at, the moment I remove the uncinate, I will show you, I will be right on the lateral limit of my sinonasal corridor. See this lateral limit of sinonasal corridor.
Yes. Yes, sir. Yes, sir. Yes, sir.
This is lamina peparissia. Can you see?
Yes, sir. Yes.
This is lamina. That is the concern for my sickle knife use. Suppose you use a sickle knife and makes an orbital entry in the beginning, it is something counterproductive for the surgeon's temperament, as it ends up in a complication at the beginning of the surgery. See this is lamina peparissia. Can you see the thin bone?
Yes, sir. Yes.
So the moment you remove the upper part of the uncinate, you reach right onto the lateral limit of the sinonasal corridor. That is one of the most important part of the surgery. Now see what I'm trying to say, what I said on CT scans. What I said on CT scans, I am at the axilla. Can you see this?
Yes, sir. Yes, sir.
I am opening more and more axilla to simplify the frontal. See the lamina all the way?
Yes, sir. Yes.
See the lamina all the way? Can you see?
Yes, sir. Yes, sir. Beautifully demonstrated.
This is my axilla which I want to open thoroughly. See this axilla. And I will here show you the most simplified version for the frontal sinus work. Most simplified one can think of. Give me a pack to give you a better field and show you. छोटा दिया करो, बीमारी है ना? Just for a while. For everybody, this is the most important step which I am coming to for the frontal in the most simplified manner, I would say. Anybody doing sinus surgery can reach to the frontal in the most simplified manner, and I have already given you an idea on CT scan. What is that landmark? Your beak. For beak, what is your landmark intraoperatively? Is your axilla. I hope there is no difficulty in identifying axilla to anybody.
No, sir. No, sir. Yes.
Once you can identify the axilla, let me show you how easier the further work is. Now give me 70 degree. The only thing is required is a 70 degree. 120. Now in no time, you can count in seconds, you will be in frontal. With utmost safety. No ifs and buts. फिर पकड़ना. Hold the hand. See now using 70 degree. Can you see?
Sir.
Hello.
Yes, yes.
I am using 70 degree for regions to see my limits in view. Let me show you. First of all, orient yourself. Can you see the maxillary sinus you have opened?
Yes, sir.
Then with 70 degree, let me remove this pack and show two landmarks. My medial landmark is the turbinate, which I consider as a useful landmark for the skull base. Can you see?
Yes, sir. Yes.
And my lateral landmark is what? The lamina.
Lamina papyracea.
See, this is lamina.
Yes, sir.
This is a reference not to cross. If I cross, I will end up entering into the orbit. Okay?
Yes, sir.
This is the turbinate, the upper attachment, which is a landmark. If I cross, I will be in the cribriform plate. Okay? Keeping these two references in mind. Now from here, see the only landmark I'm seeing. This is axilla. What I have done, I have opened up the axilla. Can you see?
Yes, sir. Yes.
See with 70 degree, everything under vision. This is what your beak is. Can you see the beak?
Yes, sir. Yes.
See from axilla, this thick bone behind. Follow this thick bone behind. Can you see this thick bone? Thick bone.
Yes, sir. Yes.
Can you see this? Bone?
Yes, sir.
And once you see this thick bone, anything behind that. See where the thick bone ends. Can you see where the thick bone is ending?
Yes, sir. Yes.
What is there? The frontal sinus.
The frontal side. Yes.
See again. There's nothing great into it. See this. This is my beak. Can you see or not?
Yes, sir. Yes, sir.
From the axilla, you can see the axilla first, which is easier structure to localize. Then from the axilla, follow the beak. And then following the beak, where the beak ends has to be frontal. This I have told you and shown you several times on CT scan as well. See this?
Yes.
With 70 degree working in this direction. It has to be frontal, nothing else. Can you see everybody the frontal sinus?
Yes, sir. Yes.
Very clear or not?
Very clear, sir. Very clear.
See, I have not disturbed any anatomy. Just found the lamina, just found the middle turbinate, just found the axilla. Following the axilla is the thick bone, the beak. The beak can be identified being the thickest bone in this region. Following the beak, go behind. See this. Following the beak, go behind. That is the beak above, the thickest bone. See this thickest bone?
Yes, sir. Yes.
Following the beak, where the beak ends has to be frontal sinus, nothing else. Can you see that?
Yes, sir. Yes.
I have done nothing great, but just exploiting the normal God's given anatomy, using it as one of the important anatomy, that is beak. See this? I haven't disturbed anything. My anterothoracic artery, I had measured you in centimeters. Remember?
Yes.
That is far behind 16 millimeter from the beak we measured in this case. And we are working with in the anterior direction along the beak in this direction, the anterothoracic artery in this direction, far away. So keeping your lateral and medial limit in view, and that is possible only with a 70 degree. Keeping your axilla in view, again only best with the 70 degree. Keeping your beak in view, see the big thick bone. and go underneath, it cannot be anything else than frontal sinus. I hope it should be very, very clear.
Very clear, sir.
Any doubts, any suggestions?
Sir,
Yes,
do
we
you
have-
routinely do intact bulla technique in one of the state conference previous
Yeah,
years
this
back?
is bulla. My bulla is still intact.
Yes.
This intact bulla was initially popularized, and I love this technique. Popularized by our own Dr. Sethi from Singapore, who did number of workshops in our country. Almost it's been 2 decades now, and popularized. You see, the beauty is my bulla is still intact. Can you see this?
Yes, sir. Yes, sir.
This
Yes.
bulla is going to the skull base, and what he popularizes, as long as this bulla is intact, your anterothomal artery is behind, because the anterothomal artery is always behind this upper attachment of the bulla. So that is for anterothomal artery. Now, adding on to that, first of all, everywhere I go for demonstrations, the first thing I've been asked, I get to know, sir, frontal sinus is very difficult. I fail to understand. This is something I made a goal to simplify it and see, out of all technique, there are number of technique. People will count in number of cells, this and that, to complicate the things. This we have practiced in our thousands of patients, simplest way. See this?
Yes, sir.
You are in the frontal. And if you want to further, enlarge the frontal sinus approaches to do further, like we have a case today of a classical inverted papilloma from the frontal sinus and its model skull base and going into the orbit, which we will kept for the demonstration. We'll show you in the extended approaches, what you need to do to further remove. See, this beak is the obstacle. Let me show you. To approach the pathologies more and more inside the frontal sinus, what is the obstacle? See, this is the interior of the frontal sinus.
Yes,
You see?
Yes, sir. Yes.
What is the obstacle? This thick beak we have seen on CT scan. If you remove this beak, the frontal sinus will marsupialize and you can see with 0 degree. So those are the draft approaches when you remove the beak. Can you see this?
Yes, sir. Yes.
So the only obstacle is the beak in those situations, and you can remove this with the draft approaches. And we have a case today to show that. We have another case of a frontal sinus CSF leak, still awaiting the, clearance, anesthesia clearance. Hopefully, if we get, we'll show you another draft. So if the things permit, let's see. Now see, this is the primary picture. So what we have done, again for the junior colleagues, middle meatal enterostomy, upper part of the uncinate removal to show that, see the lamina papyracea, lateral limit, medial limit as turbinate already in view. Go to the axilla, take 70 degree, see the beak, follow the beak and go behind the beak, along the beak, and you are going to go nowhere else but the frontal sinus. I hope it should be clear.
Yes, sir. Yes.
And how is the picture?
Picture is also very good, sir.
Yeah. I am amazed to see this morning the pictures from Manoj. I don't know what camera, what recording system he uses, that was mesmerizing. What a clear, crystal clear HD picture. So we'll like to know from Manoj what he's using, IDA or something else for the recording. What was amazing pictures. Is he in the auditorium?
Yes, sir.
Can we get to know from him? For the
Yeah,
benefit of
he just
everybody?
went outside. We'll tell him to clarify.
Yeah. So now, having done this, what I am going to do, see this particular beak is so prominent. Articulate. Sometimes the beak has a projection, making it narrow, the frontal sinus opening narrow. In that situation, we can use this, articulated punch. See this? See this? Just to show you,
Yes,
there's an
sir.
amazing articulated punch from the Karl stores. Amazing, amazing. We can bite through and enlarge the opening. See this? That is to take away the projection of the beak. Can you see now?
Yes, sir. Yes, sir.
Much
Sir, is it a
better.
crescent punch or?
No, it's not a simple Kerrison punch, but it is a glorified Kerrison punch with a number of articulations to make it angulated perfectly to reach out to the beak.
Yes. Okay.
Can you see now a much bigger opening
Yes, yes.
as I remove the projection from the beak? So these are add-on procedure if you want. Sometimes it is very narrow and you have to do that. Or sometime even a classical draft, particularly in revision situation when you have a lot of osteogenesis, lot of, fibrosis, scarring, all those things. Now the next thing, reverse. The next thing what I will show you here again. To find the ethmoidal roof, as I said on CT scan, behind the frontal sinus is the beginning of the ethmoidal roof. You know it?
Yes.
Now let it be the posterior table of the frontal sinus will flush with the ethmoidal roof, anterethmoidal roof. See this in the simplest way. This is my reverse blade, the so-called adenoid blade, which we never use for adenoid, rather condemn for adenoid use as a rear facing blade. But with 70 degree, you can make it front facing.
Yes, sir.
See this?
Yes, sir. Yes, sir.
Can you see the ethmoidal roof coming into the picture?
Yes, yes, sir. Yes.
See the posterior table of the frontal flushing with the ethmoidal roof.
Yes, sir.
Can you see?
Yes, sir. Yes.
What I removed this upper part of the bular attachment there. Simple. And see under vision with the simple tool, that is the reverse blade. Red 40 reverse adenoid blade, and we call it as a skull blade to flush it. Can you see the frontal sinus and the ethmoidal roof together? Yes or not?
Yes, sir. Yes, sir.
And see everything mucosalized. Can you see?
Yes, sir. Yes.
See above here is the posterior table of the frontal sinus, and this is flushing with the roof of the ethmoid now. See, very clear?
Yes, very clear.
And now we will see where the anterior ethmoidal artery. See, we have seen the frontal sinus, we have seen the anterior part of the ethmoidal roof, yet we have not even discussed about the anterior ethmoidal artery, not even bothered about it. The reason is we know it passes through the posterior most part of the anterior ethmoidal roof. What's my point?
Yes, sir.
Posterior most part of the anterior ethmoidal roof. So, see this? At this point, now I will take the bulla. See, this is my bulla.
Yes, yes.
I can go behind it. See, like this.
Yes.
See my direction coming out. Fracture and come out. Can you see this?
Yes, sir. Yes.
In toto, to expose the ethmoidal roof behind. Can you see?
Yes, sir. Yes.
Let me remove this. This is attached laterally to the lamina papyracea. So the major part of the bulla I have removed. Now give me 40, regular 40. See this, what I am trying to say. That is the remnant of the remnant of the bulla. See this? Attached to the lamina. Can you see this?
Yes, sir. Yes.
remnant of the bulla, this one. Now, since I remove the bulla, see the upper attachment is still there.
Yes, sir.
See this all edematous mucosa because of lack of variation. And this is the site of my enteroethmoidal artery. This is the site of that is the enteroethmoidal artery here. That is the enteroethmoidal artery there. Can you notice?
Yes, yes, yes.
So it could come into our picture or notice only after merocell, only after removal of the bulla. Imagine what a safety landmark bulla is. Unfortunately, over 90% of the 98% of the situation in our practice, it goes right up to the skull base to protect the vessel from anteriorly. So if we have such a great landmark, see now, let me decongest and reverse and show you more about this artery. Don't get terrified with this vessel all the time. This runs through the posterior most part of the enteroethmoidal cavity.
Hello, Satish, Manoj here.
Hi, Manoj.
I just picked out for a minute to take a call. So I heard you ask me something.
Yeah. So what I was telling, I was so mesmerized watching your quality of video.
Thanks so much, Satish.
I want to know, really amazing. Want to know, can you see the enteroethmoidal artery?
Yes, sir. Yes,
Yeah,
sir.
wonderful.
So see how it runs to the skull base and see the location. That is frontal sinus. This is the cell, that is suprabular cell. See this? And
Yes,
this is
sir.
the artery running so almost 1.5 centimeter behind the frontal beak. See, this is frontal beak. And we measured on DICOM how posterior this is, in what direction this vessel is running. So don't get terrified all the time. So Manoj, what I was asking, the recording system you use for, this videos.
Satish, see, at one time there was this camera that was built by J&J.
Yes.
It is no longer available now. It has got a wonderful
Yeah, it's
system.
not.
We can directly record onto the hard disk without any loss of quality.
You're still using the same one?
I am still using the same one. Luckily, those two cameras are still lasting with me all these years. So quality, imaging quality is fantastic when you record and show.
Super, super. It's not available now.
It's not available now. They stopped making it. The company
So
shut down.
anything you suggest as an alternative?
I've been trying all kinds of stuff. I was telling those people that I have not even found anything remotely comparing to that. It's really good. Right now, I asked for the demo of the latest Striker system, they 4K. I want to try out whether it's better than that or not. That also, I believe you can record directly onto a hard disk.
Yes.
I asked for a demo. They are getting it. I think next week they're bringing it to our clinic. So let me see how it works. And let you know. This is actually, like you said, no, I have not found anything even comparable to that so far.
Yeah, that was amazing. Now see, for everybody, thank you, Manoj.
Yeah, thanks, Satish.
This is the enteroethmoidal artery. You can see this oblique course
Yes, yes, sir.
going toward the skull base. See this?
Yes, sir. Yes.
So this artery coming out of the orbit, running along the skull base, and then going toward the lateral mela. Now see, what do we get the information out of it? Running towards the lateral lamella. Some mucosal ooze was bothering. See this. Now, where is the level of the lateral lamella, and why it is important to know here? See where this artery is running here. See this middle turbinate? We always, it's a standard teaching, we know that don't fiddle with the middle turbinate much as it goes above and insert on the lateral lamella. See that? So
Yes, sir.
this level of the lateral lemma is here, this part of the turbinate, this, not this part, not this part. It is this part of the turbinate, and this part of the turbinate is so flimsy. See this? This is the thinnest part of the skull base. Even the slightest manipulation, uncontrolled manipulation can lead to a distant, CSF leak. So this area is roughly from the frontal ostium, almost a centimeter behind. You have to be very careful medially. This is frontal ostium. Medial to this, there is no way, there is no important structure. But 1 centimeter behind and medial, that is the level where the anterior ethmoidal artery pierces, and that is the level where the lateral lamella is, and that is something the site for a CSF leak if you are not careful. And this is the area where you must show, extra diligence to work in close proximity when you work there. See that?
Yes, sir. Yes, yes, sir.
How is the overall picture?
Yes, sir.
So what we have done, we have already done maxillary, we have done frontal sinus work, we have done anterethmoidal roof work, we have seen on the landmarks, we have seen anterethmoidal artery, and now the last work left for us is the postethmoidal and the sphenoidal work, and for that I'll change to 0 degree again. Next case. Hello.
Yes, sir.
I hope it is very clear.
Very clear. Clear.
See now. Back with 0 degree. The best treatment for the middle turbinate, that is most important anatomy, is respect, respect, and respect. In any given situation, you find that it is not very stiff, not very solid. It is sort of, it can block the ethmoidal cavity. You have to deal with it, otherwise not. Third section there. So now this is the picture with 0 degree. See the maxillary sinus?
Yes, sir.
This one. See this?
Yes,
And
sir.
this is your remnant of the bulla, which is left behind. Lowermost part, which I have almost removed. And what you see this is ground lamella.
Ground level.
See this turbinate?
Yes, sir.
It's turning here. Can you see this?
Yes, sir. Yes, sir.
See the turbinate itself is turning here, lying in the coronal plane. This first part lying in the sagittal plane, then it's turning and lying in the coronal plane like this. See now, much better. Oh.
Yes.
That is your ground lamella. You can see much better. 40. At this point of time, before entering into the postethmoid and doing further work, the one anatomy I always emphasize, to go to the inferior orbital limit. See this?
Yes.
Explore, always explore this, especially. See this?
Yes, sir.
This medial orbital angle. See this? What I have opened up? Is that very clear now?
Yes, sir. Yes.
See the limit of the orbital roof, orbital floor, or the maxillary roof. Can you see this maxillary roof level?
Yes, sir.
That is one of the biggest, I would say, landmark for the further work behind. 0. Straight. See now, I will use this as a maxillary line, as a landmark. This level of the orbital floor or the maxillary sinus roof. See this level?
Yes, sir. Yes.
I will use medially to enter into the postethmoid. See this?
Yes, sir.
I have entered into the postethmoid like this. Just entry. Now, as I said during CT scan, my fear of working or doing a post-sigmoidectomy here is, I don't know when the post-sigmoid ends and when the frontal sinus starts. I need to have certain landmark to guide me that this is the end of the post-sigmoid and that is the beginning of the the sphenoid sinus. See now, what is this? What is this? Can you see something? This is nasal septum.
Yes,
Hello?
yes. Yes, sir.
And this landmark, what is this? This is superior turbinate. Can you see this?
Yes.
Rather than doing a post-sigmoidectomy, what I will do, I'll remove the lower part of the superior turbinate first. See this? This is to generate an additional safety. And at this point of time, see my maxillary line? Can you see something at the level of the maxillary line?
Yes, sir. Yes, sir.
See, just close to the septum. Flush to the septum. Can you see?
Yes,
I've
sir.
gone inside, flush to the septum. See this? What is this?
Sphenoid sinus.
This is sphenoid sinus. Can you see this very clear?
Yes, sir.
The idea is to follow the maxillary line. The idea is not to go above the level of the maxillary line. See, this sphenoid ostium is never close to the floor. Rather, it is relatively close to the roof. See this?
Yes,
If
sir.
I don't consider his maxillary line as a landmark and try to look for the sphenoid ostium here, I can easily enter into the plenum sphenoidum. And that's a disaster. Now, having seen the sphenoid sinus ostium, I told you during radiology, this is the greatest landmark to know further relationship. As long as I stay anterior to the ostium, once again, as long as I stay anterior to the ostium, my carotid and optic now are never going to come in the way, whether it is ONOD, whatever, whatsoever is the anomaly or whatsoever is the situation. As long as I stay anterior to the sphenoid ostium, I can never damage anything. Remember, I said the same thing during the radiology. See this. See this.
Sir, yes, sir. Yes.
Now staying anterior to this limit, that is the sphenoid sinus, anterior to this, I will remove and open up the entire post-sigmoids. See this? See this?
Yes, sir.
I
Yes.
can flush all these post-sigmoids. My lateral limit, I have already told you, it's like a box. The lateral limit is going to be lamina.
Yes.
See, all the time this ostium is in view and I don't intend to cross it behind. If you cross it behind and work with this like this, it can be a disaster. See, this is the anterior wall of the sphenoid. Can you see this?
Yes, sir. Yes, sir.
Now, staying anterior to it, you can do any damn thing. You can play around without any issues as long as you are anterior to the wall. See the anterior sigmoidal artery there. See the
Yes.
post-sigmoidal roof.
Yes.
See the entire post-sigmoidal roof flushed.
Yes.
See the skull base. See the orbital wall, the lamina. See my turbinate intact there. And now
Yes.
the last thing left is widening of the sphenoid wall. See this?
Yes, sir.
If the bone is thick, you can use your punch, you can use Kerrison, you can use sphenoid punch, you can use Stamberger punch. There are so many things, or you can use drill, or if it is not hard, let me show you. I will remove with the micro divider only. See this?
Yes.
By staying on the anterior wall, strictly on the anterior wall. Hold on. Can you see here?
Yes, sir. Yes.
stay on the anterior wall, should not debride anything, should not use any sharp instrument without knowing the where exactly you are into the sphenoid sinus. 40 लगाना है इसके बाद. अब 40 लगाना. See this?
Yes, sir.
I widen the anterior wall till lateral limit. Can you see?
Yes, sir. Yes.
See the sphenoid. 40. Very clear or not?
Clear, clear, very clear image.
Now I will use another safe tool, that is a regular red 40. Now using with a 0 degree towards, keeping the edges towards me, and I can see inside. See, just the bogey mucosa, nothing else. Nothing else. See this, just a bogey mucosa. Can you see?
Yes, sir. Yes.
And this is your interior of the sphenoid without giving any issues. You don't need to do anything much over there. This is the access now for the topicals to go inside. You can see very clear.
Yes, sir. Yes.
So that completes our full house face on this side. See, I told you in the beginning, this is a surgery of landmarks. You have to identify landmarks all the time. See this? If your turbinate is floppy sometime and you find it is not stable, you have to do something. If your polyps medial to it, lot of polyps in the olfactory recess, better to do a partial resection. And this becomes floppy because of the pressure of the polyp. This patient had massive polyposis. What you saw polyps today was the minimal one, and that too because of the preoperative steroid treatment. So this turbinate not looking very strong, though we didn't bother it throughout the surgery. Could you see?
Yes, sir.
But we need to do something to it. Any questions regarding this full house face?
Delegates, if you have any question, you can come and ask. Mics are kept in between.
Please feel free to ask any question or suggestion. Sure.
Sir, the middle terminate being unstable,
Yeah.
how will you prevent lateralization?
Yes. In this particular patient state there.
Yes, yes, sir. Yes.
Yeah, there are many ways, I told you, had there been polyposis medial to it towards the olfactory recess? See the olfactory recess? Very clear?
Yes,
No
sir.
polyps, so I will not sacrifice it. Number one. Now I can do two things lower down to everything. What is to be done is to be done at the lower end to keep this olfactory access clear. Got my
Okay.
point? Now I have two options. The simplest one I'm showing you. Can you see something?
Spot welding.
I am making the septal surface demucosalized. See this?
Yes.
The same thing I need to do. Just mucosalize, demucosalize, nothing else. See this? And we can approximate these two and keep or pack for 48 hours to invite adhesions. That is Bolgerization. Can you see this? Another thing you can do is you can put a suture. Now there are a lot of septal needles, suture needles are available. You can put a through and through suture from the turbinate here. After making a little rod turbinate to the septum, then from the opposite side to terminate back here and put a knot. What I have done is inviting adhesions between the turbinate and the septum at the lowermost end to prevent obliteration of the olfactory axis. Can you see there above?
Yes, yes, yes.
And that is called Bolgerization.
Yes.
So that's the final picture after
Yes,
the full
very
house
clear.
face.
Fantastic
in-
demonstration, sir.
Thank you. In your outpatient
very-
department with your 0 degree, you can, see the progress of the douching going on. This will allow the douche to reach everywhere. See, one of the goal of surgery to give wide openings is to allow the topicals to enter inside the frontal sinus. Can see the frontal sinus with 0 degree.
Yes, yes, yes. Very clear.
Because we widen the axilla to maximum, and this concept we are working these days more and more on 0 degree visualization of the frontal sinus. This doesn't give us except a better penetration of the topicals into the frontal sinus. See that?
Yes.
So that is all about the, the sinus surgery on this side. We can take questions before we move on to the other case. I'm not showing this on the other side. Our team will finish off and we'll
Yeah.
show you more variety of cases as the time permits.
Yes.
Okay? This
Okay.
patient I told you has a high deviation.
Yes.
So you can
You
do
have to do septoplasty there, no?
unlimited septoplasty
Limited
there.
purpose. Yeah.
Yeah. Let me show you a limited one. Okay?
Okay.
Want
Okay.
to see? Want to see?
Yeah. Yeah.
Yes, sir.
A limited septoplasty, and the aim is to give access. See this? Still, I can do surgery from this axis.
Yeah.
What
But
will happen? Going through the
post-operatively.
narrow space will traumatize.
Yeah.
So what I will do here, no infiltration.
Oh, yeah.
Subperichondrial plane now.
Yes. Yes.
See this?
Yes.
Now that is the the chondro bony junction, bony cartilaginous junction
Yes.
there. And this is actually the high deviation of the bony septum.
Yes.
What's my point?
Yes.
So what I'm doing here actually is see this. Can you see the junction?
Yes. Yes. You split it there.
See, that is the deviated portion behind.
Yes.
See this?
Yes.
This is my, and see this septoplasty we are doing for the post-operative purpose.
Yes.
To allow our instrumentation intraoperatively better. See now, this is the deviated portion.
Yes.
Is it the legs forceps you are using to remove that cartilage?
They are the bone.
Is the instrument used to remove that?
Bone. See,
Yes, sir.
I am removing the bone.
The instrument used is it legs forceps?
Yeah, lux forceps. Simple lux forceps. My anterior cartilage is still intact. See that?
Yes, sir.
And it is the higher bony deviation. Find out. Let me show you. Higher bony deviation, which was responsible, only that part I have removed. See this. Now imagine the excess previously and now imagine the excess now. Can you see this?
Yes, sir. Yes, sir.
Can you see the improved access now?
Yes. Yes, we can appreciate this.
I have not removed the cartilage anteriorly. See this? And I have adequate access now to do my sinus surgery. See this? What a roomy cavity now. Can you?
Yes, yes, sir.
So that is something you achieve. See the roomy cavity now.
Yes, sir.
Don't need to do too much of work, but yes, you from CT scan you can get to know that there is high deviation. I showed you, and now I have see this axis is defined by your view of the middle turbinate. See this? My entire middle turbinate and space medial to it is clearly visible now. See this?
Yes, sir.
So that is something the access I have got now. And one can carry out the sinus surgery work easily now without any hindrance. See this?
Yes, sir.
Hello.
Yes, sir. Yes, sir.
See the access now on this side.
Yes.
Previously it was so narrow space and now see? So roomy? Agreed?
Yes, sir.
So that is what, our aim of a limited septoplasty was to give access, This is purely to give access. See this roomy as opposite side now.
Yes, sir.
Yeah, without any, difficulty or complication, you have ample of access. See now our axilla is right in front of us.
Yes, it is very,
The high deviation is not coming into picture. Can you see?
yes.
And that is the beauty of limited septoplasty you can do.
Okay.
Thank
You-
you. So we are
You
not.
continue this case or you're going for acoustic neuroma?
Yes, the next case we are taking up. And as I told you, due to the time and other constants, I'm choosing this case as will take less time. But,
It's already started or?
yeah, we have already induced the case.
Okay.
Hello.
Thank you, Satish, for wonderful demonstration.
Thank
It
you.
was as usual, it was fantastic.
लोकल लगा दिया कैनाल इंटैक्ट रहेगी और स्पीकर पीछे कैनाल मत
Thank you, sir, for that intriguing session. We look forward for your upcoming sessions. As a token of appreciation, I invite Dr. Ram Mohan, former AOI State President, to present a memento to our esteemed chairs. Dr. Sajid, AOI State Secretary,
Hello.
and Dr. Sadruddin Ahmed, Head of ENT Department, Kottayam Medical College. The second surgery will be chaired by Dr. Manoj MP, Managing Director and Chief Consultant ENT Surgeon and Head of Cochlear Implants at Miss York ENT, and Dr. Prabhakaran, AOI State President. We have a small announcement. The PG students who are presenting case reports are requested to report to the preview room, west side of Green Room 1, to upload their presentations before 12 p.m. today. Quiz prelims will start at 12 p.m. at Sapphire 3.
The septo तो भिजवा दो सेप्टो प्लेन तो प्लेन सेप्टो ना फेस कौन सा एक और हमें इसका सीटी लाओ फाइल लाओ
Can we put those lights off, please? I feel like I'm a football stadium.
Hi, Satish sir.
Hello,
Welcome, sir. We are ready.
thank you.
Manoj and Prabhan is here, sir.
Hi, Satish. Morning once again.
Good morning, Manoj.
Very
Once
nice to
again.
see your surgery. Now let's get to something that is interesting for me also. You know, I don't do those, no? But it is lovely to watch you operate, Satish. Lovely
Thank you.
bandana, by the way.
Thank you. So nice of you. I know you have been so modest. You have been such a fantastic surgeon and teacher. And your cochlear implant demonstration started. Today's proceeding was amazing. So now coming from rhinology to otology and skull base, our next case is a vestibular schwannoma. The more appropriate name is vestibular schwannoma. So the name which applies, more commonly used is acoustic neuroma because it affects the acoustic nerve. Actually, doesn't arise from the acoustic nerve. So this patient, let me how it presented. This patient presented with a sudden sensory neural hearing loss. Almost a few months back.
Okay.
On left side, and he was given like as usual steroids and everything everywhere. He consulted, but nothing happened. Came to us. So on our workup visit, our always a policy to order an MRI for all sudden sensory neural hearing losses, whether they recover or not. I'll tell you. I'll emphasize it why. And all patients having unilateral hearing loss with interoral difference of say 25 decibel or so. This is now included in the American neurosurgical, recommendations, neurosurgical association recommendation to order an MRI when patients having unilateral sensory neural hearing loss with interoral difference of 25 decibel or not more to order an MRI. So we ordered the MRI and what we found, let me first share with you. Can you connect the laptop, please?
Yeah, we can see it well now.
Now, so now on the first image I see when I order for, for sudden sensory hearing loss is the T2 heavily weighted images or the drive images. Can you see this?
Yeah, clearly, sir. Clearly.
In these images, the CSF is so bright, more bright and prominent than a regular T2 because of the suppressed rest of the background. And what see, this is the CP angle system on this side, CP angle system on this side. See on right side is the cochlear vestibule. That's the intra-auditory canal with nerves inside. Can you see very clear?
Yes, yes.
Look on the left side.
Yeah,
Look
clearly.
here.
Yeah.
Some hypodense lesion in the lateral part of the intra-auditory canal. Young male, see the age about 28 years.
Okay.
In 3 months, complete hearing loss on this side, had dizziness and all, which has already been compensated. And now he came to us and this MRI revealed this vestibular schwannoma. Now the question is what to do? Do we really need to operate this? And if yes, why? So decision making is very important.
Is it a profound loss, Satish?
Yes,
is it a profound hearing loss?
Yes. So decision making has two aspects now. One is whether it is really needed to be operated. Or second is then if yes, then what approach do we use?
Okay.
So we have 10 minutes to start now and I will take you through these two issues. One is whether need to be operated or not. Now, As we all know, there are 4 nerves passing through the internal artery meatus. And it has already affected the 3 nerves. 3 nerves means the vestibular nerves had dizziness and now compensated being a young patient so early by the opposite side. And the hearing now, which is already affected. You know?
Okay.
So now the 4th nerve is the facial nerve, which in vestibular schwannoma, because this is a schwannoma, this is an expansile lesion, it is not an invading lesion. And it doesn't affect the facial nerve in terms of giving clinical paralysis, not only early, even in the late in the course.
Okay.
Even in the bigger size lesion, they don't present with facial palsy because nerve has a capacity to elongate and stretch with the tumor pressure, whatever big size it is. And when it is bigger, it expands into the CP angle cistern and doesn't affect the auditory nerve anymore, whatever size it may be. You may have 5 centimeter acoustic, yet not affecting the facial nerve clinically because it has an enormous capacity to stretch. Yet without being giving a clinical paralysis, yet the nerve being so thin like a ribbon, like very few fibers, still in continuity and still maintaining the clinical, integrity of the facial function.
Yes.
That is something beauty about this now. So now the 4th function, that is the 4th nerve, which is unaffected at the facial nerve. And the entire, the core of the treatment now is directed to preserve the facial nerve in future.
Yeah.
Now it has been studied. Tumors which are growing more, as I said, the nerve is more and more stretched. It has sometimes a common blood supply from the facial nerve and the tumor, which has. So, bigger the tumor it is, more the nerve is stretched, and then you remove the tumor, more are the chances of giving some sort of facial paresis or paralysis.
Yeah.
It has been generally observed for tumors more than 2 centimeter or so. It is so difficult to preserve the facial nerve function to completeness. You may have some sort of paralysis, some more paralysis, whatever, but you will never find a normal facial nerve function after in such a big tumors.
Very true. Very true.
So now we have already lost the hearing. We have nothing more to lose. Now this is the best opportunity to preserve the facial function.
Right.
And for such a small tumor of the size I will measure and show you, this is the best opportunity to preserve the facial function. Now let me see the size of this, tumor. See, 9
millimeter
by 4 millimeter or 5 millimeter, whatever, is the size of the tumor. And with this size tumor, it has been studied, our experience also in our hundreds of such cases done, the smaller ones. This is the best opportunity to preserve the facial nerve. Okay?
If the hearing was, Satish, if the hearing was okay, what would you do?
Yes, that's a question from master. Then would be the decision making would be more, difficult. If hearing is normal in such tumors, small canalicular tumors identified as incidentalomas on MRI imaging, or on certain symptomatology, if you find such tumor, now the decision making depends upon so many things. Number one, majority of these small tumors, the first strategy is to observe. Observe with serial MRIs, and all these tumors do not grow substantially.
You're right.
A chunk of tumor, more than 50% tumors, either do not grow or grow very slowly, and you can manage on a serial MRI until they show substantial growth. Substantial growth means more than 3 millimeter growth every year. To me, it is substantial growth. Until then, you can observe unless it gives some complications. Now, there are certain patients, the age is an important consideration. Small canalicular tumor in elderly, the first and the foremost strategy is observation.
Exactly.
Since they are slow growing tumor, if the patient is 65 and above, you can very well observe for years together because the life expectancy is not so much. If you can consider as 80 years as a life expectancy, you don't need to bother, you can observe. And in case if it starts growing, in that situation, you can use your gamma knife or something to control the growth, to, contain the growth. so in elderly is a different, scenario. In young patients, you have to give a cure rather than gamma knife. This is simple, one thing we know. Radiation is never reserved as a first choice for young people for any regions. And for young people, if the patient has hearing loss, then obviously like this patient who has already lost hearing, there is the best chance to give him a cure as well as preserve the facial function. If the hearing is intact, I would observe.
Absolutely. Yeah.
Observe until it gives substantial growth, until it gives hearing loss, until it gives, sometimes this definition of hearing loss should be understood. It is not the pure tone audiometry which, clarifies the quality of hearing loss. It is along with that the speech discrimination score, which is more important.
Okay.
So when you start losing the quality of hearing, when you use required for the day-to-day purpose, or what you call it as a good hearing in terms of day-to-day use, then you have to think of surgery in number one. Number two, when the patient present with dizziness, when vertigo, unsteadiness is a major problem. Maybe elderly patient for that reason. Maybe elderly patient when vertigo is the presentation and unsteadiness, which is long lasting, not relieving, when the compensation is not happening, then surgery is the answer to treat both the tumor as well as taking away the afferents to relieve vertigo. What my point? So,
Satish, in your experience, how many patients do you see presenting with vertigo as a primary symptom?
Less than 10%.
Yeah, right. Yeah.
Less than 10%.
Very low, very low.
So that's why I mentioned in the last, very low percent of the patient. But yes, a patient present with vertigo, I have seen patient with incapacitating vertigo. With small intracranial tumor, and yet to operate upon that and relieve the vertigo.
Okay.
Because sometimes these, persistent vestibular afferents are more disturbing than no afferents, What's my point?
So suppose the patient is young and we opted for a conservative management. How will you follow up the patient?
Serial MRI. First is annual MRI. Then once in 2 years, until it doesn't show any growth. If it shows growth, then start showing growth, then you can get it done 6 monthly and it still shows growth. You have to better to discuss with the patient for the removal, because this is something which requires a lot of decision making with the patient as well. Patient choice is sometimes a very important factor, because this is a major surgery. This is the surgery where you result in CSF leak, and there are always possibility of complications. Theoretical possibility, though in the present situation you can handle all these in the best way, but still you have to discuss with the patient decision making. Sometimes patient, in spite of everything, they want to live with it without getting any problem, because there is always, you cannot guarantee facial nerve preservation even in the small tumors.
Exactly.
So the decision making is important to discuss with the patient. Now, those patients, suppose this is a very small tumor. Had this been a little bigger one and cystic tumor, I would straight away suggest a surgery in cystic tumors, whatsoever the size it is.
You're right.
Because cystic tumor tend to progress very fast. And in larger tumor, in case they grow larger, preservation of the surrounding neurovascular structure become very, very difficult unless you leave behind the wall. So these are the important factors in decision making, whether to operate or not. Then there are certain issues. Once you operate, then what approach one can think of? See this, there are many approaches in vestibular schwannomas. The translab is the approach which inherently sacrifices the hearing. That is the biggest disadvantage. Every approach has its own advantage and disadvantage. So the translab has an advantage, I will mention, but the disadvantage, it sacrifices the hearing completely. So in decision making, any patient who has already lost the hearing, whatsoever size the tumor is, the preferred approach is the translap. Whatsoever size means, maybe a 5 centimeter acoustic, yet you can remove through the translap because this is the tumor which has a well preserved arachnoid, layers all around. It's not that through the translabyrinthine view, the entire tumor in one go should be visible all around. You can debulk the tumor, you can mobilize the non-visible part of the tumor in the field then, and you can again debulk and keep mobilizing the rest of the tumor in the field and remove it.
Yeah.
So size is not a criteria for choosing the approach for that matter. The other two approaches, retrosigmoid and middle cranial fossa, have an ability to preserve the hearing, and they have their different, advantage and disadvantage. Let me quickly go through in 5 minutes so that we can take decision making. I'll skip this. So, conservative management, as we already discussed, in patients with advanced age, short life expectancy, slow growth, patients who are not fit for surgery or minimal symptoms, only hearing here. This is one of the important criteria to observe as long as possible, as long as the hearing is intact. Now, suppose the tumor has grown to a bigger size and started compressing the hearing. What you can think is, you can decompress by the retrosigmoid route. You can
Yes.
decompress. You can, decompress the posterior wall of the intra-auditory meatus to accommodate more tumor without exerting pressure on the cochlear nerve. A sort
Yeah.
of decompression. Remove the posterior lip of the intra-auditory canal to allow the tumor to expand and leave the pressure from the auditory nerve, something like that. So you can debulk, you can use a gamma knife, as long as you can, wait, you can avoid surgery in the only hearing ear. And in case required, you can implant the other side. The other ear who has a profound loss, you can implant the other side and get the good hearing. Once you get the good hearing with the implant on the other side, then you can take on a call to extirpate this tumor on the opposite side. Okay?
Yes.
So these are important decision-making factors like you asked. So by and large, any tumor, see this is a simple algorithm. Any tumor which has lost the hearing, the translap is the approach. Otherwise, any tumor which is more than 1.5 centimeter, what we believe, tumor which is more than 1.5 centimeter is practically difficult to preserve the hearing. Serviceable hearing. Even if your proton shows 50 dB hearing loss, get the SDS done, it will be poor. Because the more the tumor grows, it affects the cochlear nerve. Like this patient, what happened? Where we have two vestibular nerves, superior and inferior. The inferior one is in close proximity to the cochlear nerve. So tumor which arise from the inferior vestibular nerve, they affect the cochlear nerve early in their course and present with hearing loss. What we believe in this patient, which is such a small tumor presented with hearing loss, must be arising from the inferior vestibular nerve and presented early with the hearing loss. Got my point?
Right, sir. I mean, very clear algorithm.
Otherwise, it is so difficult to predict in a larger tumor whether it is arising from inferior or superior vestibular nerve. Though you can do a calorie test. Still, if you are getting caloric responses, means lateral canal responses, if you are getting, that means your superior nerve is intact and still tumor from the inferior nerve, but it is difficult then in a larger tumor. So, by and large, for larger tumors, whatsoever the hearing is, it is never, it is rarely possible to preserve the serviceable hearing, and better is to do a translap. A distorted hearing is worse than no hearing.
Absolutely.
So, it
So
is
your
better
bad
to...
hearing thing would mean actually speed discrimination scores as a criteria, right?
Yes. Now, when the patient has good hearing, like you have asked, see this, for smaller tumors, good hearing, if the tumor is intracanal, like this tumor, being intracanalicular, good hearing, and you wanted to operate, the best would have been middle cranial fossa. That to a laterally placed tumor. This is a laterally placed tumor. Even the retrosigmoid approach is a hearing preservation approach. For intracanalicular tumor, retrosigmoid is a good approach if the tumor is medially placed. What my point?
Got it.
You can drill the medial canal and you can remove the tumor easily. But for such laterally placed tumor, this is never a good case for retrosigmoid because you have to all the way come in the lateral part of the canal,
Yeah.
drilling the canal, and you don't see the lateral end of the canal and remove indirectly and end up losing the hearing. For defeating the purpose, you started off.
Yeah.
So, had this patient been having a good hearing, would have been the ideal case for the middle canal fossa approach, because this gives you the fantastic exposure of the lateral part of the canal, for that matter, entire canal, yet preserving the hearing. The only concern to me about the middle canal fossa approach, there are two concerns, three concerns, I would say. Number one, it is a difficult approach than any of all the approaches.
Yes.
Number two, in elderly patient, this is not a good approach because you have to elevate the dura a lot till the petrous apex base and retract it. And dura in the elderly patient is very friable, and you can end up, tearing the dura. Third is you have to retract the temporal lobe a lot sometimes. And those patients who had history of epilepsy, who had issues in the intracranial issues and all that, we avoid this. And fourth is, see, let me show you through a picture. Yes, see this architecture of nerves in the intra-aortic meatus. Antero-superiorly is facial now. Hello?
Yeah, we can hear it. Yeah.
Posterior-superiorly is?
Superior vestibular.
This is inferior vestibular now. Now, coming from superior, this view, this route, most of the tumor, 90% of the tumor arises from the inferior vestibular now.
Yeah.
In order to reach tumors arising from the inferior vestibular now, small canalicular tumor, you have to manipulate the facial nerve.
Yeah.
Coming from here, you have to always manipulate the facial nerve, retract it, and some sort of facial paresis happens to take place. So, you are removing the tumor by the middle canal fossa approach at a lot of cost. I have already mentioned the concerns about retracting the temporal lobe, dural difficulties, and then the facial paresis. Many of these patients, manipulating the facial nerve results in some sort of facial paresis. That is the biggest concern with the middle canal fossa approach. So, you have to choose the approach according to the case. So translabyrinthine, what we are discussing today, has a lot of advantages. I will show you. The best advantage is it has the most direct access to the CP angle. What do I mean? Let me take you to the MRI. See this. This is CP angle. Can you see?
Yeah.
If let me show you. If I come from here as a straight line through the labyrinth, can you see?
Yeah, we can see it.
The most direct approach I will show surgically. You drill the temporal bone and you straight reach to the CP angle. Head-on approach. For the retrosigmoid approach, what happens? This is your sigmoid sinus here. So you have to go from behind the sigmoid sinus and attack from behind. So this is a different angle. This is not a head-on approach to the CP angle for that matter. Number two, this translab gives direct access to the intra-aortic canal. See this?
Yeah.
See this? Direct access. With retrosigmoid, if you want to reach out this part of the canal, you have to drill the posterior lip of this canal. And then drilling, reach out here, and you have no landmarks, you can end up damaging the inner ear organs and end up losing the hearing. So the advantage of the translab is most direct access, no retraction of cerebellum. And the first thing you identify once you open the lateral end of the canal are the cranial nerves.
Yeah.
Most easier to identify the facial nerve than any of the other approaches. So in this case, I will show you first the facial nerve. I will show you this tumor is so laterally placed, you will be directly onto the tumor and the facial nerve there behind. What's my point? So in any given case, this is the approach which allows earliest positive identification of the seventh cranial nerve in the beginning of the procedure. In retrosigmoid, you don't, because in retrosigmoid, you go behind see if your tumor is here, suppose let me make out as some sort of tumor. See, if my tumor is here, suppose this is the tumor. What's my point?
Yeah, got it.
This facial nerve runs on the stretch anteriorly and superiorly from the tumor. Since it arises from the inferior vestibular, now the facial nerve is going on the anterior superior part of the tumor. In retrosigmoid, you have to go all the way across the tumor to see the facial nerve behind. What's my point?
Yeah, got it.
So that is never a direct approach. So this translab is the one which allows you to identify the seventh nerve at the beginning. It gives you the best exposure of the intra-aortic canal circumferentially. I'll open up the entire intra-aortic canal and show you. Okay? And
Yeah.
since the bony cavity, they are in the canal, you can you can control the CSF leak very well, because in this approach, you obliterate the entire lateral cavity after that.
Yeah, yeah.
What's my point? So this
Got
gives
it.
the least risk of CSF leak as compared to the other approaches. No
Mhm.
other approach requires fat obliteration, cavity obliteration.
Yeah, yeah.
That requires a cavity obliteration, and this gives you the best opportunity to prevent the CSF leak. What's my point?
Got it.
In case post-operatively hematoma or anything happens, in the retrosigmoid, your cerebellum, you retract it swells up. You can't go easily back into the same area easily with a swollen cerebellum. Here you remove the fat and you are back onto the place in a minute, without wasting any time. In that situation, if you need to re-explore, okay?
Got it.
But obviously, it has disadvantage also. I already mentioned the hearing is always sacrificed as an inherent part of this approach. And secondly, sometimes technically difficult when your jugular bulb is anteriorly placed, your sigmoid sinus is so superior, and you have hardly any space to deal with the tumor, for instrumentation and dealing with the tumor. So narrow access is a relative contraindication. With experience, you can deal with that as well. Okay?
Oh, yes.
So anything else, Manoj, you want me to?
No, this contrast in, we always advise MRI with contrast in case of sudden initial. You would always order a contrast, Satish, or would you are okay with the flare?
No, contrast is always required. And we have the contrast. See, contrast is required for differential diagnosis,
Yeah, yeah. Mm.
See, there could be many lesions in the CP angle and you have to have a differential diagnosis. Let me tell you, in this particular patient, there's the contrast imaging coming up. Yeah, see, this is the 3D contrast.
Yeah.
Why 3D contrast? Let me tell you. See, onus is on the surgeon again to order what kind of imaging. Because you order MRI brain, the radiologist will do MRI brain, 1 or 2 sequence,
Yes.
1 or 2 printout, that's it. Why would he bother doing MRI for an hour? Unless you ask for.
Yeah.
So what we ask in this particular situation, see kind of MRI, see how many sequences we have got done. This
Mhm.
was 3D, Fiesta image, what we have seen, 3D, all 3D in all planes. Then the flare image to see if any infarction or anything in the brain. Once you suspect an acoustic neuroma in a larger tumor, see, you may have, larger tumor may give a brainstem or cerebellar or infarction anywhere. And the image which picks up earliest is the flare imaging. You must order, otherwise you will miss. Diffusion imaging is so important. Let me tell you, the diffusion is so important to know even earliest any infarction and to differentiate the masses in the CP angle. Like cholesteatoma shows diffusion retraction. Other tumors do not show diffusion retraction. So many things you can have for differential diagnosis because you can't order MRI again and again.
Yeah, right.
So diffusion is very important. Then contrast, we order 3D contrast. The beauty of 3D contrast is see the 1.5 mm section. You can't miss the lesion so easily. See the regular contrast. Let me show you. Even if you write the contrast MRI, they will do this. This is contrast MRI. And see the sections, 4.5 mm. Can you see?
You'll easily miss a tumor. Small
Yes.
tumor.
If you write contrast MRI, the radiologist, the technician will do contrast MRI with 5 mm sections and you can miss a lot of things. So, in order to get the better contrast and more details, you have to write down 3D contrast. 3D contrast in imaging where you get even sub-millimetric imaging.
Yeah, absolutely right. That point is so important because people have to know what to order for.
Yes.
But sir, one more question. So you ordered the contrast MRI. For follow-up, you would not ask for contrast, right? Every follow-up?
Yes, follow-up, I would, in a CP angle tumor, when you have operated, You have complete removal intraoperatively, so you don't generally.
Yeah.
If you leave behind a sliver of the tumor, nowadays it has been a policy. Manoj, your question is valid.
Mm-hmm.
Nowadays, in larger tumors, the protection of the facial nerve is very difficult. If you try to remove the tumor completely, so it has been a policy by various people to remove a sliver of a tumor, say 0.5 centimeter or so, along the
Yeah.
facial nerve
Mm-hmm.
to protect the facial nerve function, which is so important.
Yes.
And observe that tumor with a serial imaging, and in case it grows, you can give a gamma knife.
Hmm.
Or if it grows very fast and anything, you can reoperate.
Yeah.
But the most important thing you preserve is the facial nerve function for the patient.
Absolutely.
So in that situation, when you leave the tumor behind, you have to follow with the contrast MRI.
Yeah.
Okay. Now,
So this very clear.
now this is 3D imaging. See, I have 1.5 mm.
Yeah.
Can you see this tumor in the intraoperative
beautiful.
meatus?
Yeah.
Now let me reconstruct it. Let me reconstruct in all three planes. Always reconstruct, always sit and spend time on your imaging to get more and more details.
Yeah. There.
Yeah. So now see the same tumor in the coronal. Can you see this tumor?
Yeah. Lovely. Yeah.
Yeah, and you can measure again. Same thing you can measure.
Yeah. Yeah. 9 millimeter.
See this?
Yeah. Perfect.
Sort of. So the contrast will tell you to differentiate from others. Now, if you ask me for the closest differentiation of this tumor in the lateral end of the intra-auditory canal, my second differential diagnosis is a facial nerve neuroma. And the third one is a hemangioma.
Exactly. Yeah.
Now, in these three things are so difficult once they are so small on MRI or any imaging. But their presentation is different.
Yeah.
I told you, whatsoever size the acoustic neuroma is, vestibular schwannoma is, doesn't present with facial nerve palsy.
Yeah.
Rest of the tumor, like hemangioma or facial nerve neuroma, even a small size new tumor can in the intra-auditory meatus may present with facial nerve palsy because those are invasive tumors.
Exactly.
Facial nerve tumor, your facial nerve schwannoma runs through the facial nerve sheath and can present with facial nerve palsy. So, if such small intracanalicular tumor present with facial nerve palsy, it is unlikely to be the acoustic neuroma.
Absolutely. Yeah.
Unlikely to be vestibular schwannoma. This is important thing to note. Got my point?
Perfect, sir. Perfect.
Now, the last thing I would emphasize and then go into the surgical part, it is ready, is this imaging. This is simply, we are working on it and we have now 40 patients on it to show something new. This is 3D flare imaging.
Yeah.
3D flare is, see, MRI has a capacity, MRI is so versatile in terms of giving so many sequences to get more and more different information. When you have a small acoustic neuroma, on MRI, you can predict the hearing loss which is coming up.
Okay.
Or if you have a small hearing loss, you can see the earliest changes in the inner ear. Inner ear fluid is totally black on 3D flare. Black means black. It has hardly any protein content to be picked up by MRI.
Yes.
With a tumor in the intra-auditory meatus, start showing changes on 3D flare. See this? Changes on 3D flare, yet showing good hearing.
Okay.
Whatsoever the hearing preservation approach you use, it is not going to save the hearing for that matter.
Okay.
You got my point? So,
Absolutely.
if some neurosurgeon, anybody XYZ, looking at a pure tone that you can preserve the hearing and go by the hearing preservation approach, going unnoticed on 3D flare, which has already given alteration in protein concentration in the inner ear fluid,
Okay.
is not going to save the hearing in long run.
That's very pertinent. Yeah.
So, don't waste time and go by the translap. Better, most direct and get the best chance to preserve the facial nerve rather than wandering here and there with other approaches.
Yeah.
So this is something amazing. We are working on it, and this is something, eye opener.
These pictures are from your studies, Satish? No.
This is where we initially started off, and we
Okay.
have a lot of pictures now. I can share you where we
Yeah,
are
please.
we're working
I'm
on it.
also very curious about this. This is very interesting. Yeah.
Very interesting. You can predict the hearing loss. This is
Yeah,
for
yeah.
you. And this same thing we are extrapolating in sudden sensorineural hearing loss also, Manoj.
Yeah.
Patient presenting with sudden sensorineural hearing loss, the first question from the patient and the relatives is, will the hearing loss recover, doctor?
Yes.
You say, I will give oral steroid, I'll give intratympanic, I will give oxygen therapy, this, that, and number of therapies you give.
Okay.
Whether my hearing loss will recover.
All right.
And this is one of the way to answer those patients, and we are working on it. Those
Okay.
patients with sudden sensorineural hearing loss
Okay.
have developed changes on 3D flare in the inner ear fluid,
Okay.
are unlikely to recover.
Oh, wow. Okay.
You can prognosticate very well on day one.
Okay.
Those having clear 3D flare get MRI on day one when they present. If the 3D flare is, clear, get on to the work. You can predict a good prognosis whatsoever. Tell your patient, but you should do every possible thing,
Okay.
as you have still the chances for the hearing to recover.
Something really worth research. Shajid, we should do this.
It's amazing. So we are working on various aspects of MRI, to predict all these things.
Yeah.
So this is different from the topic. So I just mentioned. So now is the time for the surgical part. My associate is already open, and now I will change. I will wash up,
Yeah,
change,
please.
and then go to the surgical part in couple of minutes. Anybody has any questions can ask Manoj, or we can discuss together, whatever.
Yeah.
In couple of minutes, I'll be back with the microscopic picture.
We would like to acknowledge the presence of two esteemed doctors, Dr. Alok Thakur and Dr. Anand V. They have arrived here, and we wholeheartedly welcome you to KENTCON 2022.
Where are they? Where are they? Hi. Both of them very dear friends of mine, doyens in the field of ENT. I love talking to them every time I see them. Anand, especially, I love going to his house. If anybody has to, I do not know how many of you go for Anand's conferences, but go visit his house sometimes. You see everything there, dogs, fishes. Lovely place. Anand, my second visit is due. Anybody here has got a doubt about what has been talked so far? Because this is not a usual thing, because, we see, of course, so many people presenting such hearing loss having small tumors. So are you all doing imaging the same way as Satish mentioned is a question here. And this is something that I think is my fault. Sajid has been talking to me a long time about having a protocol in place, having a research project in AOI about what to do with sudden SNHL. Are you sure we are all doing this? Because if we are not doing this, we should do it this way. There is no point just doing a regular MRI brain for a patient, or taking a CT scan for somebody with a sudden SNHL. If you have to do imaging, you have to do it this way, not any other way. Any doubts here, please?
Next is that will be
One question to Manoj. Suppose there are recurrent facial pulses. In that case also, we are supposed to do an MRI, compulsory MRI, I think.
Yeah, any facial palsy that doesn't recover in a month needs an MRI. See, majority of case of your so-called Bell's idiopathic facial palsy will recover in a month without treatment. You don't need to treat Bell's palsy. There's no need to give anything. But if they don't recover in a month, you'll need to do an MRI to rule out a facial schwannoma. Any recurrent facial palsy will need imaging, of course. And again, only MRI with contrast, the same way they did it this way.
When you will do an HRCT temporal bone, in this case, where you do an MRI only or an HRCT temporal bone?
HRCT will never pick up this lesion.
Will never pick up, but HRCT is good for you to plan surgery.
Yes.
you would never know how anterior sigmoid sinus is and how high a jugular is without if you don't do an HRCT. The staging for a jugular, high jugular bulb is a CT staging. It's not an MRI staging. Right, Satish?
Yes, absolutely, Manoj. This is a very, very valid point. Let me throw some light on it, what I want to say. For any vestibular schwannoma surgery you do, whether retrosigmoid approach, any approach, HRCT is must. And let me give you an example why it is. We have many neurosurgical colleagues working.
Okay.
They do the retrosigmoid approach. You know, what we need to know the nematization of the temporal bone cell tracts.
Yeah, yeah.
In the retrosigmoid approach, if you want to remove the canalicular tumor and you drill the canal,
Yeah, yeah.
many a time there are cells behind the canal, they open up.
Mm-hmm.
And if you don't have a CT scan to know which cell tract is and where it is leading to,
Yes.
we have seen while drilling the canal with the retrosigmoid, it presents later on with the CSF rhinorrhea.
Absolutely. Yeah, yeah.
Because that cell tracts communicate to the temporal bone cellular system, petrous apex system, and ultimately through the Eustachian tube, it drains into the nose. And
Yeah.
in that situation, once the patient post-op with a retrosigmoid or anything, if you don't know, if you know this cellularity, suppose you know, what you do, you can go pre-sigmoid first, even if you are doing retrosigmoid. Go
Exactly.
pre-sigmoid first and excentrate those cell tracts first.
Yeah, yeah. Very right.
Got
Very
my
true.
point? Otherwise, post-op, if this happens to occur and present with a CSF rhinorrhea, majority of the times it doesn't stop by whatsoever conservative measures you do.
Mhm.
The reason being, because this is a bony tract, it
Yes.
is not going to collapse.
Mm-hmm.
It is not going to collapse by any lumbar drain, whatever measures you do. It has to be sealed. Now, if you go back with the retrosigmoid, number one, it is difficult because you have already retracted the cerebellum and it has swollen. Number
Yeah.
two, going by the same approach, going to the fibrosis and all that is always difficult.
Yeah.
Number three, even if you go, what can you do? Even if you try to apply bone wax or something, it is not going to work once it is lined with CSF.
Absolutely.
It is not going to stick to it. And majority of the times, you have to do a subtotal petrosectomy and obliteration of the cavity.
Absolutely.
To save the patient. I have done for many neurosurgeons this procedures for the post-operative CSF rhinorrhea after
Okay.
the retrosigmoid, this subtotal
Oh.
petrosectomy and obliteration.
Okay. Okay.
So, HRCT temporal bone is must, whatsoever the approach you do.
Yeah, yeah. That answers your question, no?
Even though it is not pertaining to this subject, suppose we are suspecting a metastatic lesion in the facial nerve. Which one will help? HRCT or MRI, sir? Metastatic lesion facial nerve. So especially it is said that in
Facial nerve lesion is always MRI. Any facial nerve differential diagnosis always MRI. HRCT is only for planning surgery. We will not.
No, please. Always feel free.
Yeah, yeah.
किसका है? ये क्या है? CTPNS 0.625 CD में लिया. So we are starting the surgical part. Our associate has already given a retroauricular incision to raise the flap so that we can start directly with the drilling to save time.
Can
Hello?
we? The picture is not visible. We can only see us.
Yeah. It's coming in a minute. So it's around 11:30 now.
Yeah.
12:30 is our video presentation time. So hopefully I'll be able to finish this trans lab in 1 hour's time.
Oh my. Any questions from the audience?
हटा दो ऊपर की light. Yeah, please feel free to interrupt me any point of time.
Satish is an ideal person to ask questions to. He doesn't get rattled at all. So I expect him to come up here and ask some questions. There are actually no stupid questions. There are only stupid answers. So please.
But see, any interaction is welcome.
Yeah.
Our
Are you
next,
getting the microscopic picture now?
Yeah, very clear, Satish. Very good. Yeah.
So this is my favorite, something I am addicted to it, this Varia microscope.
So
sorry.
that's exposure that you need for a good translab approach.
Yeah, so what we have done, see this exposure requires all around to eradicate the cellularity,
Yeah.
to see the exposure of the sigmoid sinus and even behind.
Yeah.
Because in larger tumors, you have to decompress the sinus. Now, my translab exposure in this case, as compared to the other bigger acoustic, would be little different because I don't need any larger decompression, surrounding decompression. I don't need to go to the CP angle for the large tumor. I need to restrict myself to the canal. So
Exactly.
I will not be doing larger decompressions. Okay.
Don't need to skeletonize the dura and all that here. Yeah.
Not really.
Sir, our next session will be at 12:30. We'll have a video demonstration on office-based laryngeal surgery by Dr. V. Anand. One more announcement. The prelims for the quiz for the PGs will be beginning in Sapphire Room 3 at 12 p.m.
I am also looking forward to this 12:30 session from the masters. That is a very interesting topic. See, this is the conical bar.
Yeah.
Right. Or the crude work, faster work. No.
Like in all inner ear surgeries, the posterior canal wall has to be kept very thin. You can see how Satish is doing it.
दूसरी मोनोपोलर का टूथ फॉर्सेप्स सेक्शन दूसरी दे
So suppose you have a high jugular bulb, very prominent jugular bulb. What will you do, sir?
Same thing, we will decompress it.
Suppose this
If
is
we have a high jugular bulb, anterior sigmoid sinus, we have to decompress them to get more space, more working space.
suppose that this is the major jugular and the opposite side is not adequate enough. Suppose this is the major side and the opposite side is not compensating much. Is it a contraindication, sir?
See, with experience, you can manage this situation. But yes, if you are not experienced, not able to decompress them adequately and manage them, then it is a relative contraindication.
Decompressing the sinus doesn't necessarily mean obliterating it. So you won't actually, even if we decompress it, the flow is still there. So if you are in a dominant sinus, you still can get around it by decompressing.
It is such a big pneumatized cavity.
Yeah, big cavity, ideal for this case, kind of case.
Yeah, but in this case, we don't need that big of exposure for that matter.
For the demo, Satish, it will be nice for people to see.
Yes.
You can see the sinus.
See the sigmoid sinus?
Yeah, very clearly, yeah.
And what I'm doing is the perisinus, drilling. In case required to be decompressed, you can decompress easily.
Yeah.
Dear delegates, refreshments have been arranged outside the hall. I request you to help yourself out there as time permits.
This is my lower limit as a digastric ridge you can see coming into the picture. That's the prominence of the digastric ridge.
Yeah.
This is the digastric ridge prominence.
It is so important to clearly delineate the digastric ridge, and it's been done beautifully here.
See, so much of the drilling is required. See,
Yeah.
another disadvantage of this approach, what people consider, is a long approach,
Yeah.
requires a lot of drilling as compared to the other approach. Retrosigmoid is the fastest of all approaches.
Exactly.
Fast. You open up, remove the bone flap, and get onto the dura easily.
Yeah.
But here it will require a lot of drilling depending upon the pneumatization.
What is generally described for vestibular autonomous surgery, I'm sure it doesn't apply to people like Satish. It's 1.5 hours of work outside the labyrinth, labyrinthectomy 1.5 hours, and tumor removal 1.5 hours. This is what people say. I mean,
Yeah.
it doesn't.
Yes. Even more, sometimes even more. But
Yeah.
see, in this case, the tumor removal will not take time.
Yeah.
I will remove in few minutes. Tumor it is not a big one. Yes, the drilling will require time because it is extensively pneumatized situation.
So the big advantage of seeing the digastric is also to know where the facial nerve is ascending from. Because like Satish said, paramount importance not to damage the facial nerve here.
Absolutely. Now the limits, the surgical limits for the exposure would be posteriorly sigmoid sinus, superiorly the middle fossa dura,
Yeah.
inferiorly here would be the jugular bulb. I can see the hue of the jugular bulb here.
Yeah.
And anterolaterally would be the the vertical facial canal.
Exactly.
Let me show you. See, this is my way of, faster drilling. I'm used to it. Point out.
Satish, you know what? The Medtronic systems don't have this conical burr. That's very, very irritating. I have them.
Yeah. Even I have.
I have all Medtronic systems now, but the problem is I don't get the conical burr, which is so nice to use.
Yeah, they are so amazing.
Yeah.
See, now I am in the antrum.
Yeah. That's a lateral semicircular.
The thing which there's the lateral canal. See, the conical burr expedites your work.
Yeah, beautiful.
See, I'm reaching my limits quickly.
You can actually see the posterior canal also here.
Yes, point out. Now the thing which I want to see here is the short process of incus.
Yeah.
After the lateral canal, see the glimpse of the short process?
Yeah, we can see it now, yes.
If I give a tilt, you can see better. See the glimpse of the short process.
Yeah, very clearly.
I'm using my most favorite Ben air drilling system. Now, see, as long as I run my drills parallel to the incus,
Yeah,
I am lateral to the facial canal.
exactly.
Facial nerve is always medial to it. See, I'm running
Yeah, very
parallel
clear.
to it.
That's a sentinel cell there.
Yeah, because it is so pneumatized. Now I think running medial to it, give a little magnification to show you the glimpse of the facial canal. I can see.
Yeah, you can see it very clearly. Yes.
The drill, oh, the diamond, no?
See that pink color now.
Yes. I can appreciate the change of color. You can also appreciate that.
Yeah, very
Now
clearly.
see what I'm doing. I'm closing this cell.
The sentinel cell. Yeah.
Yes, because we don't want the CSF to track through it.
Yeah.
Important thing in this surgery, I always mention, before opening the intra-aortic canal, before coming the CSF in contact with all these cells,
Yeah.
you have to drill away all these cells, run diamond and seal these cells, because once the CSF lines this cell, even
Yeah.
your bone wax is not going to stick to it.
Absolutely.
So do whatever sealing of those cells before the CSF come in contact.
Mm-hmm.
And that is what I'm going to show you just now. See this facial now.
Yeah, facial nerve seen very clearly now.
See the lateral canal. I don't intend to preserve. I have to drill it away anyhow. I am using a larger burr. See this.
Yeah, lateral canal is opened. It's ampullary end.
I have to open them. See now my facial now.
Yeah, very clear. Yes.
Facial nerve monitor is essential in this surgery.
Yeah.
What I believe, doing this surgery without a facial nerve in the Western countries is considered as a crime.
Exactly.
Now see, before going deeper, this is the time to understand. Before going deeper, so that you don't forget, all these lateral cells, see this?
Yeah.
You have to seal them with a diamond. Ruk ja. You have to seal them with a diamond, bone wax, whatever.
Yeah.
So that if the CSF comes out, it doesn't go to the other cell tracts and you second tube.
Yes.
You should seal them adequately. See this?
Yeah, very clear.
Similarly, below and see this?
Yeah. Yeah.
Everywhere you have to seal this. Perisigmoid we have done.
Mm-hmm. Sinodural angle.
Yeah, I'm coming to that in the end.
That is the cells under the digastric ridge.
Yes. See, this is my sigmoid sinus U, you can see.
Yeah.
See this? That's a jugular bulb below.
Yeah.
See, all cells have been cleared off.
Absolutely.
See that? All these lateral cells have gone until including the canal and the facial recess cells.
Yeah.
We have defined our vertical facial now. And now I'm coming to the middle fossa plate and that sinodural angle. See this? Yeah, cutting the one.
Sir, can we locate the cochlear aqueduct here, sir?
I will show you. It will come deeper, sir. Once we see the intra-aortic canal, I will show you. It will be, your point is valid. It is below the level of the intra-aortic canal, just above the jugular bulb. See this peridural.
Yeah, very cellular mastoid.
Yeah, see the dural. See the cellularity.
Yeah.
Can you see? See this peridural cell.
Yeah.
Now completely drilled off. Perisinus, peridural, because all these cells ultimately may drain into petrous apex cell group.
Yeah.
Sorry to interrupt you, sir. Participants for the quiz competition are requested to report at Sapphire 3 at 11:50 a.m. Participants for the quiz competition are requested to report at Sapphire 3 at 11:50 a.m. The following participants are requested to submit their case reports at the earliest in preview room.
See the extreme cellularity in the sinodural region.
Lot of cells.
Lot of cells.
Dr. Akhil Kumar, Dr. Remita, Dr. Sushamma, Dr. Ashta, Dr. Malvika, Dr. Sharon, Dr. Kirti, and Dr. Ammu Dilip are requested to submit their case reports before 12 p.m. in preview room.
That is most of the sinodural cells cleared.
See the amount of cellularity.
Yeah.
Bipolar. Wash diamond for a while. No bipolar. Or bleeding in the lateral skull base. Hello?
Yeah, we can hear you.
Yeah, for controlling the bleeding in the lateral skull base, for bony bleeding, we have option like dry diamond
Yeah.
or bone wax. For soft tissue bleeding, we have bipolar or Surgicel.
Yeah.
See this? Bipolar. Dry diamond. Dry. See the sinodural angle now?
Very, very clearly.
See how extensively pneumatized. This is peridural cell, the squamous plate pneumatization, over pneumatization of the squamous plate.
So normally if it is a large tumor, so this should have exposed the entire dura, the posterior as well as the middle fossa. But this one, it is not necessary, but you still have to remove all the cells.
Yeah, cells we have to remove. So Surgicel है ना? चलो.
That's it.
Now see the perilabyrinthine cells. Diamond. रुको लगा दे.
Now, one of the things, if you notice being done because of, sake of clarity, would not say it. Exposing this amount of dura is okay in vestibular schwannoma surgery because it's going to obliterate the cavity anyway.
Yes.
In a mastoid surgery or a cochlear implant, if the dura is exposed, but the arachnoid is exposed, you need to plug it somehow.
There I would not go like this then.
Yeah, it will not go like that.
See, all these are the perilabyrinthine cell tracts now. See this?
Yeah, very, very clear.
This is the region of the solid angle.
So even though it is not pertaining to this case, can you point out the access to cerebellum at this stage?
Yeah, where my drilling is. See here. That is the Trotman's triangle. Hello. This is Trotman's triangle
Yes, sir.
between the labyrinth, sinus, and the dura.
Yes, sir.
Bone vex. See all cellularity being accentuated. My vertical facial is in view. See, I applied the bone wax there. See that?
Yeah, bone wax used to stop bleeding.
Chote diamond done. Now see, the gross bone removal has been, cell removal has been done. Can you see?
Yeah, we can see it.
And I went fast because this was not so important a part of surgery.
Yeah, we
I
can
mean,
see.
You can stay a little crude, it is acceptable.
No,
Now
it is.
this is the ampullary end of the lateral
Lateral.
canal. See that?
Yeah, very clear.
And that is the facial now, anterior to it.
Yeah.
This is delineating my anterior-superior limit, facial now.
Yeah,
And see, these are the retrofacial cells.
yeah.
See, I am working retrofacial.
Very clear. See, all this what you're doing, Satish, is to prevent any future CSF egress, no?
Yes, exactly. See, what I am delineating here is the jugular bulb. See, everybody.
Yeah, yeah, very clearly see.
That is jugular bulb. That is my inferior limit. See the jugular bulb.
Yeah, beautiful.
See this jugular bulb. Suction blocked. Now is the time to drill labyrinth. Okay.
Yeah, yeah.
Now this labyrinth is composed. We all know labyrinth is composed of cochlea vestibule connected with semicircular canals. Here we are going to drill this vestibule along with the semicircular canal. This entire block, and this is the thickest bone in the body, you can see. And see, all these three canals, this is lateral one, here would be the superior, here would be the posterior, all have some or other relationship with different parts of the facial now.
Exactly. Yeah.
The superior canal here, I always demonstrate in my, cochlear demonstration, cochlear dissections. The superior canal here, it is going to be here. The dome of the superior canal is the closest, relationship with the labyrinthine segment of the facial now.
Yes.
Lateral canal has the genu, as connection with the genu. You can see how close this lateral canal with the genu of the facial now. Second genu.
Yeah, yeah.
And this posterior canal has a close proximity to the vertical segment, which is, I'll say, 0.5 to 1 millimeter deep to it.
Mm-hmm.
So all three canals have different relationships. See, my facial now is very clear in view.
Very clear, very clear.
Can somebody give facial nerve monitor to test? To show everybody.
That's a fashion amount.
On. Volume. Yes.
You can hear the beep if your ears are very.
Yes, I can show. Can you put some कौन सा? नहीं. Volume क्यों नहीं आ रहा है इसका? volume probe is connected or not. Give a, I can see a small beep, not a good one. Yeah.
Is the muscle accent has been cut out, no, Satish? Because you
Yeah.
won't get muscle accent has to be off.
Yeah, that is already. Can I ask NSD how long it's been? Anupam? मसल रिलैक्सेंट ऑफ है कितनी देर हुई यस आई कैन ये कैमरा ये इधर माइक उधर लगाओ उस पे मॉनिटर
Yeah. Of course, we do have no doubt it's a facial nerve. We can see it. It's already, you can bend it a bit.
Yeah, so it is important to familiarize. It is important to familiarize this beat so that
Yeah.
we can hear the same thing from the canalicular segment.
Yeah, we can hear the sound very clearly. Yeah. The thing is that if you repeatedly stimulate, the nerve goes into refractory phase, it will stop.
We'll see later more. So this is the vertical segment of the facial now.
Yeah.
And this is my, the cavity drilling, exentration of all cells now.
Yeah.
Now give me some right angle. I will remove this incus also here. Because later on I will pack this editors more effectively with what? Muscle.
Muscle. Do you remove the incus before packing, no?
Yes,
Yeah.
yes.
Yes. Because if you need to
Yes.
pack it properly, you need to have the incus out.
Yes, yes. You can pack with the incus, but then it doesn't give very effective,
It won't be.
Packing.
Yeah.
See, I am just demucosalizing the entire editor's walls. See this?
Yeah, very clear.
Or packing will stick later on.
You can
Okay.
see the malleus now.
Yes. Now give me same size cutting. Now I will drill away the labyrinth quickly to reach out to the intra-aortic meatus. Lateral canal, we have already seen this.
Yeah.
Now I am with a cutting burst. These three canals, they open in the vestibule medially. The vestibule is medial to the facial now with 5 openings. See the 2 openings. Number 1, give me pack.
Lower one is a non-ampullary end of the lateral canal.
Ampullary and non-ampullary end of the lateral canal opening in the vestibule in the posterior and superior wall, anterior superior wall.
Yes.
Now, this is the superior canal. The ampulla of the superior canal is close to the ampulla of the lateral canal. See this?
Yeah.
See this?
It's the ampullary end of the superior semicircular canal.
Yeah. And this is non-ampullary end.
Yeah. It's a subarcuate artery that's bleeding.
Yes, this is subarcuate. This is solid angle. This is ampullary end of the lateral canal. And this is non-ampullary end. Will follow. This non-ampullary end is going to join the non-ampullary end of the posterior to form the crus commune there.
Yeah.
This is solid angle and that is solid angle and the subarcuate artery. I hope the picture is good through this microscope, Manoj.
It's beautiful. It's beautiful. Nothing to complain. Perfect. The subarcuate artery is the upper limit of the internal aortic meatus. So you will know that it's below that.
Yes, absolutely.
It's a posterior canal, ampullary and below.
Yes. See this? What I drilled is a pre-sigmoid this plate.
Yeah.
This is not very important in this case as I don't need to go to the CP angle so thoroughly. There's no tumor projecting into the CP angle.
Yeah.
I don't need a wide exposure, but it's still for a proper translap. Oi. Don't touch my hand. See the
Yeah, we saw that.
posterior canal. Hey, तुम ये vowel क्यों कर रही हो?
The ampullary end of the posterior canal is always underneath the facial nerve.
Yes, that is the facial nerve above, and this is underneath. This is the posterior canal. And this non-ampullary end. See here. That's the non-ampullary end. This is going to join the non-ampullary end of the superior
Superior.
canal. See this? See this?
Yeah, clearly. Yeah.
This is the region of the endolymphatic sac.
Yeah. Yeah.
Now, having seen all the canals, I can drill away this bridge of bone to open up the vestibule thoroughly.
Yes.
See the vestibule below.
Yeah, very clear. And see
That
the
is the
Mike's dots.
yes. That's representing neuroepithelium. Now see, I am in the medial wall of the vestibule to show you something. That's the vestibular aqueduct.
Yeah.
This white structure,
Yeah.
there's a white structure coming from the medial wall and turning here like a J, and this is the endolymphatic sac. Give me a bipolar. I bipolarize this region completely. Hold. Diamond. See my area,
Yeah.
the sigmoid sinus, pre-sigmoid region. See, all plates flushed. No cell is left behind. Can you see?
Yeah, very clear.
Bipolar. Bipolar. Oh, the drill there. See this subarcuate artery at the solid angle.
Good, lovely.
Good. Yes, now. Now, having drilled the vestibule, labyrinth, this semicircular canal, now medial to it is going to be we are going to go to the intra-aortic meatus. Now our limits again, you can see this is the middle fossa plate.
Yeah.
That's the jugular bulb. Behind is the pre-sigmoid. See, this is already CP angle dura.
Yeah.
And laterally is the vestibule. Medial to the vestibule is going to be this is saccular area. And
Yeah.
medial to this is going to be the intra-aortic meatus. This is extra-aortic meatus. This is intra-aortic meatus. See this?
Same plane.
Yeah. So, I'm not cutting that. Now, in order to go to the intra-aortic meatus, circumferentially, we need a good exposure, more than 180 degree, and I will acquire almost 270 degree exposure. So that I can see the canal from inside thoroughly.
Yes.
Now, all bones, entire bone from dura to the intra-aortic meatus canal has to go.
Yeah.
See, there's a huge chunk of bone which has to go to uncover the posterior wall of the canal. Here is going to be the posterior wall of the canal.
Yep.
This entire bone has to go.
For the audience, if you realize that he is drilling in that direction, that circle, so as to skeletonize the internal aortic meatus.
That is my site of the intraortic meatus going to be. See how much of the drilling is required, and very close in next 10 minutes or so probably will be through. See my anterior superior limit, this lateral canal.
Yeah.
मोटी दे यार. I will make the superior trough to the canal.
You're seeing a slight change in color to the bone. Which
Yeah,
is,
yeah, that is dura.
you're coming close to the dura.
This underlying dura. My canal is going to be here.
Yes.
Like extraordinary canal.
Yeah.
Some 37.
Jugular bulb bleeds, 90%.
No, no, this is outside periosteum. Yeah, that one. Nothing
yeah.
else.
Nothing else.
Just outside periosteum it is. You know, bleeding from the jugular bulb is more difficult
Yeah, it'll be very.
than the
You get these little vessels outside the periosteum of the jugular bulb.
Yes.
You must see the cochlear aqueduct somewhere in that region, no, Satish?
Yeah, it is just about the jugular bulb.
Yeah.
And the structure which is closest medial to the aqueduct.
Yeah.
That is the aqueduct. Let me show you.
Clearly see.
The structure which is immediately medial to the aqueduct is the glossopharyngeal nerve.
Okay.
As it comes out of the jugular foramen. That is the aqueduct.
Yes, you can see it clearly. Yeah.
That is aqueduct. See my jugular bulb?
Yeah.
And see how much the thick bone I am drilling. See, once you open the aqueduct, is a strategy in vestibular schwannoma surgery. So that keeps on releasing the CSF.
Yeah. No.
This canal is almost a centimeter deep canal. See, this all bone, centimeter deep bone has to go.
You know what, Satish? I'm very impressed. None of your drill noise is coming across through. How do you guys manage to do that?
None of the drill noise.
We can hear you speaking, but we don't hear the drill noise, and that is very nice. How did you manage?
Thanks to Ben Air.
Yeah.
I am not doing anything. Can you see the canal, prominent canal I am working around?
Yes, yes, yes.
Is superiorly the canal content, superior to the drill.
Yeah.
I am making this inferior trough of 270 degree. See this?
Yeah, very clear.
See the canal?
Yeah, you can see it. You can see the periosteum of the canal very clearly.
I am almost on both sides. I'll go around 270 degree.
Yeah. The whole idea is to expose the canal without injuring the periosteum. So that's what is being doing, and it's done so beautifully.
Yeah, all contents are within periosteum. See my canal contents 360. I'm see 270 degree all around. I'm going.
Yes.
See very clear?
Yeah, very clear.
Making a bigger and bigger trough. Diamond.
Bleeding is slightly irritating.
See my canal? Yeah, doesn't bother. It will stop. Look now. See it has stopped.
Yeah, stop.
Oh, this is the canal with tumor in it.
Yeah, and that's a posterior lip of the IAC.
Yes.
And very, very hard bone it is.
Yeah. This is the hardest bone in the body. See my, how could I reach so fast? Because the maximum work I have done with the cutting bar.
Yeah.
Though it is dangerous.
This, if it was a large tumor, Satish would actually remove the bone between the dura and the sinus too. But here that is not needed.
Yeah, that is not needed. This is not going to the CP angle. Cutting this.
You just need to remove that lip, which is between the posterior fossa dura and the IAC. But it looks very easy, but it's not.
There is.
That is that big lip of bone there needs to be removed.
Yeah. That has to go entire. See, this is 1 centimeter depth canal.
Yeah.
You have to drill 1 centimeter deep. Oh. Bipolar. See the vertical height of the canal
Yeah.
right from here till there 1 centimeter. Medial to lateral.
It doesn't look so deep when you see it on camera, but actually when you do it with 2 eyes, it is really, really quite.
See, if you compromise with the exposure,
Yeah.
you're likely to invite complications.
Absolutely.
How much I am extending, because then my tumor removal will be a cakewalk.
Oh, that is beautiful. That is very nice. You've almost got to the lips.
Yeah. In tumors, in the transapical approach, if you add on transapical, for more anteriorly extending tumor,
Okay.
I would do circumferentially, 360 degree,
Complete.
complete. I will get more exposure anteriorly if the tumor is going far anteriorly towards the brainstem. I won't
Some
mind.
Ronger to remove that last piece of bone. Do you use it?
Yeah, 100%.
Yeah.
A diamond though. See how deep we have gone so far.
Very deep.
Use the largest possible burp for that place.
Yeah.
See the canal below?
Yeah. We are nearly there.
See, I left the thin bone over it. Now I am with the diamond again.
See, the EM periosteum looks white. If it starts looking pink, that means you've gone through it, which is not very good. This is exactly how it should be done. Yeah, the bone is moving.
Yes. See, this is dismantle and I will dismantle from this side as well.
Yeah.
See this bone?
Yeah, that bone is moving.
I am very greedy about more and more bone removal.
Yeah, no. There is no need to compromise there.
Yeah. Wonderful. One size smaller.
That is a coarse diamond I was telling you guys about earlier.
Yeah, coarse diamond it is. It is not a polishing bar, it's a coarse diamond.
Yeah.
See, I have gone beyond 270 degrees. See this?
Perfect.
Hello?
Yeah, very clear. Now actually
Right
you
angle.
can see the tumor. Oh, Satish?
Yes. See, the tumor is dying to come out.
Yeah, tumor is dying to come out.
The last part of the bone.
Perfect.
I told you tumor removal won't take time. Couple of minutes and I'll be through. Fine.
Getting some CSF leak now.
Yeah, I want that to come out. Had I gone to the CP angle, I would go to the cistern and open it.
Yeah.
Let it. See, the total volume of CSF in the body is 150 ml. Let it come out.
Yeah. You need to allow the CSF to drain out from the CPM.
Yes. The patla de do. See, the tumor is coming on its own. I don't need to do anything.
It's getting delivered.
Ye patla de aur. It will come out in a minute. The facial nerve is antero-superior. See this from this orientation.
Yeah.
Posteriorly from my side are the vestibular nerves. This
Yeah.
is antero-superiorly here going to be the facial nerve and antero-inferiorly going to be the cochlear nerve.
Yeah.
Side circular. I am letting the CSF to come out. This lateral bone is the cresta.
Yeah.
With this tumor, I am opening the periosteum from below.
Mm-hmm.
See the intra-aortic meatus?
Yeah.
See the nerve. See the nerve and the tumor. See this tumor.
Yeah.
I told you it will come out in a minute. See, I am right on the nerve, on the tumor. Scissors.
And you can see the cut into the inferior vestibular, no?
See this? इससे
Yeah.
पतला दे. Tumor has fallen out. Pick that. Pick. Then, yeah. This is the intra-aortic meatus inside. Hello.
Yeah, we can hear, we can see very clearly. Very exciting part of the surgery.
Yeah, I'm separating this.
Yeah.
This should be the facial now.
Yeah, the one on top. Yeah.
Yes. And see the most important thing, this cochlear now.
Yeah.
The brightest of all is the cochlear. See, it is involved.
Cochlear nerve is separate, no? It is.
Yeah, it is separate, but see, it is involved by the tumor here, where it has given hearing loss. See that?
Yeah.
Adhered means involved means adhered.
It's inferior.
This is the vestibular nerve behind.
Yeah, behind.
From where the tumor is arising. Can you see?
Yeah, yeah.
Very clear or not?
Very clear, very clear.
This is vestibular now. Now, give me bipolar at the lowest current.
You can see the facial also very clearly now.
Very clear. Don't need to do anything there.
Yeah. You use a CUSA for large tumors, Satish?
Pardon?
You use a CUSA for large
Yeah,
tumors?
yeah, always, always. See what I have done?
Yeah.
I am coagulating the vestibular now. Give me scissors. Why I am coagulating? Because once I cut it, it may retract.
Okay. Oh, all right. Oh,
See the
beautiful.
now surface?
Yeah, beautiful, beautiful. This is why we should not call it an acoustic neuroma.
Vestibular sonoma. Because it arises from the vestibular now.
Beautifully done. You can hear the applause. You can hear it louder, please.
Thank you for your patience. I know your time is, that is the cochlear now. See?
Yeah, yeah.
That
See,
is
in
the
fact, if
facial
you,
now there. That's the
Yeah.
facial now.
yeah. Satish, actually, if you leave the cochlear nerve intact, now people have even started implanting these people if the cochlear nerve is structurally intact.
Yes, structurally intact you can. Yes, you're right. You can. See now?
Yeah,
That
beautiful.
is my intraocular meatus.
Yeah, yeah, perfect.
Now I will take your 2 more minutes. Sarji sir. 2 more minutes before you start your lecture. I don't want to take your time.
We have time. We have time. We
So-
are still on schedule because it is now still 11:23.
Really?
12:23. Sorry.
Oh,
20
we have 7 more minutes. Cut. We have 7 more minutes, so I will finish exactly in 1 hour. See?
Yeah.
Cut.
Surgical on the
Cut end. See, CSF has escaped.
yeah, yeah.
No bleeding at all anywhere. See this?
Yeah, yeah.
Not a drop. Fat fast. Fat. No, एक पतली layer बना. See, I will tell you once you do canalicular tumor, how to efficiently prevent a CSF leak.
Okay.
This is almost now we have long series. Almost I can say 100% you can avoid a CSF leak once you have not gone to the CP angle cistern. बोला वो फैलाने वाले वो glass. I will show you something. Okay, no? So there is, you can see the field absolutely dry.
Very dry.
Now I will show you something. I have taken a sliver of fat and
Okay.
I will compress it and show you.
Mhm.
इधर ला दे. इधर ला.
Even though in textbooks and all, they describe that you should incise the periosteum and resuture, I think it's impossible to do it. I have never been able to.
No point in doing anything.
No, it is completely.
See, this is a glass slide.
Okay.
I am trying to compress this fat. See this?
Okay.
This is another glass slide.
Okay.
Compress it. See this?
Oh, wow.
See this fat?
Mm-hmm.
This is pure fat I have compressed.
Okay.
Okay?
Mm-hmm.
Let's remove it. Come on. Glue. Ready? See, even with the Surgicel and all this thing, no CSF is coming
There's no leak.
now, but it is not a efficient seal.
I know.
So what I am doing, see this flat piece of fat.
Mm-hmm.
I'll wrap all around and put a
Glue.
glue.
Okay, that's nice. You don't
Number
put
one.
fascia underneath. I generally put fascia and then fat.
Yeah. See, once you put fascia, fascia doesn't stuck to the bone so efficiently as the fat.
Oh, okay.
It is more raw. See now. Now
Yeah.
on this, I will put 2 or 3 long strips to compress this.
Okay.
Long strips, 2 or 3. And before that, I'll harvest a small muscle. Give me knife. 2 minutes more.
Absolutely.
Knife. Oh, here they. There. A muscle from anywhere. पकड़ना है इसको. इसको रोटेट कर. दे दो. रोटेट कर. See this?
Yeah.
I'm harvesting a small muscle piece.
Yeah.
This is for editors.
Oh, okay.
Editors always muscle because this muscle swells up.
Okay.
So muscle is something which swells up initially and it will fit snugly into it. Some suggestion.
Why you need to take out the incus before doing it?
That's why. For this efficient sealing.
Yeah.
See, first of all, we have sealed the CSF below. So it is not going to come out.
Okay.
In case it should not give rhinorrhea.
Okay.
See this? I will compress with the Surgicel like this.
Yeah, perfect.
Now I'm waiting for the glue at both ends. This and this, whatever I place, I
Okay.
first place the glue to keep everything in place. See this, both the things,
Yeah.
they will remain in place. This I will place like this and keep some glue. And then I'm waiting for the glue. It may take 5-10 minutes. And then I will put 1, 2, 3 or 4 strips of fat. And then
Okay.
on top, a horizontal piece above it to compress all. So
Okay.
that will be a sort of complete 3-dimensional sealing, not sealing. 3-dimensional means my entire from right lateral cortex till there 3 centimeter.
Okay.
3 centimeter long tunnel will be completely sealed with the fat. It is not a 2-dimensional sealing like you place some seal some there directly.
Okay.
It will be a 3-dimensional all the way 3 centimeter complete tunnel will be packed.
Okay.
It can never give CSF leak. In my practice, it has never.
Yeah, perfect, Satish. Wonderful demonstration. We
That
love.
is what a translab has advantage. I mentioned that you can efficiently seal for the future. See this? See this?
Yeah. So this is what, ladies and gentlemen, what a perfect surgery should be. Complete removal of the tumor, adequate exposure, safety for the facial nerve, and prevention of CSF leak. So you've seen a master at work. So let's give him a big hand once again.
Thank you all. Thank you for the patience. I'm waiting for the glue. Will apply later. You can continue with your, lecture.
Patience. It was like watching Ethan Hunt. Okay. So it was brilliant and we enjoyed it. It was done super quick and I never thought you will finish in this time, but that's okay. Wonderful, Satish. Great.
Thank
always
you. Thank you. Glue is ready. Give me, Manoj.
Yeah.
Just a minute. The glue is ready. Just
Yeah.
last minute. First of all, this fat.
Yeah.
It's so important to keep in place.
Okay.
Number 2, अब लगाना glue इस पे मसल पे glue लगा. Number 2 is this. Compress this. See this? Hard.
Yeah, okay.
And then apply the glue so it will not mobilize now. See this? Lambi strip. Now I will use few strips patli. See this?
Okay.
I can press through it now easily.
Okay.
So it will be a three-dimensional tunnel.
Mhm.
This will be three-dimensional tunnel ceiling. It is not one place or two-dimensional ceiling.
Okay.
All the way, the entire tunnel is being sealed.
Perfect. Yeah.
And now a bigger piece laterally, and that's it.
Yeah. 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 Wonderful.
And see this horizontal piece.
Oh.
So this will be sort of overpacking to keep a
Yeah.
pressure and on the inside layers.
Yeah. Then the periosteum. Yeah.
This will be the final seal. And see, our suturing will compress on it all the way.
You're right. And how long will you keep the patient there, Satish?
2 or 3 days maximum.
And suture removal?
Initially, some patients who had vestibular signals intact
Okay.
may develop some vertigo.
Yeah, they do. Yes.
It may take some time for compensation.
Okay.
So initially, some patients who the vestibular system is already died out, they will not perceive any vertigo.
Okay.
Young patient, they recover very fast as the compensation is very fast. Elderly is a problem.
And what about post-op medication? Would you give an antibiotic?
Yes, give some broad spectrum for a couple of days. That's it. Nothing is required now. It is completely sealed. Forget about it.
Thank you, Satish. Thanks. We'll move.
Thank you.
Thank you, Dr. Satish.
Thank you.
Your surgical skills has indeed kept us all in awe. As a token of appreciation to our esteemed chairs, I'd like to invite Dr. Prakashan, Senior ENT Surgeon, Allied Hospital, Thrissur, to present a certificate to our chairs, Dr. Manoj MP and Dr. Prabhakaran.
And then I was taking the video of tumor in.
Moving on to our next session by Dr. V. Anand. I would like to invite on stage our chairs for the next session. This session will be chaired by Dr. Gautam, Senior ENT Consultant, Kasargod, and Dr. Jayakumar, Director at Jayakumar's Laryngology Group, Trivandrum. We are pleased to welcome Dr. Jayakumar, sir, a very special guest who we have amongst us. He's a director at Dr. Jayakumar's Laryngology Group, Trivandrum. He is also the founder and vice president of Association of Phonosurgeons of India. We are esteemed to have your presence amongst us, sir. It is with great pleasure that I would like to introduce our next speaker. We have Dr. V. Anand, a renowned ENT surgeon known for his expertise in creating a contemporary ENT setup.
Meeting you is always a pleasure, always a learning experience. Thank you so much for being in this session. So, this next case, yes, sir.
Tell us about your next patient. Yes.
Yeah, so this patient is a lady who presented with some, dull headache and orbital, prolapse, proptosis, you can say. Clinically presented with proptosis and dull headache. Somebody did the CT scan. First of all, let me show you the CT scan. And CT scan findings were some soft tissue mass. You can see. Are you getting the CT image, please?
Now we do. We see the axial image. Yes.
Yeah, some soft tissue mass in the medial part of the orbit.
Yes.
If we reconstruct it, yes, this was a mass lesion occupying this part of the frontal recess and upper part of the orbit, medial part of the orbit. Not much information we could get. Then we had another soft tissue window. This was a CT scan. Patient already done before coming to us. See this?
Yes.
This kind of a mass lesion with erosion of the outer wall, superior wall, and prolapsing into the orbit. The orbital roof was completely dehiscent.
Yes.
Now, with a CT scan, you can't differentiate into soft tissues. CT gives you bony details. Soft tissue, it can give you just an opacity. It could be mucosal, it could be soft tissue, it could be benign tumor, it could be malignant tumor, vascular, non-vascular. It can't differentiate. It can just give you a soft tissue opacity.
Right.
So the MRI was done, and it was interesting to see certain findings on MRI. See the MRI.
Yes.
This is fat suppressed T2 weighted imaging. Fat suppressed T2 weighted imaging suppresses fat everywhere, and whatever lesion, it has become prominent. This T2 weighted imaging, can you see this?
We see it.
Alternate, bands of alternate hyper and hypo intensity into the region of the frontal sinus. See this?
We see that. Yes.
These alternate bands of hyper and hypo intensity, we always look for cerebriform convolution pattern. We call that cerebriform convolution pattern. That is suggestive of inverted papilloma. Though inverted papilloma is a pathological diagnosis, but there are certain features of inverted papilloma which gives you suspicion on radiology. That could be inverted papilloma. And one of them is these kinds of alternate bands of hyper and hypo intensity. The reason being, inverted papilloma arises from the surface, and as it grows, the epithelium grows into the stroma. So these kinds of patterns of, alternate bands. This hyper intense band is inflammation, hypo intense band is tumor. This inflammation of the mucosa and the tumor. Tumor and mucosa in between like folds. This is what inverted papilloma is, and it looks very better on T2 weighted. It is much better on larger tumor than the smaller ones, and then you can confirm on contrast as well. So this was the initial observation we made. We don't know whether it is papilloma or not, but there was nothing in the nasal cavity. On endoscopy, everything clear. No finding on endoscopy, no any positive finding, I mean to say. And see, this lesion is typically occupying the anterior part of the ethmoidal cavity. That's the anterior ethmoidal cavity. And frontal recess, the outflow of the frontal sinus, that is anteriorly the frontal sinus, and then it is prolapsing by means of eroding the superior wall of the orbit into the orbit, but maintaining the planes.
Right.
Maintaining the fat planes.
Seems extraperiosteal.
Yes, it is extraperiosteal.
I
It is
agree.
extraperiosteal. So now let us see on the certainly more important findings on contrast. See this. Alternate bands on contrast. Alternate band, this is classical of cerebriform convolution patterns. And see, this periosteum looks intact. The periosteum all the way looks intact. So it is because of the obliteration of the frontal outflow, this lesion is expanding more and more. towards the thinner wall which it could have eroded, and that is the superior wall of the orbit, and that's how it is, prolapsing into the superior wall of the orbit, presenting as a proptosis. But the planes are intact. See, the superior rectus muscle, medial rectus muscle, superior oblique muscles, all are intact, and it is extra periosteal. Now, some more information from the sagittal plane. This is most important section for this particular patient. And what we see here, see the convolutions pattern?
Yes.
The best part of the MRI, it gives you a sort of idea about the diagnosis that could be papilloma by means of this CCP. The CT scan cannot give. And secondly, if you trace the CCP, you can have a fairly good idea where it is attached to. So what we can see, yes, sir.
So what you see out there, that the bony plane between the cerebrum and the frontal sinus is violated at one point.
Yeah, at
Does
one
that
point,
cause
yes,
a concern?
Yes. At this point, is it violated and looks like it is attached to the posterior table there.
But it's very possible posterior table just eroded because of pressure.
Yes.
But it's something
Could
you
be.
notice.
Could be.
Connected, though the two, of course, have different attenuation, so it's likely not to be so. But that's a small point of concern.
Yeah. Now see this CCP if you follow. CCP if we follow, they're emerging from here. So this is one possibility that this lesion is attached to the anterior ethmoidal cavity, or could be this is the level of the bulla ethmoidalis above.
Right.
So see the CCP extending. So CCP, either it is attached there or attached there going up, could be any possibility. Now, in papillomas, this being a benign tumor, this is a classical picture of giving me a strong suspicion of papilloma because of this classical CCP pattern. Now,
So we haven't done a biopsy, but based on the radiological findings of this stria that you see,
yes.
you believe it is likely to be an inverted papilloma. And
Yes,
of course,
and see there is
behaving
no
like a
mass on
tumor.
no mass on nasal endoscopy in any no mass in any sort of in the nasal cavity or anywhere to take a biopsy.
It seems the agar nasal are involved. I mean, it's coming fairly far anterior.
Yes, far anterior. So now
Yeah.
we will take a we have a frozen section facility round the clock. So once we get onto the mass, we'll take this for frozen section for immediate reporting. We get in 20-30 minutes the idea of the what it could be on frozen section. Now, in inverted papilloma, assume if it is an inverted papilloma, there are certain concerns. Inverted papilloma is notorious for two reasons. Number one, it is notorious to recur. And number two, it is notorious to turn malignant in certain percent of the patients. Now, if you go in the depth of these two things, first of all, to me, this is a benign tumor, and like any other benign tumor, if you remove completely, it cannot recur. As simple as that. Like JNA, if you remove completely, it cannot recur. But if you leave behind even the smallest portion in the bone or somewhere, it is likely to come back as a bigger mass and more notorious lesion.
True.
Sir, I give your reference of your study you published in Head Neck Journal in 2016 about the JNA infiltrating the Vidian canal. I
Yes.
give your published papers reference everywhere, and you had almost 40% patients of JNA invading the Vidian canal.
Yes, more than that, more than 80, I would say.
Now, if you go back in the retrospective area where the open approaches were prevalent, what you do in open approaches, you remove the tumor grossly, gush of bleeding and pack and come out. And actually, you don't have anything to look into the nooks and corners where the tumor can go. And even a small sliver of the tumor left behind is going to come back and termed as a recurrence. It is never a recurrence, it is a residual tumor which has grown back. Now with the endoscopic facilities, endoscopic development, we see under vision, under magnification, bright illumination, wherever the tumor is going. If it is going into the pterygoid, it is going in the Vidian canal, we can drill out the pterygoid easily and remove the tumor completely. And that's why the endoscopy is a better outcome, less chances of recurrence. But this recurrence is a so-called recurrence. It is never a recurrence. It is a residual tumor which has been left behind. And that tumor has a propensity to invade the cancellous bone, the Haversian system of the bone. Similarly, in the papillomas, what I mentioned, if you go in the depth of these two findings, what I mentioned, one is the recurrence and one is the malignant transformation. So this recurrence is never a recurrence. This
No, it's
tumor,
always a
wherever it is,
residual. We agree with that one, that what you find out here is a residual tumor. It's not really a recurrent tumor. And
Yes,
the
sir.
previous techniques did not quite allow us the surgical finesse to work at the skull base. And maybe that's why recurrences were more. And today, as you said,
yes.
So-
Yes, sir.
so you're getting ready for the operation.
Yeah.
We discussed these scans. And I saw those muscles, but could we also see the superior oblique? I mean, you mentioned that you could see all those muscles, because my little concern, if you take
Yeah.
the coronal scans, I'm just being the devil's advocate, I'm sure you will, but if you do the coronal scan,
Yes. Yes.
so this angle of small, immediately you see the orbit going up, the fat of the orbit sort of going up between the tumor. As you see the tumor go up into the frontal sinus, and then the floor of the frontal sinus is dehiscent, and the tumor prolapses in.
Yeah.
And my little concern is that this little nubbin of orbital fat that is sort of going up may actually include the trochlea and this superior oblique.
Superior oblique.
And so you might find the superior oblique come in your way as you sort of start to work.
Yes.
That's a bit of a concern there. You see that? Is that the superior oblique that we see?
100%, you are right. Now, what I'm planning, what we generally do this for many of such indication is the orbital transposition, which I'm going to demonstrate.
Right. So you would push it down. You'd push the whole.
Yes, I will push it
down.
laterally and down.
Lovely. It's going
Laterally
to-
and down, and we'll have a thorough access from here to there. I'll have a
And
thorough
are you-
access. I'll have a thorough
planning a
access
Lothrop?
like this.
Mm-hmm. So that's a Lothrop you're planning from the contralateral side.
So I will do a draft 2 on this side, and
Right.
then do the orbital transposition, and then everything will be in front of me. If I need more exposure to go laterally, I will go transeptal with my endoscope to get more, visualization and more instrumentation.
Because the conventional technique, the conventional limits of endoscopic surgery were that if you had a tumor which was going
Yes.
lateral to the infraorbital nerve
Yes.
or the middle orbital line or the pupillary line, then
Yes.
it was difficult to access. But of course, the world moves on, and but it is a challenging tumor. It's a challenging
Yes.
tumor. I don't deny that at all.
So now,
Very
sir
challenging
is
tumor.
right. Earlier, it was used to be considered that the tumor beyond the line of the lamina papracia going laterally, like this line, anything beyond is difficult to address endoscopically. Now, with the development in the science of endoscopy, equipments, angle debrider, angle instruments, angle telescope, the navigation system, people have started tumor, and now it was considered that any tumor lateral to the mid papillary line are difficult to, address. Now, with the advancement, we have addressed even tumor reaching up to the pterion with the orbital transposition, transeptal approaches, modified Lothrop's approaches, and so on. And this is the classical case for a orbital transposition with draft 2.
It is challenging, both because it's going
Yes,
to
it is.
lateral and because it's very anterior.
Yes,
And
yes.
the endoscope is challenging in both these situations. But of
Yes.
course, you have the master here to show us how to do these difficult situations.
Now,
Very,
the
very nice.
challenge is our multi level in this situation, for this situation, for this case. And that's why we divide the papillomas in 2 categories, the favorable and non-favorable. And to me, this is non-favorable category. The reason being, as I was saying, for papillomas, they cannot recur unless you leave behind in the bone where they are attached to. So they have again the tendency to invade the cancellous bone and enter the Haversian system, and you have to drill away the underlying bone. If you remove the underlying bone thoroughly, you can give a cure. Now, favorable are those tumors where it is easier to remove the underlying bone. Like, let me give an example. I call those tumors favorable, like this case. Let me give an example. Yeah. See, if the tumor is attached to the medial wall of the maxilla, you can do a Denkers and remove the entire medial wall of the maxilla. It is favorable. If the tumor is attached to the anterolateral wall, you remove the anterolateral wall, you can give a cure. If your tumor is attached to the lamina papyracea, you remove the lamina, keeping the periorbita intact, you can give a cure. If the tumor is attached somewhere to the terminates or septum, you can remove that. You can remove and eliminate the attachment. What I mean, those are the favorable sites. Now, in situation where tumor cannot be, the underlying bone cannot be eliminated. Like in the last webinar, in the LChem webinar, if you have seen, I demonstrated one tumor which was attached to the walls of the sphenoid inside, in and around the, onto the carotid canal, optic canal, everywhere. That was again for the demonstration, last one. And I had to drill over the carotid and remove the underlying bone of the carotid canal, keeping the periosteum intact to give that patient a cure. And that is so difficult, and we call it as unfavorable because it's not all that easy for everybody and every time. So similarly, this frontal sinus involvement is an unfavorable tumor, particularly if it attached to the anterior wall. Suppose this tumor is attached to the, we showed in one of the webinars, if this tumor is attached to the anterior wall, it is difficult to address endoscopically, and then obviously you need to take the help of some outer approach like minimal trephination or some sort of osteoplastic or whatever. So unfavorable is the anterior wall attachment. The overall frontal sinus involvement and the skull base involvement is unfavorable. This could be attached to the skull base also here. So that is unfavorable, and because if you try to remove the skull base, you have to be ready to resect the skull base, and you may get a CSF leak and ready to repair and seal that as well. So that makes the surgery more complex, chances of complication very high, and that is called unfavorable. So this tumor is unfavorable to me, and that is the biggest challenge besides the challenge of invading the orbit. Yes,
So
sir.
because it's unfavorable, have you considered an open approach?
Yes, we have told the patient, in case required, we may do a trephination, an additional port for instrumentation, as well as the telescope insertion, you know.
Because, I mean, there are a couple of other challenges too. A, of course, it's a very deep keros. That should not be such a big problem, but something to take note of. And B, I think it's anterior to the anterior ethmoidal, but do we have a CT which can sort of show us as to the relation with the anterior ethmoidal?
Yeah, it is anterior to the anterior ethmoid for sure. That is hardly an issue, because this is anterior to the anterior ethmoid, and that doesn't matter. I will coagulate the anterior ethmoid in case we need to transpose more.
It is, yeah, it is anterior. If it is anterior, that's okay.
Even if it is not, I may coagulate that. That is something not a concern to for the decision making. See, this is anterior ethmoidal,
Yes.
and the tumor is far anterior to it.
Yes. No, I mean, if it's in the tumor, then you get into trouble. So I mean, it's separate from the tumor.
Additional, yes. But
So-
since we are opening the orbit, so it should not be a
planning there.
problem.
Perfectly
Yes.
planned. Lovely.
Yes.
So let's get on. Let's get on with it, because unfortunately the audience will move out for lunch unless you sort of show them some surgery.
And the last concern,
Yes.
that you cannot rule out 100% in malignant transformation.
No.
Though on MRI, it doesn't look like malignant transformation, because wherever the malignant transformation is, the center starts necroting and losing this, lamellar pattern, this CCP. So it doesn't look like turning into malignant, but she's being lady approaching 60, and the location and the destruction of the wall to a different compartment all may go in favor of a malignant conversion. So that is a histopathological situation. In case it is, then it will require an additional treatment later on as well. But the chances, for me, my gut feeling is it has not transformed into malignancy so far.
Excellent. And what are we doing in terms of pre-op preparation?
Pre-op, we have given her just antibiotic, nothing else. Because for tumors, there is hardly anything for the, as far as unlike sinus surgery, for preparation. But yes, we have given antibiotics for any additional inflammation which may have, may have been associated.
And your anesthetic plan, what do we do for anesthesia? Do we use Tiva? Do we use hypertensive? Do we use
Hypotensive anesthesia for this patient. For FES, we don't use hypotensive anymore these days. Normotensive with less cardiac output by reduced heart rate. But yes, for tumors, always hypotensive anesthesia. This lady had been on anticoagulants as well earlier, which have been stopped few days back. So though the PTINR, all those coagulation factors are normal, but that is again another concern as compared to the, other cases. I may expect little more, I would say, additional bleeding.
Okay. So paradoxical middle turbinate there.
Yes, paradoxical middle turbinate. Yes,
You
sir.
have packed with Merocel initially and now with Gauss pack, I see.
Yeah. So since
you're
this is
using-
not as, yes, sir.
We're using topical adrenaline, I'm sure.
Yes, sir. Since this is not a sinus disease, mucociliary clearance is not the issue.
No.
Reduced local immunity in sinus disease, which is the issue, is not here. So I'm not concerned with that and using, being a tumor, these Gauss packs, which are more efficient than the Merocel packs for overall,
Yes.
field. See this?
So that's 1 in 10,000, 1 in 1,000, 1 in 5,000.
No, this is 1 in 4,000 for this particular patient.
1 in
There's an
4,000.
elderly patient had some issues earlier. I don't know for what reason.
No,
She
no,
had
I
been
think
on
1 in
the-
1,000 can give problems. I agree. We tend to use 1 in 10,000, frankly, in our practice.
Yeah. And now see, this is high deviation.
Hmm.
Though in this case, I am going to resect the middle turbinate partially.
Hmm.
Let's see how it works out. That will be. In the first case of sinus surgery, I had shown you a limited septoplasty for the high deviation.
You might need one here again, it seems, for access.
Yes.
It is a challenging patient. She's also on anticoagulants, you said.
Yeah, earlier we have stopped couple of days back. So I'm expecting a little extra bleeding. So we are prepared with that. Now this is the turbinate, and I have already told you we have already decided for a planned resection, partial resection.
Right.
Anyway, we are going to do the draft. We need more, extended approach to the orbit. So this is going to go.
So that's the coablator coming in and, of course, coagulating the anterior end of the middle turbinate.
See, this coagulator helps in reducing the bleeding, mucosal bleeding.
And you're using coagulation mode now, I guess.
Yeah. Just see some mass in the ethmoidal roof.
Yes, we of
Coming
course
from the ethmoidal roof.
we see the tumor prolapsing into the anterior ethmoidal area.
Yeah.
The patient's about 60, wasn't she? Patient's age.
Age? Age is 60.
Okay.
I don't know. See, this is initial.
That's a curved microdebrider blade you have there.
Yeah. This is for initial, this mucosal debridement. So every time you can pack the same packs to for surface packing to reduce the bleeding. And they are
Yes.
safe. We never, sir, we never infiltrate in the nose for any regions for the fear of systemic, dissemination. Stop this years back. So the challenges are extra bleeding, elderly patient not using the pure adrenaline as a topical, no
Hmm.
infiltration.
Yes, there are challenges, of course. It is, we appreciate this, how difficult the patient it is that you have taken on. I mean, I think I can see the uncinate there, and it seems to be, of course, medial to the uncinate and coming in out through the hiatus. The tumor seems to be prolapsing out through the hiatus. Hiatus semilunaris is prolapsing out through the hiatus.
Sir, this is the tumor,
Yes.
and I'm taking this frozen clip.
So as I understand, you're using a two-surgeon technique.
See,
I see a suction there.
yes.
Someone else is holding the scope for you, or someone else is holding the suction for you.
No, it is me only who is holding the telescope right now,
Right.
but we may interchange in case required.
Do you
See,
have an
this initial
Yes.
tumor I have taken sending for frozen first.
Yes, I see that. So lovely.
So
We have
phone
taken
kar
the
dena.
tumor sent for
Phone karwa de.
frozen, and we'll continue to work.
And we'll get the report meantime,
Yes.
Sir, we have here round the clock frozen facilities available.
Which is remarkable. It's very nice. In-house, eh?
In-house
It only
means
speaks of the
we have a tie-up with the center,
yes.
gives us round the clock. And I have a habit of operating in the night, so it is a luxury for me.
If it's your passion, that's what you do, day or night. Eh?
So this is the initial, part of the access so far. So, no?
So I'll just recount what he has been doing so far because some of you were away for lunch. But basically, he's clipped the anterior end of the middle turbinate. He's coagulated part of the septum, and because there was a DNS which is, he's taken a part of the tumor which is sent for frozen. And what you see out there is a little bit of the tumor in the roof of the middle meatus, and what you also see is the uncinate process. Uncinate
I will,
very well seen.
yeah. Now I'll carry on further.
And are you
Also, the
using
middle
a 0
meatal
degree scope?
Pardon?
You're using a 0 degree scope, I guess.
So far 0 degree. Whenever
Yes.
I'll change, sir, I'll intimate.
So now what he has done is that he is using the backbiting forceps to cut the uncinate at its middle segment in a retrograde fashion. And with the ball probe, that's the horizontal portion of the uncinate being medialized. And the ostium of the maxillary sinus coming into view.
This is the middle meatal antrostomy.
Yes.
Since we have to do an orb work, this middle meatal antrostomy always is something which will keep me orienting. So this will prove to be a great landmark in this situation. Public. This middle meatal antrostomy will serve as a great landmark.
Yeah, it tells you where you can anticipate the floor of the orbit. And I notice that you like the curved microdebrider. You haven't even started with a straight microdebrider, which is nice.
Sir. So that is your maxillary sinus.
Yes.
And now I'm taking away this upper part of the uncinate with a debrider only
Lovely.
to get on to the lamina peperacea. See, this is very close to the lamina. That is the mass.
Yes, the tumor being removed by a microdebrider as he moves up.
Yeah, to get more space. See, this is what the mass which
Region
is
of frontal recess, because
Yeah,
as you know,
the-
bulla is still intact. In fact, you seem to be getting rid of the suprabullar recess.
yeah. So it was just prolapsing down, not attached anywhere here. See, in papillomas, we have to keep an eye on the attachment. Whatever luminal component which is prolapsed, you can just debride. That has no value, but the attachment has significant value.
As you said, if you are to not leave behind a residual, you have to find the attachment and remove it. So you think you're on the lamina papyracea there, where you are using
this is on the mucosa.
You can actually see it
Yeah,
papery.
this is lamina. This is lamina only.
It feels like the lamina.
Yeah. You can see the ballotment even.
Lamina
You can
papyracea.
see on ballotment even. See this lamina.
Yeah, so that's the wall of paper or the lamina papyracea, which we saw. And the anterior ethmoidal should not be very far away.
Anteropoidal is at the roof, so I'm still away from
It's
that.
behind the tumor. So as long as you see the
Yeah.
tumor, obviously you know it won't be there. But there seems to be a suprabundal.
Yeah, so give me a pack. See this. This is my bulla ethmoidalis.
Okay.
This extra bleeding I'm anticipating in this case, and we will handle it our own way.
Given the circumstances, I think it's not bad at all.
Yeah.
I mean, the patient has been on anticoagulants, and the age of the patient, which certainly limits how much they can do in terms of anesthesia to limit the bleeding.
Now I will acquire some more space. Straight debrider. Wash. Straight. Wash. Straight. I'll remove this bulla to get more space.
Yes.
Once I get full exposure, I will control the bleeding then efficiently. Meantime,
Once you remove the bulla, you can get behind the tumor and possibly access the anterior ethmoid, which might actually be the supply to this tumor, and that might make a job quite simple.
see this lamina now much better.
Yes, so that's the bulla coming off, and you can see the lamina papyracea laterally. Bulla comes off. Yes.
So I am removing all this to improve my exposure.
So this is only mucosa. This is not tumor in the bulla.
Yeah,
no?
this is not tumor. Tumor is not anywhere lower down. Tumor is coming from above.
Yes. So that's the bulla coming out. Yep.
Yeah,
Lovely.
I am in the post-ethmoid directly.
Yes. Which is all virgin.
I want more and more space. And immediately after that, I will remove this to do a draft to marsupialize the frontal.
So you basically want to get at the skull base posteriorly and then come forward. That's the strategy you seem to have there.
Yes, that is the skull base behind.
Lovely. Beautiful.
See the lower part of the ethmoids, everything clear?
Yes, perfect. Lovely.
There's nothing, but
So you see the lamina papyracea on your left. You see at about 9 o'clock, you see the lamina papyracea. At about 11, 12 o'clock, you see the skull base and the posterior ethmoids. And now he's coming forward. And we can anticipate that he will soon see the anterior ethmoidal artery.
वॉश करता रहा पूरा टाइम फील्ड खराब है सक्शन में
Lovely operation, Satish.
I hope the picture is good.
Yes. Lovely.
Now see this axilla. I am taking off. See all this axilla I am opening up.
Yes. Okay. The
As my area of interest is above. See this necrotic component coming. As my
Sorry.
frontal recess is little widened,
Right. You're still using a 0 degree, of course.
yes, so far 0 degree.
Yes. Because, yeah, we aren't that far anterior anyway. So, yeah. So somewhere here we should see the anterior ethmoidal artery, I would believe, where you're working. He's exploring carefully. He's careful here for the obvious reason.
See, this is all frontal recess, but no
Yes.
tumor is attached. So far, it is all prolapsing into it.
Only prolapsing. I love that. Yes.
This is the mucosa.
See behind the frontal recess, is it the
See, this
anterior?
mucosa I am taking to give me a good plane.
I see that. Yes.
That is the region of the anterior ethmoid. See, anterior ethmoid is there.
Yeah. That is anterior ethmoidal artery. That's what you're
Yes.
saying. And it's a.
See, and I am working far anterior to it.
Yes.
This is all tumor.
But do you want to bust the anterior ethmoidal? I'm just asking. I'm not
See,
saying.
this is all tumor.
I would
Tumor in
have.
the superior part of the orbit. See this?
Yes, I see that.
But I will not remove from here. I will get a more exposure by means of a draft and then do something like, see this? All frontal recess is cleared.
You are denuding and it's lovely.
See, from lower down up, there is no tumor lower down. The frontal recess is widened itself by the tumor.
Agreed.
See, about this frontal recess is widened
This
above by
anterior
the tumor.
working a bit. The anterior ethmoidal artery.
Anterior ethmoidal artery is there behind.
Yes.
See this?
Working a bit.
Yeah. See, this is anterior ethmoidal artery.
Hmm.
And it is quite behind. See, above the tumor, which I don't want to remove right now. I'll marsupialize this part of the sinus so that I can remove head on.
Okay.
Under vision head on.
Perfect.
Knowing the fact that even a slightest of the bit of the tumor, if it is left behind, it is going to come back. And those recurrent tumors, she is already 60. Recurrent tumors in elderly are more likely to undergo malignant change than the primary tumors in young patients. So we have to be
So you're
extra
packing
careful.
hemostasis. I would agree with that. You're packing to get.
And more than that, another information, this lady is a smoker.
Okay.
Because if you analyze the malignancies, one of the strongest point in inverted papilloma turning to malignancy, the smoking is one of the biggest factor.
Yes.
Cavity के लिए दर्द बड़ा था. See this? Now I'm packing this cavity for a while. See this?
That's nice.
I'm
Yes.
packing this cavity for a while until I do a draft.
Okay.
So that will take care of my oozing and everything. See this?
Yep.
Now the field will be good. Stop there. This will automatically, in meantime, will make the field very good. This part I have done quickly as it is.
So this is your middle meatus, of course.
Yeah.
The maxillary sinus ostium and the maxillary sinus that you can see there. And
Middle
the base-
meatal antrostomy. This is lamina papricia for your orientation. The frontal recess tumor, which has been, we have little bit debrided, and the rest of the ethmoidal cavity is absolutely clear. See that?
Perfect. Very nice.
So this part I intentionally did fast to reduce the overall, bleeding and unnecessary time. You can save time in less important areas and spend on more critical areas.
So you want to do a transeptal now? You want to?
No transeptal. I will first go up and then
Right.
do a draft.
You want to do a draft 2?
Yes.
So, I mean, we already have a draft 1 from the From the lamina
Yes.
papillacea to the middle turbinate, you have already exposed the
Yes.
frontal sinus
So
area.
now, for my draft 2, I will show you the steps. It's very straightforward surgery, very surgery in the safe region if you follow the landmarks. So what I am doing, using the cobbleator, I am, I will sacrifice this mucoperiosteum
Hmm.
on the beak
Okay.
till the roof of the nose and coming a centimeter anterior to the axilla. See this?
So basically, the origin of the middle turbinate is coming anterior to it, which
Yes.
is where you expect the agar nasal cells, and the tumor was there. And he's coming on the lateral wall anterior to the middle turbinate attachment, 1 centimeter anterior. And from here, you will enter the agar nasal.
Yeah. Now see, this is roughly my area of interest. And I'll expose this bone by removing this mucoperiosteum. See this?
Yes.
Now I'm using the cutting mode.
Okay.
See,
So you coagulated, and to remove the mucoperiosteum, you're using the
first I coagulated to reduce
Cutting
the
the-
bleeding.
yes.
Now I'm removing this mucoperiosteum. See the roof level
Hmm.
and uppermost part of the septum as well.
Okay.
See, anterior is the safest region.
So anterior to the middle turbinate is very safe, of course. There can't be any olfactory cells anterior to the.
Yeah, and before that I will show you my posterior limit. Until that, I can play around like anything. The posterior limit is the beginning of the olfactory area. And that is demarcated by the certain landmarks which I am going to share with you and show you. The brighter.
So you can see
Let
the
me
middle
show you.
turbinate there. You can see that he has coagulated with the coablation, and you can see that the lateral wall of the nose anterior to the middle turbinate attachment has been removed. The mucosa has been removed, and now he's using the microdebrider. Again, removing more mucosa on the septum.
See this?
Yes.
Can you see something
you
coming?
see
This
the
is not the
first
olfactory
olfactory-
neuron.
You see the first olfactory neuron there.
No, that
So
was
very
not the olfactory
nicely-
neuron. That was the branch of ethmoidal artery. And now
No.
this lateral opening anteriorly is a
Yes.
branch of ethmoidal artery. And now,
Okay.
as you go behind,
Yes.
see this, the medial opening, this medial opening, that is the region of the olfactory fibers coming out. Can you see?
You have very nicely elevated the mucosa circumferentially, or let me say, to be able to make this elevation.
See this? And that is going to be the region of my posterior limit. See that?
Yep. Yes.
So this is how I will direct my, cobbleator. Anterior to that, I can play around like anything without any, fear. My limits will be skin all around anteriorly.
Okay.
See this bleeding coming from the bone. Never try to use cobbleator over that. Otherwise, it will ruin the wound.
Sorry, say it again. Bleeding from the bone. You see,
Never try to use the cobbleator. Otherwise, it will ruin the titanium tip of the wound.
Okay.
You should not use cobbleator on the bone. If you have bony bleeding, either I will use a monopolar, insulated monopolar, or you can use a dry diamond. See this? Insulated monopolar. Because this is the safe zone. I can use monopolar here. See this? This is beak only.
Yes, we see that. So you have controlled the bleeding on the bone.
Because I am not on the skull base, so I can use like this. Okay?
Yep. Lovely.
See now, the bone to be removed is being exposed. Draft is always, almost every day, a part of our OT list. So we have our fixed steps for the draft.
Okay.
Now see, this bone, imagine, the moment you remove this bone, the entire frontal sinus will be marsupialized. I am working all the time with a 0 degree only. For that matter, I have not changed the telescope yet since beginning. Can you see this? The beak, which is the obstacle?
We
The
see
frontal
that.
sinus is behind this beak. Once we drill this beak, our frontal sinus will be uncovered. So this surgery is like marsupialization, after which the frontal sinus will directly drain into the nasal cavity. See this?
Yep.
Now,
we see that.
the surgical, yes. See now, this is the frontonasal process.
Do we have a pointer? Yep. So now you got your drill, and
This is my favorite Medtronic stylus 15-degree coarse diamond. See this?
yes. So 15-degree angle drill, coarse diamond drill.
Coarse diamond. See this coarse diamond? It has irrigation system. See now I have started on the frontonasal process. Now the first part is for everybody, for junior colleagues, first part is to define my lateral limit. See, I have started anterior to the axilla. See this?
Yes.
And then first I will define my lateral limit as I drill through the thickness of this bone. You will find the outside periosteum coming in picture as a change of color. I will show that.
So he's drilling in this area, and the idea is to drill right till the laterally till the skin. We are now anterior to the lamina papyracea.
Yes, anterior now above the lamina. And soon you are going to appreciate the change of color. See this change of color.
See the change in color?
Yeah, give me that cobbler to remove this and to show you. See the change of color?
Yes, we see. We can actually see the bones very thin.
So that is my anterior limit, lateral limit.
Lovely. Yep, we see
Now,
the very thinned out bone. Just like we see on autology when we get very close to the dural plate, the very similar appearance you see here as the bone is
I am
thin.
running this drill at a speed of 60,000 RPM.
Lovely.
And this is diamond burr. So safe. Now see, keeping this lateral limit, keep on removing the entire bone medial to it. And keep on going at the same time laterally, anteriorly. This operation is being done in the safest zone of the nasal cavity.
So because
the only thing is you have to define the posterior limit. In the lateral limit, even if you worse to worse, go through this lateral limit, you can give a buttonhole, you can suture. See this lateral limit?
Yes, we see.
This is outside periosteum.
Yes, we can see that.
See this ballotment from outside?
Yep, you can see you pressing there.
Yes.
Lovely.
So follow
we have
this and keep
confirmed
going
it.
anteriorly.
And going superiorly. Yes.
Yes.
So now you're so far forward that you're not worried about the dura at all. And you can just keep going up and up.
Yeah, yeah.
No,
I'm
you're at
going more and
frontal
more
peak.
away from the dura.
You're anterior to the frontal sinus ostium.
Yes.
All you have to do is to keep going up, and you will enter the frontal sinus.
Yeah. So what I was saying, those junior colleagues, this is the safest zone where I'm operating now. Don't think draft is a difficult procedure. Only thing is you have to orient. You have to have a good drill. Practice on cadavers a few times.
You continue to work with the 0 degree?
Yes, always. The entire surgery will be done with 0 degree only.
Because I tend to take an angle scope at this point.
I will show inside if needed with the angle scope.
Yes. Lovely.
The beauty of this coarse diamond is it cuts like butter. See this?
Yes. So a coarse diamond burr, because it cuts well and it doesn't bleed. Doesn't damage the soft
The best thing is it is so safe.
So it stays anterior to the posterior limit that we had defined.
What are you using? Give me a calculator. What are you? Fine. See, we
Beautiful.
are doing everything with 0 degree only.
And you have this back posteriorly where the frontal recess was.
Yes,
So you know
this
that
was,
you're anterior to it. You know you're anterior to it. That itself is a posterior limit.
that's a guide. Again, my lateral limit is in view.
So just when we were sort of ages ago, we were doing external ethmoidectomy, we were told to stay lateral. Similarly, now when we sort of come in this area, we stay lateral because lateral is safe. Lateral is safe. You can see the skin of the nasal. You can see the skin of the medial canthal area, and as you go forward and you stay lateral, you are safe because, of course, the cribrium of plate is medial.
See, I'm drilling this more than a
Seeing
centimeter
lateral to
thick
middle
beak.
turbinate. Yes. There is lateral to middle turbinate, and he is anterior to the first olfactory neuron that we had identified. He is anterior to the frontal recess, so everything is safe.
Wash. See this frontal inside?
Yes, yes. We can now see the tumor again coming through as you go higher and higher.
And this way I will come anteriorly to the anterior skin. Would be my limit.
Say it again, sorry.
I will come anteriorly until I reach the anterior skin.
Yes, yes.
That will be my limits. Now, anterior to the middle turbinate, I am turning laterally as well.
He's entering the frontal sinus now, and you can see tumor as he goes up. You can see a little bit of tumor coming through.
Let me orient you. Suction. See this? This is the middle turbinate attachment there. See this?
Yep.
I have removed this entire beak. And see, I am in the frontal sinus proper.
Perfect. Lovely.
See this?
Yes. And again, you seem to have tumor which is unattached. I mean, you see
Yes.
the frontal sinus mucosa and tumor filling the frontal
Give me,
sinus.
give me the
So that's
40
good news.
divider. 40, give me red 40. Give me cobbletter first to improve. So I am in the frontal proper. I have to drill a lot of bone to improve my field.
Lovely operation.
What a tool cobbletter is. Now see, that is your frontal. Can you see?
Yes,
That is the turbinate. That is the attachment of the turbinate here.
middle turbinate attachment, agreed.
And I am anterior to the attachment of the turbinate.
Yes.
In the true frontal sinus, that is mucosa.
So
See, this
basically,
is incipiental secretions.
is it secretions or tumor?
Yeah, this is incipiental secretions.
Okay.
Okay, give me 70 degree to show you the depth. Because still a lot of, curved section there. A bone has to go.
These secretions are not the pink tumor that we had seen before. These are more creamy yellow.
See the
Yes.
secretions.
Yes. Does it seem like allergic fungus?
No, doesn't look it.
Maybe
It's
it's
just
just
because of
infiltrated.
the blocked access. Blocked. blog. See this?
Yes. Will you send this to
Wash.
pathology too?
Wash, give me a wash to flush them. And sometimes I use hydrodebrider in the frontal recess. Sometimes you have an insipid secretion, allergic fungus, or something like that. See, there's a lot of material.
Yes. So you're washing it out and all of this debris is coming out.
Yes, to give me better orientation. See
Good
all
news
these debris.
Good news for the patient that it's not a tumor but debris. Hmm.
See this? All debris.
Yes, which is good news. Yes.
Now, look at the shut up. Done. Shut up. See this?
Yes.
This is the material which is lodged in the orbital roof. See this?
It is lifting off, which is nice. Yes. Are you pressing the orbit to mobilize it? You don't need to.
Yeah, I will. See now the inside of the.
Frontal sinus, the posterior limb. Yes.
Yeah, let me widen it first. Give me the drill. 0 degree. Back to 0 degree. I hope the picture was good.
Lovely. The world has come to expect very high standards from you, and we are living up to those standards. So everything is perfect.
All your blessings, sir.
Not me.
I'm your ardent follower. Now, once you do a draft, try to
Yeah.
complete it to prevent post-operative issues.
Yes.
Wash karwa.
Because though it looks so good now, you must realize that all of it is denuded bare bone, which will obviously
It
go
is
into
upper part of the septum.
Yes. So now he's drilling.
And see,
medially.
I see my olfactory neuron are there behind. See this?
Yes.
So I can
Anteriorly
trim this bone as well
so anteriorly is safe. Yes. Good.
to give it maximum widening.
Hmm.
This is upper part of the septum, which is the thickest part.
So the medial part he's drilling now anteriorly, and he's sort of connecting it to the septum.
Yeah, and this is the anterior part further.
Hmm.
This I will go until I get the anterior skin. See this is skin. It's
Yes, yes.
turning anteriorly.
Yes, we see that skin. The brownish tinge, pinkish tinge that we see there. The periosteum, really. Yes. So Dr. Jain said a very important thing. He said, once you have gone down this road, you have to complete it, because obviously there will be a repetitive reaction and there will be granulations. So if you have gone down and drilled it in this way without mucosal preservation, because this is not a mucosal preservation technique, then you have to make a really wide opening. If you were doing a mucosal preservation technique, then of course you can get away with small openings, relatively small openings.
See the frontal with 0 degree.
I am impressed. Yes. 0 degree and he's gone so far.
See the skin turning anteriorly.
Yes, a little bit of bleeding as the skin is bleeding as he's drilling through the bone.
See the frontal sinus.
Lovely. Beautiful.
with a 0 degree. Now,
Yep.
all this bone, medially, I will remove. Now, I need to go above the level of the orbit. Okay.
Yes.
Not only this, but the lamina, I will drill away. See the periorbita?
Yes. So he's thinned the bone so thin that it's becoming papery now. Beautiful.
See this bone completely gone here?
Yes.
No,
Yes.
no bone?
No bone. You can press from outside too, so that we can see that.
Yeah,
angle.
I will. Let me clean now the field. I see. I went off so fast. See this? The
Yeah.
draft finished in 10 minutes, by and large.
Lovely.
This is thanks to this drill.
Yes, the coblation, the drill, the anesthesia, all the new advances that we have had over the years.
Vandal. Wash, wash.
So important to have the right instruments. So you will notice that all the instruments that he is using are curved instruments. So that's posterior right again, maxillary sinus. As you can see, lateral wall is now not bony but soft tissue because it's removed all the bone on the lateral wall.
Yeah. See, my still the gauge piece is there.
Hmm. So as I understand, suction is in your hand
Yes.
at the moment. Suction.
My
but it's-
assistant is giving irrigation
right.
and sometimes needing a second suction.
Yes, and your assistant standing behind you or on the opposite side?
Yes, besides me.
Besides you, behind you.
Yes. See now with a 0 degree.
Yes.
And this is another gauge piece we have packed. See that?
Yep.
Now, give the brighter. Give the brighter. We'll show you some interesting finding after this. If I take the 70 degree, a little bit trimming of the turbinate, which is unnecessary.
Okay.
See now, this is the orbital wall.
Yes. Laterally on the left at about 9
That is
o'clock.
the orbital wall.
Yes.
And this is my entrance model. And you know, to retract this,
That's the anterior.
I will coagulate this entrance model there
Yes, I think that
without any issue. Karna section kar.
that's a no. So that's a monopolar.
See, I remove the bone from the entrance model artery.
There. Anterior
Hello?
model. Yes.
Coagulator. See, I remove the bone from over the model artery. This
Yes.
one. Very
Yes.
clear.
Beautiful. And you can see it going into the orbital periosteum and the orbital pad, the anterior ethmoidal artery.
This is a small, tiny vessel.
It is. I agree.
See this?
Yes, there might be something behind
And
it.
I have cut it. See this? I have cut it.
There might be another artery behind this, where your other instrument is. Your
No, not artery.
here, this area.
That's a nerve.
Okay.
See now, this area is
So now he's
separated.
in the orbit medial to the lamina papyracea. You have that.
Yeah. So I need to go to retract that and remove that now. If I cut the anterior thyroidal artery, see that? So I have more leverage now to play with the periorbita. Otherwise, it will stretch on the periorbita and sometime would retract. Okay?
Lovely.
See, this is lamina. Now I am coming with a 70 degree. Was back for a while. Back for a while. Just back for a while to improve the field, and then we'll come with a 70 degree for the last part. लिस्ट लेके बोलो बड़ा देना थोड़ा बड़ा देना पैक के काउट सेक्शन सब चीज काउट ले लो वो राइनोस्पोइडस वॉश करना कोबलेटर
So Satish, you were just asking if your colleagues in pathology have had a chance to look at.
Pardon, sir?
I said if your colleagues in pathology have had a chance to look at what this tissue that you sent out initially.
Yeah. I'm waiting for the report. पता कराओ ना यार.
So he's coming anteriorly again.
Yeah, I'm just improving the field a little bit more.
Using the coblation to control the oozing.
Okay, by and large, okay. Point down. See, now the field is much better.
Maxillary sinus is sucking, just to orient you again. Septum where he is coblating now.
Yes. This irrigation is an important tool to wash out the stainings. See this?
Lovely. Field is so much better.
70. So now I'm taking 70. Periosteum, अच्छा वाला. क्या है ये?
Still a little bit of debris, I think, in the frontal posteriorly.
See, now is the picture with the 70 degree.
Yes, we can see. And with
Cloud
70.
section. And see what is there. See with 70. This is lamina papyracea.
Yep, lovely.
This is above in the roof. See this. All this disease.
Still a fair bit there. Yes.
Now I am above the orbit. See this.
Now you basically, it doesn't seem attached to periosteum or anything. It's just coming off.
Yeah, with the section. See this.
Lovely. Beautiful.
See this massive region.
So we have been lucky today because it's not attached anywhere.
Yeah, it is underneath.
Yes. Because you can actually see the mucosa underneath it, which is quite reserved. Mucosa of the frontal sinus is well preserved.
Our section, I have always emphasized on the good, powerful section when you use the shavers and these tools.
I would test for fungus too, even though it doesn't seem there's so much debris, even though radiologically it wasn't typical. But the kind of
See
debris.
see the frontal sinus.
Yes, lovely.
Absolutely clear. This is the mass.
Now you have mass. I agree. Yes.
See all these debris coming off the orbital periosteum.
Hmm.
See this?
Yes, we see, of course. Lovely.
I would like to make a small announcement.
Mhm.
All the postgraduates are requested to move towards their posters as we're about to begin with the poster presentation soon. I repeat, all the postgraduates are requested to move towards your posters as we're about to begin with the poster presentation. Thank you.
See this lesion now?
We see the mass now. It's obviously different from the debris that we were seeing then. So there was some inspissated debris behind the mass, but now that the debris has come out, you see again the fleshy mass. It would be interesting to see what the pathology is. Let's see. It's obviously PNS pathology is not easy to do even for the pathologist because there's such a variety of pathologies here. It's not just squamous cell cancer or no.
See this? The area of attachment. Can you see this?
I see that that the mucosa seems to be involved or infiltrated on the lateral surface.
See the area of attachment there.
Hmm. And the underlying.
Can you
bone-
see?
Yes, we see that.
That's the posterior table.
Perhaps it's the area where on the MR we sort of found a
वो debrider है.
thinning.
Now I am removing with the debrider little bit of the bulk which is left. This is attached to the posterior table. See this?
Yes, yes, we see that. So certainly a little bit of the bone of the posterior table doesn't seem fully healthy.
See this mass which is
Yes, going into your microdebrider.
jumping into the blade.
Ah,
Grossly came out.
very challenging operation, but very well done. Beautifully done.
इसको दबाओ. Now see.
So what about that bleeder? You're going to drill or just wait?
Yes, definitely. Let me first. Let me first show you.
Again, looking.
See, that is the mass which is attached to here.
Yes.
That is what we expected. And see, wherever the mass is, you will find the vessel. See this?
Yes. So a little bit unhealthy.
See this dura. See this dura there?
Is it dura? Okay.
Posterior table dura, this one?
Yes, yes. So this is the point where we probably thought that the bone was a little bit eroded. That is that point then.
Yes. Now, let me improve the field again. To orient you, I have seen, wash section. Wash section.
You must realize that he's using a 70-degree scope, so it can be very disorienting to use a 70-degree scope, but he's doing it so well.
That's why I will reorient you again. I have seen the area of interest.
So this is anterior now. I'm showing it to you. The 12 o'clock is anterior.
And see, if I go up, I will show you the orbital roof. Let me remove this gauge piece first again, the remaining one, to reorient you. See this?
Yes.
Wash.
So now you're sucking on the roof of the orbit, so to say, where the
Yes. So now first I will see the roof of the orbit, where it was to me so far looking like not attached to. It was prolapsing there.
it picked up. Yes, it sort of was picked out very easily.
It
You
is
put your
attached to the
thumb in and-
posterior table we have seen,
Yes.
and we'll do something radical to it. The brother.
So this is in the frontal sinus, fairly posterior. He's using a 70-degree scope.
Suction. And now I will go 70-degree up above the orbit and then turn it down to show you the roof of the orbit.
And even laterally, we need to see what's happening laterally. Yes.
Yes.
It was quite a well nematized, going very lateral.
See this.
Yes. What is very nice to see is that the mucosa of the frontal sinus is very well preserved.
Now see, that is the roof of the orbit. See from above.
Yes. And we can see that the
gone-
floor is nicely cleared. Very nice.
See, I have gone above the orbit and turned my telescope upside down. Can you see this?
To explain to everyone, he's put his 70-degree scope, then rotated it around so that he can look into
This
every.
is the roof of the orbit.
Yes.
This
And we
is the
can see the attachment
periorbita where
site.
the bone was dehiscent. No tumor. See, this is the periorbita intact.
Yes, we appreciate that.
And see, I have turned my scope upside down to show you the roof.
We see that and appreciate that.
See, there is nothing in the orbital roof now. Agreed?
Beautifully done. And
Now
that is
the
the
area of
bleeding
interest
area.
is this. Now area of interest is this.
Hmm.
Where the tumor was attached to, and we'll do something to it now. Okay?
Lovely.
Pop later first. See, one area, we had little bit of the, region of the periosteum which came in section. So I will coagulate this.
So this is the orbital area that is coplating currently, which is at 9 o'clock. Almost
See,
at the
separating from rest of the tumor, because this is intact. See, it has nothing to do with tumor.
No, we appreciate that. This is normal mucosa. It's just the point of attachment where it is bleeding, where you have a little bit of a.
That is coming from above.
The floor is perfect. So you're holding the scope?
Yeah, it is me only, because I am turning it again and again everywhere. So that control I have to have.
So my compliments to your assistant, doing wonderfully well in getting that suction in to follow wherever you go.
Yeah, he is the dear one who has been with me for last 20 years.
Lovely.
Assisted me in thousands and thousands of surgeries. That's why I always mention whenever we talk about the skull base to make a team. See this orbital periosteum.
See that.
See this? Away. See this? Away.
I think you have very convincingly shown us that you have excised disease very well.
I will drill this bone.
It is nice to
Later-
see that there is so much preserved mucosa.
Whatever bone I have exposed this after elevating this. See this? The
We see that.
bone I will drill to stay on the safer side. See this bone?
Yes.
So
That's
now
probably
orbit is away from our field now. See this?
So that seems to be the floor of the orbit that you so little bit.
Yeah. See now the floor? See the periorbita below?
Yes, and we can see
See
you.
the rest of the orbit is away.
We can see
Orbit
that.
is now absolutely away from my field.
Yes. So that is the floor of the frontal bone. A little bit that is still left. The floor of the frontal sinus on the
Yes.
medial side that is still left.
And
Then
we'll
of
do
course,
something
the
to it.
rest of the frontal sinus. You can see much of it is mucosalized, which is very, very good news. But you can also see that much of it is bereft of mucosa, which is a bit dangerous because it will obviously scar and maybe.
Now, my goal is to drill away, coagulate away the final attachments. You know,
Yes.
this is tumor coming out of the bone here. See, this is.
Hmm. And you can feel that the bone is dehiscent there. Hmm?
Yes.
Hmm. Yes, all this looks so normal now. It's only that area in the dura where we seem to have some
Yeah,
concern.
see, I am removing. It has been in the recent studies proven that when you drill away, remove the papilloma from the bone or anywhere, take 5 mm margin of the mucosa because sometimes you have a
Okay.
mucosal contamination. See this?
Yes. So we see that you have taken your margin.
Yes, that is important.
You can see that bleeder in the bone.
Now see the entire area. The area of interest is in our view.
Lovely.
That's the dura.
Hmm.
See this dura.
Hmm.
Dura is there because the bone is dehiscent.
So coagulating on the surface of the dura very lightly.
Yeah,
He's
yeah,
staying
dura.
a bit away, as you say. He's not really hugging the dura. He's staying a little bit away and trying to get away with minimal coagulation. Just
And
to
see
watch.
this bone from here to here. That is the site of attachment. See this bone?
We are convinced.
Hyperosteotic bone.
Yes.
The drill. And now is the time. See where we have to reach out. See this area. And this
Yeah.
could have been possible only because of this draft.
Agreed. So we just lost the picture. We are back. We got the picture.
See this. This is the culprit bone. See what I'm doing.
Yes, we can see the bleeder in the bone, and we can see
The bleeder in the bone is the bone where the
the
tumor is.
diamond controlling that bleeder, attempting to control that bleeder.
Keep an eye, close eye. I will completely eliminate this bone.
Very nicely. Beautifully done. So he's removing this bone to expose the dura because his concern is that this is the site of attachment, and if he leaves it here, then of course the chances of recurrence may come back.
They're bound to come back.
But it is the beauty of his skill and the beauty of the safe instruments that we have that he's able to do this so effectively.
$60. Later. See the bone I have drilled.
Bone you have drilled, just a little bit of bleeding from the dura.
Yeah, that's from
Only
the
one
dura.
bleeder.
See the underlying dura. That is from underlying dura.
And it's amazing to see that your suction follows you. Lovely.
See, this is all dura.
And you have managed to control the blade quite effectively. One side still there.
Drill. Either. See now this remaining bone.
Yes.
Retractor.
That's actually the roof of the orbit, the little that is left of it.
Yeah, that bone was not looking good.
Hmm.
See the flush bone now?
Yes, we see that.
Retractor. Oh. Section. Or retractor. See this bad bone.
Lovely.
Section. What point also? See this entire bone.
Yes, so as it drills it away with this coarse diamond burr, you find that it stops to bleed because that's the.
See this bone now?
It all looks very healthy.
All looks healthy, but
Fine,
still I am
fine.
not.
Even the bleeder
Yeah.
on the dura is almost controlled. I mean, still a small loose, but nothing very major.
That is not an issue.
And yeah,
The
that's
issue
not
is this bone. I have little bit doubt on this bone.
this one.
Yeah, little bit.
Hmm.
See this bone. See this.
Okay.
Looks good, but I don't want to leave it. See, everything being done with a diamond burr. I am
Very nice.
far lateral and above the orbit to do all this.
Yeah, this is more on the
Using
posterior
70
side.
degree,
Hmm.
all angle instruments, under vision. See this bone?
Yes, it's very nice.
Though it looks good, but I don't want to leave it on the safer side.
You're being extra careful by drilling away all that bone on the margin. Doesn't particularly seem like it's grossly pathological, but you're being careful, and certainly we should be.
Wash. Or yes. Now give me the wash. First give me a cobbletter and then give me a wash. See this entire area.
Yes, we see that. We see it very well.
This is the area where the tumor was attached to. Cobbletter. I will show you after cleaning everything.
Do check if the pathologist and someone in your team do check as to if the pathologist has an opinion. I'm well aware that it will be difficult for the pathologist because there's so many different kinds of tumors in the PNS. But if he has got an opinion, then of course it would be nice to know. The bleeder seems to be at the inferior edge of the bony defect, so to say.
Wash. Give me wash. And see now what I'm trying to show with this wash. See now?
Yeah.
See now the underlying bone.
We see the underlying bone. We see the underlying dura too, where the bone's been.
Yeah, and see the bone, entire bone has been drilled away. Give me. Retractor. Let me show you once again.
We generally get the impression that we have done all that.
Like,
done.
Here this नीचे रख section. एक section नीचे रखा आपने. See the dura.
Yes, we do that.
Suction भर के suction. धार नीचे रहनी चाहिए. देख एक तो नीचे रख, दूसरा ऊपर रख. Now retract this and see this. See this, no tumor at all. Can you see? I was little extra cautious.
No harm, but it's nice.
too little.
Yeah.
Let me show you once again. Oh,
So once you're done, we'll see it again with the 0 degree to see what the anatomy is like and revise it.
yeah, I will show you that later. Let me first see this retract. Yeah, now see the area of attachment.
Yes, I mean, you have removed most of the area of attachment. What we
See
see
this
is dura
thoroughly.
there. Hmm.
See this?
Yes,
See the skull base, how the thick bone was there and been completely removed. See the posterior table.
we see the
Well,
posterior.
Yeah. See this entire region where the tumor was attached to.
Beautifully done. Was
See now
attached
the
to
underlying
it.
bone, this bone which was thick, left bone I have completely drilled out. See this?
Yes. There seems to
Touch
be
kar
one
de.
feature on
Touch
the
kar de.
bone still posteriorly of the mucosa. Yeah, where you have your coblator.
Touch kar de, some mucosa loose. क्या करना है यार? Okay. So that's the final picture from above. See that?
Very nice.
No tumor. Look at the frontal sinus. See the tumor attachment there. This was the area of interest.
Very nice, Dr. Jain. Very nice, Satish. It looks lovely. You seem to have done a wonderful, wonderful job there. I mean, everybody is greatly appreciative of how
0
this
degree.
is done.
Wash.
Beautiful operation done.
Thanks,
Great
sir. And your,
demonstration. Good
your
for the
presence
patient.
has made it much better and more interesting. Your every single word was,
No, I have enjoyed this. It's been a long, long time since I've actually sort of run through a surgery like this. But I've
your,
enjoyed this.
your tips and your points were really, useful. Every single suggestion was important because it was
So
coming.
now
out
the
with 0
70
degree.
degree, and you can see the maxillary sinus ostium down there. You can see the ethmoidal roof there.
See
You
with
can
0
the
degree
frontal
everything.
sinus.
See the tumor attachment area with 0 degree.
Perfect.
And some, mucosa.
Maxillary sinus ostium, posterior ethmoids, skull base. Coming forward, this is where the anterior ethmoidal was. Just anterior to it, you see the frontal sinus taking off. Posterior tabular frontal sinus.
Since I told you that we may have to retract the orbit in those situations, we may have to, cut off the anterior ethmoidal artery.
So you have
See,
done that. Yes.
If we are retracting the orbit like this, much more. See how much we have retracted. See the posterior wall.
We see that. Lovely.
See the superior wall, posterior wall, everywhere. So this tends the anterior ethmoidal artery. So it is better to cut it in a planned way than allow it to transit.
Allowed, yes, that has allowed you to retract the orbit medially.
See, this has allowed us to retract. See, I am in the orbital roof. See there?
Yes.
Above
Yes.
is the frontal sinus. This entire area has been marsupialized.
So actually the frontal sinus floor is there where I'm trying to, I have a pointer here where I showed them the frontal sinus roof, the frontal sinus floor. And yes, you could push the periosteum much below that.
So that's the final picture.
Yes, we are done. I mean, absolutely wonderful operation. Accomplished in very quick time. Lovely. Excellent.
Thank you. Please
Any
close-
thoughts,
close it.
questions for Dr. Any questions for Dr. Satish Jain? Any comments? You have a mesmerized audience.
So any questions? My associate will, close it.
Okay, lovely, Satish. Thank you so much. We loved
Thanks to
it.
you, sir, for your presence has really made it more, informative, interesting, and your every word was encouraging.
It's a great day for you. We have loved it. I don't think there's much more from Dr. Jain there, or is there? Okay.
So any questions or anything before we move on?
No, Satish, no questions. It's all sort of gone to plan. Everything was pretty obvious. Yes, everything.
So the next last case, because 3 o'clock is there. 4 o'clock till 4 we have a session. I have a flight 6 o'clock. So will be the last case now coming up.
And where are you off to, Satish?
Thank you, Dr. Satish. You indeed have us mesmerized with your surgical skills. To present a certificate to the chairs, I invite Dr. Jadavedan, Senior ENT Surgeon, Thrissur,
Karo.
to present a certificate of appreciation to our chairs.
So, Dr. Satish, I'll be taking off now, saying thank you. We love that operation, and we'll have another pair of people take you through the next operation.
Thank you, sir. Thank you so
Right.
much.
Pleasure. Lovely. Yes.
इसका MRI था? हाँ? 2 पेशेंट है, बाद में देखूंगा। बुझो उसको डेट वो। इसकी वो तो करवा दे।
I would now like to invite the chairs for the next surgery. Dr. Anand, Director and Head of ENT at MCV Memorial ENT Trust Hospitals, Tamil Nadu, and Dr. Idikula Matthew, Senior ENT Consultant, Lakeshore Hospital, Ernakulam. Respected chairs, please take your seats on the dais. I would like to make an announcement. The meeting of the government body is postponed to 8 a.m. tomorrow in Hall A. The meeting for the governing body is postponed to tomorrow morning 8 a.m. in Hall A. The Kerala Skull-Based Osteomyelitis Group meeting will be held at 9:45 a.m. tomorrow at Hall B. The Kerala Skull-Based Osteomyelitis Group meeting will be held tomorrow in Hall B at 9:45 a.m. A gentle reminder to all the postgraduates, the poster presentation is about to begin soon. I request all the postgraduates to be near your posters.
Good evening, Dr. Satish. We are ready here. Once you are ready, you can start the program. I think you have a case of rhinosporidiosis now.
A gentle reminder to the delegates, please do not lose your QR coded tags as they're needed at food counters, welcome dinner, and also at the banquet counters. Evaluation forms are to be filled and submitted to the registration counters. Certificates are issued against submission of these forms only, and this is a requirement of NMC. Dear delegates, please do not lose your QR coded tags as they are needed for food counters, welcome dinner, and also the banquet counters. Evaluation forms are to be filled and submitted to the registration counters. Certificates are issued against submission of these forms only. This is a requirement of the NMC. Thank you.
Dr. Satish, we are ready
Hello.
here.
500 plus.
Hello.
Hello, sir.
Hello, sir. Hello.
Hello, this is the auditorium. Can you hear us?
Yes, please.
Yes, sir. This is Dr. Anand. I'm so happy to see you work now for the next case. I think it's a case of rhinosporidium. So I think if you can give us a preliminary on that case, we'll hear it and then we'll go for the surgery. Thanks.
So this patient is a male patient who has been operated 7 times somewhere. And now he has come with bilateral, rhinosporidosis. Both nose are full and little bit of it is hanging down in the nasopharynx. Rhinosporidosis, as we all know, is a notorious disease. Isko idhar le lo. Notorious for its recurrences. This sporangia, the spores may germinate anywhere they come in contact and then can lead to again a same story. So the surgery also is very challenging in the sense when the sporangias are released, if any of them are germinating, can invade the mucosa or the bare surfaces wherever you have created. So it's always a challenge to deal with this situation. And secondly, in surgery, the ongoing bleeding is the biggest challenge. Because of the ongoing bleeding, sometimes you do not know where this tissue is attached to. Because it is the attachment that needs to be identified and completely coagulated at the base. That is what you can do in surgery. Secondly, it is not one attachment, it may have multiple attachments anywhere in the, nasal cavity. It may go behind to the oropharynx, nasopharynx, and it can be systemic as well. So this is something which is adding on to the challenges. The microbe which is responsible is again a big mystery. Earlier it was considered to be a bacteria, then fungi, then parasite. Then now in recent studies it has been more in favor of a protozoa, aquatic protozoa, or so many other stories, shown. So it is still a mystery. A lot of things are not known. Medical treatment is still not developed to this. Only some adjuvant therapies which work, we all know. And one of them, the dapsone, is the someone, which is more, reliable to certain extent. Now I will show you a palate retractor. Bola, tonsil retractor. Tonsil retractor, palate retractor. Hello? Hello?
Yes, sir.
Okay.
So
we can hear you.
So I have directly come to the surgical part, looking at the time constraints. So first of all, I will show you how we can deal best surgically this entity. Number 2, how to prevent the dissemination. And number 2, how to begin. Because the moment the bleeding starts, then nothing is visible. So our tool of choice to deal with this situation is the coagulator. Coagulator maintaining the bloodless field.
Yeah, you are in love with the coagulator.
Yeah, this is very important in this surgery to maintain a bloodless field, to maintain the visualization so that we can go into the attachment. Secondly, to prevent dissemination, we have to have a pack in the nasopharynx. Number 2, we have to fill the entire cavity at the end of the surgery because some of the spores which might have released may have are in the germinating phase may invade the other areas, and povidone iodine has been proven to be effective against those germinating spores. So we fill the entire cavity at the end of the surgery, say 15 minutes or so, with the povidone iodine. So this is what the measures we do, and in recurrent cases, we don't know the efficacy, but we almost always refer this patient to either our immunologist or the dermatologist for the depth on therapy.
Okay. What is the dose of Dapsone and how long do we give it? Okay.
We don't give Dapsone for that matter. We don't give Dapsone. Dapsone had a lot of adverse effects as well.
Okay.
So we refer to our colleagues and keep in touch with them.
Okay.
See, first of all, this is the mass which is coming in the nasopharynx. Can you see?
No, we don't have the picture. We don't have the picture.
Please.
Yeah, we have it now. Yes.
इसको retract कर, यहाँ से retract कर, यहाँ से करना, देख के करना, sir. Yeah, see this mass in the nasopharynx?
Yes, sir. We can see that.
Photo gauze, please. This is notorious to disseminate anywhere. We have seen rhinosporosis disseminated in the oropharynx, nasopharynx, even the tongue, laryngopharynx, even the outside skin, everywhere. So to prevent this, see, this is the lesion which is hanging down. Can you see?
Yes, sir. We can see that.
This is something I want to put down. Cobbleter. और मंगा और मंगा. See this?
Yeah.
So I want to remove it under vision. पानी नहीं है, suction नहीं है. Suction. सुन, एक नई प्लेट मंगवा. Just a minute. वो प्लेट कौन ला रहा है? इसको बोल दिया तूने यार. लेके जा दे. जल्दी पास. Hello.
Yes, we can hear you. We are with you.
Now, see, this is the cobbleter. This is the part which is overhanging.
Yes, sir.
Section. See, you have to slowly ablate, not going very fast.
Yes.
वो फोर्सेस से उठा. काट देता हूँ. इधर. See what I want, this overhanging part, I need to remove for the reason. Hey, come on. And now give me a pack. What are they? This pack I want to keep to prevent during the entire surgery, to prevent dissemination down. See this?
Yes, sir, we can see that.
Hold this. Hold this. See this?
Yes, sir.
That was the goal of initial removal
Okay.
from behind. Now we have MRI and everything, but nothing predicts the site of attachment in this, because it is so vascular and so inflamed all the time. Like that. See this?
Yes, we can see that.
So vascular it is, inflamed it is. Try to go as bloodless as possible. That is the best way, I would say, and challenging as well.
You wouldn't think of embolization or
Nothing works. Nothing works.
Nothing works. Okay.
There is no single named vessel which you can embolize.
Yes, sir.
It takes attachments from many places, takes vascularity from many small vessels. See this. Debrider. See this after decongestion.
Yes, sir.
Debrider. See this?
Very clear, sir.
करो सक्शन रखिए और एक्स्ट्रा सक्शन रखवा
Satish, you want to use debrider now? You are asking for it?
See, if I use the debrider, the field will be so bloody.
Okay.
You will not be able to see what is happening there, where it is attached to, or you may end up traumatizing many mucosal surfaces.
Okay.
Coagulator is not very fast a tool, but it's a good tool in the sense the visualization is maintained almost always, all the time.
That is true. Yes.
See how slowly you can remove the tumor. And all the upper. I hope the picture is good.
Yeah, it's very clear here.
I am going slow, but things are under control. I know where the attachment is going to be. It's a very, very frustrating disease. Block हो गया? इसका God bless you. Hmm? See, we have reduced.
Yes, it has reduced.
And see, no attachment in the nasal cavity anywhere.
Yeah, it is free.
And we are not giving any further raw areas. Minimal. क्या हुआ? यार नरेश. पानी, 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 section पानी. देख देख.
Hmm. You are getting near the attachment, Satish.
Not seen yet. Not seen yet. See, at two places I have given little raw areas on the turbinate, but that is looking healthy. Slowly, slowly, never be in hurry. Let it go like this onto the attachment.
Okay.
So this is allowing us to visualize this cobblator.
Yes.
With debrider, it would be full of blood. आगे रख सकते हैं. See, quite a bit of the tumor we have removed. बोल देना अनुपम को.
Satish, your posterior pack is still there, no?
Hello.
You have put a pack in the nasopharynx behind this mass, isn't it?
Just a minute.
Okay.
कहाँ रहते हैं यार? इधर है. पागल आदमी. आनंद एक जने को छोड़ के जाने हैं. Hello. Yes, you are asking something.
I think we have a pack behind this mass, isn't it? You already put a pack.
Behind to prevent
Yes.
anything going behind.
Yes.
Section लगाना है यार. No, this is not. वो खोलने का वो लेके आओ. Slowly, slowly. Keep reducing the volume. पकड़ लो. Keep reducing the volume.
Yes, sir. Correct, correct. Satish, who's handling the second section for you?
My assistant.
He's doing a good job.
Yeah.
As the bleeding gets a little brisk, I think the coagulator loses the original efficiency. It's a little slower.
See, even the coagulator is not able to give 100% bloodless. But still, we are able to maintain the visualization.
Yes, yes, yes.
Now, pack for a while.
One more thing, if you have a posterior pack, we can't use a debrider because in the presence
so we
of
have
a
already left a posterior pack.
Yeah,
Now, this is another pack. We'll leave for a while. Go to the opposite side.
that's a good plan.
See this? Massive. यार अनुपम को इधर बिठा देना यार. वो काट देना बीच की. Just wait a minute, then we'll move on to the opposite side. Posteriorly, our pack is there. See that?
Yes, sir. Yes. Oh, it will work. Satish, just a question.
Yes, please.
If you are using irrigation during these steps, the coagulator, will it work equally efficiently or it will lose its efficiency?
No, it works well. No issues. Provided the suction of the coagulator is good.
Oh, yes. No, the suction on the coagulator in the soft masses frequently gets blocked. Your assistant suction is more important, I think.
So the coagulator suction should be the stronger one.
Okay. Okay.
Now coming to the opposite side.
Okay.
सिर पकड़ना. It's all coming to the anterior nares. There is hardly any scope. Hardly any space for our instrumentation even.
Yes. Satish, you have thought of harmonic for this purpose? Harmonic scalpel?
Harmonic, the introduction and the irrigation and so many issues.
Okay.
Coagulator in itself is a complete with everything. Suction, irrigation, ablation, coagulation.
Okay. Harmonic has a better hemostasis. But in your hands, coagulator is giving a wonderful performance.
This surgery is a slow surgery with a coagulator.
Okay. And another very important thing, there is no collateral damage to mucosa of the turbinate or the septum.
Yes, keep
So
minimal.
careful.
Yeah.
I think if somebody else is doing, there'll be a lot of injuries on the lateral wall and septum. In your case, you're just hitting the mass.
But still it is suction needed.
Satish, is it possible to show the external view to show how the assistants are handling?
Yeah, we'll show you.
Okay.
किधर है? ये क्या है? अच्छा. See the purulent collection within it.
Yes.
Within the lesion. So vascular it is, so hard. The lesion is 7 times operated, you know.
Yes, sir.
See, I am within the lesion.
It's almost getting loose.
Somehow trying to debulk this. He is such a bad situation. पकड़ के उठा. There was hardly any space in the nasal cavity.
Yes. So basically what you have done is debulked so that you can see the posterior part.
Because of the repeated surgery, it become very hard. The only way we have to prevent dissemination is the povidone iodine
Yes, sir. I agree with you.
and cauterize the base.
Your idea of keeping povidone iodine for 15 minutes is very good.
What about post-operatively? Can we do douche with povidone iodine and things like that?
Povidone iodine, yes.
Yeah.
Section पकड़ा है, कौन है? Section. See this, in spite of, see the situation. नहीं कर रहा है काम.
Certainly not a easy case for Satish. It looked very.
The situation is bad. He's such a massive one. See, wherever is raw area, you have to coagulate hard. Wherever is the contact we have given, no?
Yes.
Hello?
Yes, sir. You have to cauterize the raw
Yeah, we
areas.
have to coagulate hard. Though it will give more raw areas, but you are not left with any choice. Looks like attached to the septum.
Septum and floor also.
And here septum was definite one, which I have taken. See the septum?
Yes.
Yes, yes.
Please irrigate. They are irrigating. Beyond that block only.
Now this luminal part, we have removed one attachment from the septum. Bleeding is ongoing, so let's take a chance with the washer. Defibrillator also. See? Quick. See the septum and the floor.
Yes, sir, we can see
Hello?
that. Yeah, we can see
Yes.
that.
Hello?
Yeah.
Sir, we can hear you. We can see the
Hello?
picture. Hello?
Can you hear me?
Yes, we can hear you and we can see the picture clearly.
Hello?
Hello?
What is coagulator? Hello?
Sir, we can hear you.
Oh. What I can see, that is the site of attachment.
Okay.
Hello?
Yes, sir. Sir, we can see you, we can hear you. Yes, we can hear you.
Yeah. So what I am trying to show, it was attached to the septum and the floor in the middle.
Yes.
I remove that part with the micro defibrillator quick.
Yes.
See this septum and the floor, which I have coagulated.
Yes.
Coagulator. नहीं इसका सेक्शन काम करो, रुको रुको। You don't know, with so much of oozing. The problem is the bleeding. See this?
Yes.
Actually, okay, it's so difficult to guess where it is coming from.
The white base.
Forceps को पकड़ यार, forceps. अनुपम को बुला लेना. Good writer. जल्दी दे यार. Hello.
Yes, we can hear you, sir.
See, it's such. यार यहाँ बैठ जाना यार. तेरी problem क्या है? See this mass.
Yeah.
Still, funny. In spite of all means, difficult to know where it is coming from.
Yeah.
So this is another effort to, go to the site of attachment.
I can do it quickly with the debrider.
Yeah, so see, it has taken the luminal part
Yes, sir.
Yes.
and see some attachment onto the turbinate. See this?
Yes, we can.
So that was the attachment on the inferior turbinate. Okay. Looks like it has come, but looks like that was the attachment on the inferior turbinate.
Yes, sir.
Let us see. बस. Section. Another section. Now I will go to opposite side.
Yeah. Okay.
Find all.
Yeah, that's,
So the nasopharyngeal part was pulled from opposite side. See that?
yes, sir.
Nice. Very nice.
It looks good, and this is the pack behind.
Okay.
Can you see?
Yeah, we can see that.
There's nothing on this side. See?
Okay. Okay.
That is the pack coming from.
Other side.
Wonderful.
Give me the cobbleator.
Satish, we want to have an outside camera view after this, how they were able to get the instruments inside and so
नहीं
forth.
काम करे. जब भी मैं कह रहा हूँ यार. So, yes, sir. Looks like we are through. The only attachment was we have got is the posterior end of the turbinate. We'll see to it. Like that. Section. Patla. Look, give me. Right side is pretty clear.
Yes, right side is not bad.
Yeah, but what I'll do, this area, on the basis of the doubt, I remove this.
Yes.
So it doesn't look like.
The mucosa looks thicker than the normal.
Yes,
in that
that's
area.
for the only reason.
Sphenoethmoid recess, it shouldn't be so thick.
See, rest is good.
Wonderful.
This side is terminate part, which is bleeding. Quick section, kar. Wash kar. Wash, wash. अच्छे से करते हैं बाहर बनाए. Now coming to the left side, see this.
Yes, sir.
See the site of attachment onto the terminate. It was.
Yes.
We had earlier seen the floor we have removed.
Yes. Satish, a bipolar, will it give the same efficiency as this?
Not really. Not really.
Okay.
The tool should have all the capability to deal with the bleeding.
Okay.
Suction, irrigation. See the floor where it was attached to.
Yes. To clear it up to the bone.
I have no option but to remove it.
Yes, it has to go right. Yes.
See inferior turbinate and vessel to the inferior turbinate.
From the undersurface also.
See this little venous oozing. That's the only venous oozing now. So there. Patla dena yaar. We'll coagulate that. Rest of the thing, I have removed a part of the turbinate.
Yes, sir.
No option but to go radical, boss. Follow. Touch. Touch.
So when he uses a diathermy, you're using monopolar, right?
Yes.
No. Monopolar gives very good energy to the bleeding site. And if you want more energy, use a solid instrument like a ball probe or a curette. Suction conveys around 50% of the energy only.
Gallbladder. So most of the, I think the lesion has gone.
Only the terminal is giving a little trouble posterior.
That's the turbinate.
Satish, at times when these kind of oozing comes from these bones, do you mind, will you consider cutting the bones off?
Cutting the bone?
The bone that is partly destroyed and
You can do a partial resection here, but it will stop with the monopolar.
Yeah.
It will stop in no time. This is hardly anything.
Yes, yes.
Almost stopped. Gallbladder. See now, it has been stopped.
Yes.
Imagine such a frustrating disease. बंद है यार, बंद है वो.
For the audience, the black coating on the suction tip is insulated. So he is able to use the suction tip on the area of the bleeding. There is something in Amazon called shrink tube. Just see what is the shrink tube. You have that, you can insulate many of your instruments, laryngeal, even curettes or ball probes. It makes a wonderful insulation. Much better than the insulating tape because you can even autoclave after that.
What is that called as?
Shrink tube. That's how all your cell phone chargers are all insulated. The wires are pushed into this tube and they heat it and it shrinks. I use it for instrument insulation, Satish, because how much ever cautery machine we use, a hollow instrument conveys part of the energy only. You need solid instrument to, especially maxillary crest bleeding.
Got your point. See now, that is our pack behind.
That's all collected blood, no?
On the pack. See, below is the pack. See that pack?
Yes.
See the pack behind?
Yes.
What is this one? So now there is nothing, no more tumor behind. We have coagulated the floor, the part of the septum, the posterior end of the turbinate, partially removed also. See this?
Very nice.
No more lesion. I don't know. Very nice, but it's so frustrating. It makes you, but that is what you can do. And the most important part is we have ample of access. These patients require a close follow-up. See, we have ample of access in the nasal cavity now for future.
Yes.
Everywhere we have used the cautery or coagulator. The attachment was on the surface, but we have radically removed the inferior turbinate. See, radically remove the floor. See how radical I am here?
Yes, sir.
Radically remove the septal attachment.
Yes, sir.
Practically, opposite side is ultra clear.
Yes.
And now we will fill this entire cavity with the povidone iodine for minimum 15 minutes. Betadine. But syringe. Syringe. So this
Povidone iodine was proposed during COVID times also. After an exposure to a COVID positive patient, doctors can use it. I don't know how effective it was, but it was proposed because it's antiviral also.
Yeah, it is broad spectrum. It works against. See now, this entire cavity, because we have a pack behind, and we are filling this cavity on both sides with iodine solution. See this?
Yes, sir.
And post-op iodine irrigation, and it works very well. You know, the basis is there are two things: spores and sporangias. Those spores we are not germinated are never going to grow. Okay?
Yes.
Germinated spores can go onto the surface and create problems.
Satish, 15 minutes of povidone iodine is actually sporicidal. It will destroy the spores too.
Yeah. So we'll keep it for 15 minutes and it will take care of the germinating sporangias, and then post-op also irrigation with the betadine, and then, you know, close monitoring with telescope. Since it is a multiple revision, so we'll give dapsone also by all these measures. Even if there is a smallest of the recurrence, by early follow-up, close follow-up, you can pick up and remove easily. Because now we have good access in the nasal cavity. So follow-up is very important. If you get early, you can remove it radically. So that is the only way you can prevent recurrences. And by all these means, these patients do well. It's not that you operate and forget about it. This is not that kind of a surgery. और भर दे और भर दे अब तो सामान रख चल
Satish, it was a wonderful demonstration. Very nice. We are from an area of South India where I think rhinosporidium was once upon a time rampant. With the number of people taking bath in columns have reduced. I think rhinosporidium also has reduced. I think the only residual pocket is areas around Kanyakumari in Tamil Nadu and a few pockets in Kerala now. I still remember in the 90s when we used to do large rhinosporidium without any of these tools, only with bipolar and unipolar. Tulsidas and myself used to conduct these workshops. We used to do one side with the amount of blood that the patient bled. You can't proceed. Pack it and go for the next side the next day. Now you saw how he did. It was a wonderful demonstration, Satish. Thank you. Any questions from the audience? Dr. Satish will be glad to answer. Nobody wants to do any study on the rhinosporidium. If you want to get Padma Bhushan, you can work out the life cycle. You'll definitely get a Padma Bhushan. Sieber, the old man, did it some hundreds of years ago. You can continue that.
Sir, one question.
Please.
Sir, please comment on use of dapsone, because Dr. Satish was telling this is the 5th or 6th time we are using. There is no scientific or consensus regarding the use of dapsone, its dosage, for how long we have to use. Second thing is, sir, this use of povidone iodine, what percentage or how long you have to give? Is it nasal douching or drops? Please comment on that. Thank you.
Yeah. So post-operatively, we continue douching with povidone iodine. Very close follow-up every 15 days until it completely heals, and for next 1 year at least, so that even the smallest of the recurrence you can identify endonasal and you can take care of that.
Satish, they want
prevent
to know
it
the
becoming-
concentration. They want to
Secondly,
know.
regarding the dapsone, as you commented, there is no concrete therapy for this. You're right, but the only thing which works, maybe, I don't know, placebo or whatever, but the only thing which has been known to work as an adjuvant to reduce the recurrences is dapsone. But dapsone is a dangerous drug. We never give on our own. So send to your skin or immunologist and let them monitor with that. Well, it can cause G6PD deficiency or many other enzymatic reactions in the body. So be careful. But it has been shown, I don't know, like we give Dimox to reduce the pressure, whether it reduces or not, nobody knows. It's like that.
Satish, they wanted to know the concentration for post-op use of povidone iodine. How much dilution, etc.
0.5%. 0.5%.
Okay, sir. Dapsone, there is one more drug, rifamycin, that was also proposed and also given up. None of us have seen a case going away with dapsone or rifamycin.
No, that is not the answer
doesn't
to the
work.
problem. That is an adjuvant.
After surgery is what is the question?
Yeah. When you have nothing, something is better than nothing, like that. So it's an adjuvant therapy. If you have anybody has rhinosporosis, without surgery, we give dapsone, there is no use. After complete clearance, as an adjuvant therapy in the post-op, in recurrent cases, is something indicated. That's it.
I think here we are talking about the organism which is protozoal, unknown. Right
Yes.
now, no, the states of Tamil Nadu and Kerala are affected with Kerala wilt, which comes in coconut. That's also protozoal. No agriculture college is claiming any medicines, just like this protozoal. So we have lot of scope for research in this organism. Any bright minds, you can always take it up.
Sir, you're use separate nasal endoscope for these rhinospodium procedures.
You have
One
to
separate
sterilize it.
instance.
Everything what you have used, coagulator went through.
Including nasal endoscope, is it?
No, endoscope you can sterilize.
Yes, sir.
Doctor, I think endoscope, how to sterilize is your question.
You can autoclave.
Is the one which is used for these rhinospodium procedures, can it be used for other?
The one thing that you don't use is the endotracheal tube.
Yes.
It's thrown, right? Because it cannot be
always
disposable. Are all autoclavable.
Always disposable.
Okay, sir. Thank you.
Satish, what you do with the wand? This wand which you have used?
Throw, immediately throw.
The coagulator wand is removed and thrown.
Yes, yes. Coagulator, debrider, both.
Any other questions? Satish, it was just a wonderful exposition of your surgical skills and the way you used the tools which are available to everybody, but in your hands, it becomes like a magic wand, not a coagulator wand. I think I should appreciate, you can hear the applause from the audience. So not everybody with coagulator can do like this. He did really wonders. And the assistants who helped you also did a great job. I think we should congratulate them also.
Thank
Everybody
you.
should learn to handle it like that. That is the whole purpose of this exercise.
Thank
That
you.
he's so kind enough to sit the whole day and demonstrate this. That means every one of you should be able to handle that. Thank you very much.
Thank you so much for your attention, and big thanks to the organizing team for giving me this opportunity. Thank you so much.
Respected Dr. Satish Jain, we request you to come on live. Dr. Satish Jain, we request you to come on live.
We would like to take this opportunity to thank you for your extensive virtual presence. It was indeed engaging and wholesome. On behalf of Kerala AOI Thrissur Chapter, KENTCON 2022 Conference, we would like to honor you with the Kerala Memento and Certificate. On behalf of you, Kerala State President, Dr. Prabhakaran, is receiving it, and the scientific committee, represented by Dr. Ihsan and Dr. Indudharan, will deliver this memento, certificate, and plaque personally to you at Jaipur. I would like to cordially invite on stage Dr. Arun Kumar, Organizing Chairman, KENTCON 2022, and Dr. Ramesh, Organizing Secretary, KENTCON 2022, to present the certificate, the memento, and the plaque.
Sir, on behalf of you, I am receiving it.
We would also like to thank Dr. Mohammed Sharif PK, Senior ENT Specialist, Astamims Cortical, for being representative of KENTCON 2022 at Jaipur. I would also like to thank Dr. Shajid, AOI Secretary, for coordinating the live surgery.
Sharif, just come in. Okay, thank you very much, Sharif. You have been very expert to coordinate with Satish and Sir. So we'll see you tomorrow. We'll have your memento directly.
You should tell that.
Dr. Satish, this is an ornament used for caparisoned elephants, especially in temple festivals. And Thrissur is the place for temple festivals. They have 20 to 40 elephants paraded on the day of Thrissur Puram. So this is very emotional. This is very valuable thing for people of Thrissur and Kerala. And this to be, we are giving it to you to make you one of us and appreciate all that you have done for us today and throughout your career and our careers also. Thank you so much.
And one more thing is, being a giant in ENT, this ornament is given for the giant in the animal kingdom. So now we are giving it to the giant of ENT. That is Dr. Satish.
Oh my God. Thank you so much for your all love and affection. Thank you once again, the entire team, ENT Kerala, for all this you have showered on me. Thank you so much.
We would like to express our heartfelt gratitude to the esteemed chairs. I request Dr. Gopikumar, past AOI President and Senior Consultant, to present certificates to Dr. Anand and Dr. Idikula Matthew.